168 embryos for the TL12. Want to add Miri TL in your IVF lab? Contact us.
Элевит содержит необходимые компоненты для мамы и малыша на каждом этапе беременности.
Витамин А для развития легких, цинк и витамины С и Д для развития иммунной системы.
Элевит, чтобы малыш родился здоровым.
Добро пожаловать в клинику Астана Эколайф, ваш надежный проводник на пути к долгожданному материнству и отцовству.
Здесь вы найдете все для репродуктивного здоровья, современную гинекологию и урологию, программы помощи в зачатии, от ЭКО и суррогатного материнства до заморозки яйцеклеток и сперматозоидов, передовые гинекологические и урологические операции, круглосуточный стационар, амбулаторные приемы, точная диагностика, лабораторные исследования – все собрано под одной крышей, чтобы путь к вашему счастью был максимально комфортным. Мы гордимся тем, что помогли появиться на свет уже более чем 7000 детям. За каждым из них история любви и надежды. В 2023 году государство присвоило нам высшую категорию аккредитации. Это значит, что у нас безопасно и качество медицины на самом высоком уровне.
Астана Эколайф – это не просто клиника. Это место, где мечты стать родителями становятся реальностью. Место, где забота встречается с профессионализмом. А жизнь дарует шанс стать родителями.
The MIRI TL is a time-lapse incubator with individual chambers for a complete, undisturbed culture environment. It provides high-quality time-lapse images of embryos developing in real time without having to remove the embryos from the safety of the incubation chamber for manual microscopy. It comes in two variants, the MIRI TL6 with 6 separated chambers and the MIRI TL12 with 12. It has independent chambers to avoid cross-contamination. Opening one chamber does not affect the environment in any other chambers. It has a built-in gas mixer, hence it uses pure nitrogen and carbon dioxide gas. Pre-mixed gas is not required. pH measuring and data logging are standard integrated features of the system. The MIRI TL data logger continually monitors and documents gas flow, gas concentration and pressure, temperature regulation. Its easy gas and temperature validation allows external quality evaluation of gas levels and temperature in each chamber. For each chamber, you find independent gas sampling port and a dedicated PT1000 temperature sensor on the side of the equipment. The MIRI TL provides a unique environment from the continuous recirculation of gas through the UV light gas mixer and HEPA VOC filter before entering the chambers. This keeps an outstanding stable environment and extremely low gas consumption, hence running cost is kept extremely low. You also have an option to integrate SafeSense for continuous pH monitoring. The Culture Coin is a specially designed culture dish that can host up to 14 embryos, giving a total capacity of 84 embryos for the TL6 and 168 embryos for the TL12. Want to add MIRI TL in your IVF lab? Contact us.
Элевит содержит необходимые компоненты для мамы и малыша на каждом этапе беременности.
Витамин А для развития легких, цинк и витамины С и Д для развития иммунной системы.
Элевит, чтобы малыш родился здоровым.
Добро пожаловать в клинику Астана Эколайф, ваш надежный проводник на пути к долгожданному материнству и отцовству.
Здесь вы найдете все для репродуктивного здоровья, современную гинекологию и урологию, программы помощи в зачатии, от ЭКО суррогатного материнства до заморозки яйцеклеток и сперматозоидов, передовые гинекологические и урологические операции, круглосуточный стационар, амбулаторные приемы, точная диагностика, лабораторные исследования – все собрано под одной крышей, чтобы путь к вашему счастью был максимально комфортным. Мы гордимся тем, что помогли появиться на свет уже более чем 7000 детям. За каждым из них история любви и надежды. В 2023 году государство присвоило нам высшую категорию аккредитации. Это значит, что у нас безопасно и качество медицины на самом высоком уровне.
Астана Эколайф – это не просто клиника. Это место, где мечты стать родителями становятся реальностью. Место, где забота встречается с профессионализмом. А жизнь дарует шанс стать родителями.
MIRI TL is a time-lapse incubator with individual chambers for a complete, undisturbed culture environment. It provides high-quality time-lapse images of embryos developing in real time without having to remove the embryos from the safety of the incubation chamber for manual microscopy. It comes in two variants, the MIRI TL6 with 6 separated chambers and the MIRI TL12 with 12. It has independent chambers to avoid cross-contamination. Opening one chamber does not affect the environment in any other chambers. It has a built-in gas mixer, hence it uses pure nitrogen and carbon dioxide gas. Pre-mixed gas is not required. pH measuring and data logging are standard integrated features of the system. The MIRI TL data logger continually monitors and documents gas flow, gas concentration and pressure, temperature regulation. Its easy gas and temperature validation allows external quality evaluation of gas levels and temperature in each chamber. For each chamber, you find independent gas sampling port and a dedicated PT1000 temperature sensor on the side of the equipment. The MIRI TL provides a unique environment from the continuous recirculation of gas through the UV light gas mixer and HEPA VOC filter before entering the chambers. This keeps an outstanding stable environment and extremely low gas consumption, hence running cost is kept extremely low. You also have an option to integrate SafeSense for continuous pH monitoring. The Culture Coin is a specially designed culture dish that can host up to 14 embryos, giving a total capacity of 84 embryos for the TL6 and 168 embryos for the TL12. Want to add MIRI TL in your IVF lab? Contact us.
Элевит содержит необходимые компоненты для мамы и малыша на каждом этапе беременности.
Витамин А для развития легких, цинк и витамины С и Д для развития иммунной системы.
Элевит, чтобы малыш родился здоровым.
Добро пожаловать в клинику Астана Эколайф, ваш надежный проводник на пути к долгожданному материнству и отцовству.
Здесь вы найдете все для репродуктивного здоровья, современную гинекологию и урологию, программы помощи в зачатии, от такое суррогатного материнства до заморозки яйцеклеток и сперматозоидов, передовые гинекологические и урологические операции, круглосуточный стационар, амбулаторные приемы, точная диагностика, лабораторные исследования – все собрано под одной крышей, чтобы путь к вашему счастью был максимально комфортным. Мы гордимся тем, что помогли появиться на свет уже более чем 7000 детям. За каждым из них история любви и надежды. В 2023 году государство присвоило нам высшую категорию аккредитации. Это значит, что у нас безопасно и качество медицины на самом высоком уровне.
Астана Эколайф – это не просто клиника. Это место, где мечты стать родителями становятся реальностью. Место, где забота встречается с профессионализмом. А жизнь дарует шанс стать родителями.
сцену. С той стороны встаньте. Это дочь моей сопутницы. Кардинова. В следующий раз в Махабадзе Зубаевна вместе приедете. Да, конечно, я видео включите два слова. Поближе, чтобы слышали. Удовольствие мою работу, моя эмпатия. Вот эта эмпатия, она держится на счастье и на любовь. Эмпатия моя. Спасибо. С нами сегодня профессор, гинеколог, профессор-гинеколог, руководитель клиники в Тбилиси, но он еще и скульптор. Он еще большой-большой души человек, художник. Спасибо огромное, Оксана. Мы очень всегда рады вас видеть. И эмоциональный интеллект. Это для жизни. А это вешается за? Это мое просто, чтобы приоткрыть. Нет, а мы можем это за ним повесить и на фоне поставить, правильно? Потом я вам... Это вам оставите или вы везете? Нет, это увидите, все, я вам пришлю. Я вам пришлю. Спасибо.
The MIRI TL is a time-lapse incubator with individual chambers for a complete, undisturbed culture environment. It provides high-quality time-lapse images of embryos developing in real time without having to remove the embryos from the safety of the incubation chamber for manual microscopy. It comes in two variants, the MIRI TL6 with 6 separated chambers and the MIRI TL12 with 12. It has independent chambers to avoid cross-contamination. Opening one chamber does not affect the environment in any other chambers. It has a built-in gas mixer, hence it uses pure nitrogen and carbon dioxide gas. Pre-mixed gas is not required. pH measuring and data logging are standard integrated features of the system. The MIRI TL data logger continually monitors and documents gas flow, gas concentration and pressure, temperature regulation. Its easy gas and temperature validation allows external quality evaluation of gas levels and temperature in each chamber. For each chamber, you find independent gas sampling port and a dedicated PT1000 temperature sensor on the side of the equipment. The MIRI TL provides a unique environment from the continuous recirculation of gas through the UV light gas mixer and HEPA VOC filter before entering the chambers. This keeps an outstanding stable environment and extremely low gas consumption, hence running cost is kept extremely low. You also have an option to integrate SafeSense for continuous pH monitoring. The Culture Coin is a specially designed culture dish that can host up to 14 embryos, giving a total capacity of 84 embryos for the TL6 and 168 embryos for the TL12. Want to add MIRI TL in your IVF lab? Contact us.
Saturday, and we've got those with the most endurance here today. But before we start the section, I'd like to ask our Sen Gvenitadze to come here. And great surgeon from Georgia, from Tbilisi. We are tied by friendship. And Arsen, if you can just go to the microphone for a couple of words. We have this statue. Yes, thank you for this minute. This is called the Beacon of Empathy, and it is created for people who can be empathic with themselves, be who they are, and have empathy for doctors who work with patients. So empathy, as I believe, is based on happiness and love, empathy. This is a gift for you personally. Thank you, Arsen. So see what Arsene delivered, and I wanted him to deliver back this beautiful cup made by our artist Nelly Boubet. Nelly Boubet, that's one of the famous Kazakh artists. That's my mother's name, Nelly. We'll see how beautiful that is. So I'm touched. You know, you always make these surprises for us. You know, why else would I live? So then, dear colleagues, we start the session. I'm going to pass it to Maria Kisilova. Today we have this group of oncologists and reproduction specialists at the Presidium. So have a great session, everyone. Thank you very much, Professor Lokshin. Good morning, everyone. With great pleasure, I would like to start our section. And as the first speaker, I would like to invite Dr. Mustafin with his message, Oncofertility, a chance for happiness for our patients. And he is the medical director of Astana Inco Live, a reproductologist from Astana, Kazakhstan. Thank you. Good morning, everyone. Wonderful Almaty Saturday morning. Thank you very much for coming today, this day, and thanks to all the organizers of KARM for making this wonderful congress to honor the 30 years of reproductive medicine in Kazakhstan, for providing your vision about this process, for giving us this opportunity. So let's start by saying, that oncology versus reproductology, what can they have in common? Of course, they may seem very different disciplines, but you know, they operate in concepts like survivability and life birth, right? But they both have to do with one thing. We want, in this world, for there to be more beautiful, healthy people. Everybody has their different ways, but we have one goal. And thanks to the rapid development of oncology, there's more and more of patients and people of ours who now can survive in what used to be condemnation before is now just history, things that you can overcome and just keep going. And of course, if a person keeps on living, he has something, or she has something to live for, and they can overcome these issues, and they can keep on planning their happiness in future. And in spite of the rapid growth of our success in oncology, these diseases, they don't decrease. I mean, they decrease and increase, but still, these diseases are still in the high level. But what's flattering is that we have more and more patients who are found at an early stage, diagnosed at an early stage, when things can be prevented and saved. And that is why, in 1996, Teresa Woodruff described an interdisciplinary field of oncofertility. So if a person can overcome the disease, so once they become cured, they'll start thinking about the future and what they can do then. And to implement plans for fertility, that's one of the biggest tasks for modern medicine. And oncofertility is pretty much maintaining the reproductive function in patients with a disease that's already been diagnosed. Of course, oncofertility has its own indications in terms of oncology. It's going to depend on the type of the oncological disease, the age, to see if the person still can develop the reproductive potential. And we shouldn't make a favorable forecast for everyone, those who have a chance, right? Those who truly have a chance only. And the medications that are used, they should be safe for the germ cells. And there's, of course, a difference that we should have between stages so we have time to bring our mechanisms into effect for oncofertility. And from the reproduction side, it's, up to 40 years old is the best option when we can get the healthiest gametes and embryos. And having all the criteria in place for a good ovarian reserve. And of course, the woman should want it herself. We shouldn't be making a patient do something if they don't want to. And thanks to these steps, we've developed a brief mechanism, like stages of how to move through oncofertility. So once you've diagnosed, you found a disease, you should refer. There should be a referral from an oncologist. Then there's a controlled induction, ovulation, or biopsy of tissue, and then you should do oocyte retrieval and then begin the treatment of the underlying disease, the cancer treatment. And so, in a patient with cancer, when they want to go to a fertility specialist, they shouldn't be waiting in line. They should go right to the doctor, and the consultation should be skipping the queue, because every day matters. Every additional period of time spent will have an effect, and the doctor should get the patient acquainted with the different methods of treatment and what they still can prevent. So what are the possible options for stimulation? So what are advantages is we can do it regardless of the day of cycle. We shouldn't wait for the start of the cycle to start stimulation. And of course, we use modified protocols, especially with hormone-dependent tumors. We can use aromatase inhibitors and other ways of suppressing the hypophyses. We can do IVF in a natural cycle, or modified protocols with minimal stimulation. It's for young couples of patients who still haven't planned it. For women and girls, we can use cryopreservation of their ovarian or ovarian tissue. We can also use gonadotrope antagonists. And in spite of the long period already of there being oncofertility and existing, not just in our country but in the world, there's still a big problem with having the right approach. There was this big observation study that showed that in the whole world there are problems with patients who have survived oncological diseases. 73% of patients didn't even know that they had a chance to preserve their ovarian reserve and their fertility. Very many cancer survivors, talking to their husbands, their wives, of course, problems with the sexual function will have an effect on their quality of life later. And they have big financial problems because treating cancer and rehabilitation is pretty expensive, and not everywhere do they cover that with government funds or insurance. And so they will have questions about what is the priority. Is it treating the disease or maintaining their fertility? And there's a lack of awareness, and not just in our region but in the world. No matter how much it develops, the lack of awareness is still an issue. There's aesthetic problems like scars, changes in appearance, learning and communication styles. And of course, this is an issue which is pretty difficult to resolve and hard to change in our government, still in our country. Although we've actively worked with oncofertility for a while now, we still haven't redone the protocols. Still have problems with oncologists and with their oncology and reproduction medicine centers who are afraid to take on oncology because we work based on Soviet standards still. And if somebody has oncology in their anamnesis, it's grounds for aborting pregnancy pretty much at any time period, any term. And so we have the whole pathology of breast cancer. We've already done about 19 programs, and we don't do that for everyone, of course, because of the low awareness. They send patients to us, refer patients for who it's already impossible to do something, or there's no sense in doing it. When it's an unfavorable prognosis, we have to refuse them. And when they have two or three children already, it's just that the risks are not justified sometimes. So out of the programs we did, mainly it was breast cancer. We've already also had disease, the brain, blood, and kidneys. We froze 23 embryos, 32 oocytes, sperm, and the pregnancies. For those who have done the full course, we have had, everybody's had patients who have done treatment and gotten pregnant, but I'm talking about those who have done the full course, diagnosing the disease and treating stimulation, and the main treatment, the chemotherapy. She's had 6 courses of that, and then embryo transfer and pregnancy. We've already had 2 such transfers. One, unfortunately, was a stillborn, and the second one, a girl, she gave birth. She gave birth in December of last year, after the full course of treatment. During pregnancy, when working with oncologists and obstetricians, we gave birth to this beautiful girl, and this example really inspires. As when the girl was born, our oncologist said, it's a shame that this situation right here is a unique case, because it should actually be the norm for everybody. It's a natural process. And we should not just be proud of it as a unique case, but have statistics showing that we have so many patients who are able to achieve this. And of course, the emotions that have to do with oncology, they're very ubiquitous, and we have to try to balance these. And the biggest motivation, especially for women, is the hope to have a baby. So let's work together on this, and hopefully with every year we have more and more positive cases like this. Thank you for listening. Thank you very much for your interesting experience. We hope that this is not the only case in your practice, and that this will continue to develop, because in Kazakhstan, as well as in other countries of the post-Soviet space, unfortunately, the number of people with oncology is growing catastrophically each passing day. The next presentation, Kisilova Marina Viktorovna, Oncofertility Development Prospects. Happy to welcome you at our forum, our annual forum. Dr. Kisilova, also always very interesting, always a lot of experience that she brings. Doctor, over to you. Thank you very much for your introduction. I'm sorry. I know that everybody knows Dr. Kisilova, but let me just say, she's the head of the Department of Gynecological Oncology and Treatment of Breast Diseases at the Medical Research, the Federal Scientific Medical Research Center for Radiology of the Ministry of Health of the Russian Federation. Thank you. Distinguished colleagues, allow me to present to you our vision of one of the prospects of the development of this in this field. Now, we all know that that in spite of the measures taken for prevention and the treatment of cancer, and unfortunately, the cancer continues to grow. So based on GlobalCan forecast data for 36 types of cancer in 185 countries, the projection of new cases by 2040 is 28.4 million, which is a lot. And 28.4 million new cases are expected annually by 2040. And these are young people. And breast cancer is leading for mortality. It's in second place, and for new cases also, it's in the lead. Unfortunately, breast cancer is growing very fast, and with every year, in spite of the screening programs we have for prevention of breast cancer, 39% of those with the disease who acquire the disease are young people under 40. On the other hand, and this was already talked about yesterday, we have a significant drop in birth rates all over the world. Unfortunately, my slides aren't working very well. And oncofertility continues to develop more and more. There's more and more articles in PubMed for oncofertility, or fertility in cancer patients. There's the OncoFertility Open, which is a free of charge network based on membership. And the purpose of this network is to exchange resources, methods, and experience for collective development. The leaders in this development are Japan, Belgium, China, the US, and the Russian Federation, of course. Now, birth rates, unfortunately, are decreasing in the whole world, and even in the African states and North America. And due to that, I wanted to just reiterate that what's still relevant is treating young patients of reproductive age with cancer. I always show this slide because radiation therapy and chemotherapy, which are some of the main methods of treating oncological diseases, they have different concepts. With radiation therapy, you have necrosis of the primordial follicles. With chemotherapy, you have uncontrolled apoptosis. And we all understand very well that if you radiate reproductive organs, then there's no question of recovering their function, because the dose of just 4G will destroy 50% of the existing follicles.
Today, there are a lot of methods of preserving fertility for young patients, for women, but all these methods came to us from the ART, except for the ovarian transposition and getting ovarian tissue for these patients as a genetic material. Why we are talking about ovarian tissue? During the endometrium cancer, according to our center, for 3 years, we had 12% of the total number of treated patients. These were young women under 40. And for the patients that came to us with the cervical cancer, the number of young patients was 70%. Metastatic failures with the ovarian cancer is only 2.7%. For the adenocarcinoma is 3 to 9%. So always there is a question how to preserve genetic material for this group of patients, not talking about cellular technologies. Cryoconservation of ovarian tissue is a technology which has stormed into this area since 2020, when ASRM has considered cryoconservation of ovarian tissue not experimental procedure and allowed it to be used in practical health care. The cryoconservation of ovarian tissue is quite developed and poses no difficulties for any oncological disease. Mostly the differences in this technology in different clinics is just how to preserve ovarian tissue. Some clinics are using slow freezing, others are using vitrification method. The leaders are, of course, Belgium, Professor Dane, Norika Kagawa in Japan, Sheba Center with Dror Meir in Israel. Now I'd like to dwell on some details. Ovarian transposition is a routine method which is used more than 50 years in oncological hospitals of Russia and throughout the world. And it seems like there is nothing new to invent. But today we have to state that despite of having ovaries outside of the irradiation, the remaining radiation still gets to the ovarian, and ovarian transposition preserves 91% of patients in its functional state. Having remote radiation, this percentage decreases to 60%. There are various prognostic models of the therapeutic dose impact on the human ovarian, and depending on the dose which is used for the pelvis irradiation, we can determine high, moderate, and low risk for the ovarian damage. There are a lot of publications on the ovarian preservation after transposition. We have our own experience, and I'd like to say that despite of all these activities that we have developed and that we are using, unfortunately there are a lot of issues. We have some challenges that although we are taking ovaries from the irradiation area, after 3 to 6 years of this procedure, ovarian reserve is declining. Perhaps it's because we are disturbing the blood supply of ovaries, and that leads to the depletion of the remaining radiation which gets into this area. We had several methods of assessing devitrified ovarian tissue. We've proven that it's viable and could be used for subsequent transplantation. Our patients came to us to transplant it, but we used the surrogate motherhood. So ovaries functions after transposition, unfortunately, is not always justified. So to preserve this genetic material, this procedure should be done before we invite a patient for the ovary transposition. We've been discussing about this so that we receive the pregnancy for the oncological patient after thawing the vitrified tissue before the start of treatment, but we haven't received our own results in a large number. There is a Ishiba Center for Dror Meir who has started to do autotransplantation of ovarian tissue since 2020, but probably it's more about preserving hormonal phone and not about childbirth. At the same time, we insist that in large ovarian centers there should be biobanks, biobanking is one of the 10 ideas that can change the world right now. You know that there are a lot of biobanks to preserve reproductive material in many countries of the world, and there are also preserving military and other law enforcement professionals. So there are some 1,500 samples of ovarian tissues, but we received only 15 pregnancies from this amount. Well, not all patients come back to us after remission, and that is the problem throughout the world. According to Teresa Lupta, only up to 7% of patients come back. There is also a metastatic damage of ovarian tissue for the breast cancer patients. We know that up to 15% for various surrogate breast cancers, and these are double damage of ovarian tissue. There are a lot of laboratories now that are studying the opportunities of mitigating the ovarian tissue damage. These are Spanish researchers that has developed their immunohistochemical panel, and the Dutch studies of 2016 with Yekaterinine to identify metastasis. We have our own panel testing for the ovarian tissue of the breast cancer patient, taking the most difficult cancers such as HER2 dependent, triple negative cancers, and using immune histochemical panel we have assessed all these samples. And we understand that yesterday there was an outstanding presentation on pre-implantation genetic screening, on mosaicism, and we can confirm that we are using immunohistochemical methods, but that they do not present to us clear picture of the entire bioptat of the cortical layer of ovaries. So we're just studying the bioptat which we give to our morphologist. And the part which goes for cryoconservation cannot be subjected to these methods because it destroys follicular pool entirely. Our colleagues from US last year have published interesting publication on using photodynamic therapy. And photosynthesizer allows to mitigate metastatic damage of ovarian tissue while preserving follicular pool. We've tried to do that. We were gathering our experts that are doing photodynamic therapy. Unfortunately, we did not obtain any success. The perspectives of ovarian tissue are, of course, obvious when we talk about childhood cancer. More than 400,000 children are diagnosed with cancer, leukemia, Williams tumor, and brain tumors. So unfortunately for children, this is the only way to preserve their genetic material. For girls, it's cryoconservation of the cortical layer of ovaries with orthotopic subsequent transplantation. And this is done quite broadly by our Chinese colleagues. But these publications that are available now, they attest for the studies of 13 patients. So the research as of now, unfortunately, is episodic. Preserving fertility for boys is also proves to be difficult. And we see that the only way is to preserve the tissue of their testicles. So this is a global context which has to be developed and further studied. Autotransplantation of cryoconserved cells or tissues of testicles is combined with the risk of reinduction of benign, of malignant cells. So there is no technology to prevent possible damage. The auto IVM method, which is highly developed, including in Kulakov's center and in St. Petersburg centers. We have also tried this method, getting up to 128 oocytes from 38 patients, but we've been able to freeze only 14% of embryos. 112 children were born from oncological patients, but unfortunately, our patients not always want to talk to us after they had happiness in their family, maybe due to some beliefs. In November 2025, President has given to Teresa Woodruff an award. We also received that award, and this premium became international, and our colleagues from Kazakhstan were invited, headed by the academician Vyacheslav Lokshin. So everything which today in Russia is done in oncofertility is not only a work of a single federal center of medical radiology, but it's the work of the entire team of Russian doctors. Of course, RARCH, this Russian association headed by Dr. Korsak, was the pioneer. Also, Viktor Radzinsky was helping us, and all our reproductologists, Yelena Kalinina, who always came to our help in choosing various technologies. I'd like to say a lot of thanks to the team from Kulakov's center. When we were starting to develop this technology, we as oncologists were unaware where to go to. We knew that the future is there, and we knew that we need to do this. So we then came to Vladimir Kulakov, and he introduced us to Tatiana Nazarenko. And thanks to the scientific intuition of Tatiana Nazarenko, we started to do this. And quite unexpectedly, each of us went our own way, but after several years, I must say that we came to the same conclusions. And that means that we are on the right path, and I'd like to say, as we discussed this with Professor Lokshin, that oncofertility is not a task of a single country, and we can create some scientific protocols to develop this area, because this is not a practical area, but it's the area which requires fundamental academic scientific research. There are lots of problems, lack of awareness among doctors, limited time window to get genetic material. However, we need to continue ovarian tissue cryoconservation. It's the most prospective way of preserving fertility. It does not limit the time of starting specific treatment. It does not have a big medicinal burden. And genetic material can be obtained from any healthcare outlets in any countries. So we need to continue studies of the safety of using ovarian tissue. As we develop ART, we can do simultaneous operations with ovarian transposition. Thank you for your attention. Marina Viktorovna is not only onco-gynecologist, but is a pioneer and a founder of oncofertility. We thank you for your personal input. We thank you for sharing your experience and emotions. It's always interesting. And I believe that together, Marina Viktorovna, as you said, together with all the countries, we need to create and we need to have right protocols to follow the experience which was already accumulated. We thank you for your presentation. Thank you. Next speaker, Almina Byrykova, candidate of medical science, head of ART named after Paulsen, from the Kulakov's Center, Breast Cancer, Our Success and Challenges, Clinical Observations. The floor is yours. As it was mentioned, it's the leading oncological pathology, the breast cancer. When treating breast cancer, there is operative surgery, target therapy, and chemotherapy, which poorly impacts ovarian reserve and leads to its loss. This is the Paulsen department in the Kulakov's Center, headed by Tatiana Nazarenko. We have researched more than 700 patients with breast cancer. The patients were given IVF programs, and also patients came to us after the treatment. So we managed to cryoconserve the embryos, the eggs. We've made some transfers. We had pregnancies both for the patients and for their surrogate mothers. And as of now, we had 27 children from the breast cancer patients. All patients were stratified on biological subtypes of their tumors, proliferation, index, localization of their tumors, stages, and oncogenetic mutations. What was the algorithm? The patients come to an oncologist, diagnosis confirmed, then what are the reproductive intentions? Is the patient planning children? Do they have children? And then oncological parameters are identified, whether this is reproductive age, is there a favorable survival prognosis and gonodotoxicity of the treatment. Then the oncologist should notify a patient that there is a high risk that after all treatment, the ovaries would stop working and patient won't be able to have her genetic children. And at the same time, this time for the programs to preserve won't make her treatment worse, because there are a lot of publications which shows there are no significant difference for the long-term outcomes for the survival and remission and the general state of patients among the patients which had IVF programs and patients which don't have IVF programs.
After that, the oncologist will refer the patient to the reproduction specialist. We, of course, face many issues because, unfortunately, nowadays we don't have clear clinical recommendations for oncofertility, and thus the process can be delayed. Oncologists and mammologists have made changes to their clinical recommendations where they replaced the word reproductologist consultation possible. They changed it to recommended for patients of reproductive age who don't have children before the start of treating of the oncological disease. In the algorithm of the gynecologist, reproductologist, first we assess the ovarian reserve, because as we know, and we've become persuaded that in spite of the age, maybe a young patient, the reserve can be quite different. And we have to clarify the possible prospects of ART programs. And it's not a 100% chance of having a baby, not even having an oocyte and banks doesn't always determine success. Then we determine the timing for the chosen ART period. We know that's 14 days, but there's oncologists who can give a few times 14 days, and there are those who recommend to start treatment immediately. We should also clearly explain all the planned stages of the ART program. And we also need to explain to the patient that the disease can have different outcomes, and after we've frozen the embryos, they can have a situation that we might need to still do surrogate programs. And many patients say no to that and say, I won't have that opportunity anyway, well, then I'm not going to cryopreserve anything. And after that, we do an interdisciplinary consilium, which will give us an opinion that, based on the health and the prospects of this specific patient now, you can do an IVF program and will give us a certain amount of time for that. Now, the features of ovarian stimulation in breast cancer is, of course, random start protocol that everybody knows based on international recommendations. It's recommended to use aromatase inhibitors for estrogen-dependent subtypes of breast cancer, and because the patients are relatively young with a high or normal ovarian reserve, we should quickly take care of all the hyperstimulation symptoms. As we can see on the slide, the protocols have shown that we can get from any day of the cycle mature oocytes and good quality blastocysts. After that, the reproductologist should straight away refer the patient back to the oncologist so that they can start their treatment. After that, allow me to present 3 cases. First patient, 37 years old, with a confirmed cancer of the breast, came for her reproductive material to preserve it. As we can see from her ovarian reserve, she has a good medium ovarian reserve in spite of her 37-year age. We did ovarian stimulation and we got 16 oocytes, out of which the 6 were good mature blastocysts that are suitable for cryoconservation. After that, the patient did fully combined treatment of her oncological disease with further hormonal therapy for 5 years. After that was over, the patient was planning pregnancy, and during an interim study, an interim examination, there were changes in the endometrium found, and given that she had a comorbidity, the myoma of the uterus, then laparoscopy was indicated, and ended up removing the myome. After the hormonal treatment was over and time has passed after XVII taking, we do an interdisciplinary consilium once again to this time try to achieve pregnancy with the patient using her cryopreserved embryos. We got the permission. We did a standard cryo protocol for the patient. She got pregnant and she gave birth. And in the second clinical case, a younger patient, 33 years old, however, after treatment already, and as we can see, her FSH level is almost 20, AMH 0.4, but she still had 4 antral follicles. We did all the stages necessary, and an interdisciplinary consilium, the whole examination. This is the treatment she had for her breast cancer that she had undergone. We did the stimulation. We were able to, in spite of the low reserve, obtain 3 mature oocyte complexes. 2 of them got impregnated, and we got 1 competent blastocyst. The patient was insisting on doing PGT, but as we can see, having analyzed the embryo, it wasn't recommended for a transfer. The gonadotoxin therapy, is it, or is it just luck or bad luck? We don't know. A third case, patient also quite a young age, but in 2017 she came with breast cancer. In 2021 the surgery was performed. Reproductive function has not been yet realized. What's interesting is that in this patient's history, and her mom and her grandmother had breast cancer. Her mother's sister had ovarian cancer. This patient, they found pathogenic mutations of the BRCA1 and BRCA2. She was scared, but young, beautiful girl, she still wanted to preserve her reserve. But she was really scared, all the same thing. She had hormone therapy for more than 5 years, 5.5 years. Also, before we plan to do something, we do hysteroscopy for diagnosing to make sure there's no endometrium pathology. And after that, we start the actual ART program. This is based on ultrasound that the endometrium pathology, hyperplasia, is suspected. The histological test shows that there is no pathology. Now, because she was very scared because of this hereditary picture, she didn't want to use any inductors. Letrozole was indicated, and here are the 3 protocols that we obtained throughout 1.5 years. In the first protocol, we had 2 cells. After a certain while, we had 3 mature oocytes, and totally, currently, to this day, we've cryoconserved 12 oocytes. What's surprising is that in spite of the whole combined treatment of breast cancer for more than 5 years, taking tamoxifen and an agonist, the patient with age, her menstrual cycle is beginning to restore. And after 3, 6, 9 months, we are getting more and more quality oocytes. However, there's a question that emerges here. Can she get pregnant? Of course not. There's a lot of complications in terms of difficulties in implementing her function because of the tumors, and we're not allowed to use estrogens to prepare the endometrium. But the patients with their compromised reserve being compromised by treatment, age, not having their own ovulation, a thin endometrium, all of that makes us think about how do we implement this reproductive function in them. Also, there's a lack of legislative documents, and since we're already making pregnancies and having healthy children born, we're doing the right thing. Second clinical example, unfortunately, shows that there's a lack of communication. Like, if the young patients had all been notified timely that they can preserve their reproductive function before the gonadotoxin treatment, possibly they would have been able to have, during remission, have known the joy of motherhood. And the third thing, there's a lot of questions still in joint work that the reproductologists and oncologists have to do together in order to get pregnancies with the least amount of harm. So what are the conclusions? Gynecologists and reproductologists do not make decisions without oncologists at any stage of the patient's reproductive intentions, before or after treatment, before planning the pregnancy. All stages of ART programs only after an interdisciplinary consultation with cross-cutting specialists, reproductologists, oncologists, chemotherapists, radiotherapists, just therapists, and if there's comorbidities, you have to get everybody involved. Random start protocols have really proven their effectiveness. In combined use of inducers with aromatase inhibitors allows for the production of competent oocytes and embryos. The patient must clearly understand all stages and outcomes of the ART programs, and also should be notified that surrogate motherhood can be used. And most importantly, we believe, is that the priority always should go to the oncologist and not to the reproductive specialist. No reproductologist, even having an oncologist certificate, can on their own make a decision like that. Oncological treatment is primarily aimed at preserving the lives of patients, while ART in the context of oncofertility is aimed at improving the quality of life in the future. Thank you very much for listening. Distinguished colleagues, thank you very much. Maybe we can do questions at the end of the session, if anybody has some. So allow me to present to you our next speaker with a very positive name. The impossible is possible. Successful childbirth after fertility preservation with OTO-IVM for ovarian cancer. The speaker is Kalugina Alla, professor, director of the department, professor of the Department of Obstetrics, Gynecology, and Neonatology at Pavlov St. Petersburg State Medical University, and general director of the Skyford Clinic. Thank you. Well, I'd like to thank the organizers of the Congress, first of all, and personally, Professor Lokshin, for this hospitality. Not my first time in Kazakhstan already, and I'm always amazed at you and how high the level of this conference is. Thank you very much for that. Always a big pleasure for me to come to Kazakhstan. So, successful childbirth after fertility preservation. Now, this presentation was prepared with the support of the Sun Pharmaceutical Limited Company. The relevance of this matter, I don't think we need to dwell on that too long. Marina Viktorovna already emphasized this part in her presentation. I'll just say that the growth in the numbers of the disease of oncology diseases, every year there's a growth of 7 to 8%, and whether that has to do with more diagnosing at our earliest stages, but oncology has really made a step forward, just like ART did. And it's these two fields of medicine that have given the ability to develop oncofertility. Now, I'm not going to talk too long about what the damaging effect is of radiation therapy and chemotherapy. You've already heard that in the previous presentations. But on my slide here, I'm also trying to show the folliculogenesis and the impact of age on the on how many follicles you have. And when you have radiation chemotherapy overlapping that, then sometimes we get complete absence of ovarian reserve. So can we stop the biological clock? And we can confidently say that yes, thanks to the development of cryotechnology. And today's methods of preserving fertility in women, they allow us, they've become a routine. Cryoconservation of embryos, eggs, mature and immature ones, with subsequent IVM maturity, tissue preservation, but we're more careful about that, and we use that mostly for children nowadays. And they're developing auto-IVM technology. OT is ovarium tissue oocyte, getting an egg from tissue that's already been removed, ovarian tissue, and we'll talk about that today in more detail. So patients with egg tumors, they are a special group, a special risk group. It's due to these tumors can spread to the abdominal area during the puncture, so that's why they cannot be doing these stimulations in standard mode like we can do it for other patients. And cryoconservation of the ovarian tissues for this group of patients is not feasible because there's a risk of contaminating by neoplastic cells when you do the transplantation later. And in the majority of cases, the only way to preserve fertility in such patients is the auto-IVM method. It does have lower efficiency than the standard methods and should only be used in cases where it's a critical case, where it's impossible to do anything else as an additional method. Now on this slide we have all the live birth cases in the world after auto-IVM. There are 6 currently, but probably 7 already now. And there's 3 cases, which is getting an egg cell from a removed ovarian tissue, and that's they're highlighted a different color there. Now from publications, this patient case, 21-year-old female patient with serous bilateral pelvic lesions, and this is a clinical case in the literature. And from the removed ovarian tissue, we got 4 egg cells and oocyte complexes. Then it was the maturation. We obtained 3 embryos transferred. 2 embryos were transferred after cryoconservation, and pregnancy occurred, which resulted in labor in a healthy child. Second case of getting doing the same thing. It's also left-sided salpingo-phorectomy. We obtained 10 OCCs. 3 embryos were obtained, 2 transferred, and as a result, we have a healthy boy. In the third case, 33-year-old patient with serous borderline tumor, single right ovary, and from the tissue we got 8 OCC complexes, 3 embryos, and as a result of the transfer of 2 embryos, at fragmentation stage, we have pregnancy, and at week 36, urgent C-section because of gut issues, but it's a full-term healthy baby that was born. Everything is fine. But I wanted to emphasize as well that, that we studied 20. There was a work where they studied 20 OTO IVM procedures, 15 in oncological patients, 5 in non-oncological. 10 had organic ovarian cysts found, and the results that were obtained were that the number of oocytes that we're getting from the ovarian ovaries with the cysts is much less, and having an organic cyst on the ovaries, they damage the endocrine function, and the number of mature oocytes goes down drastically. And another work that has shown live birth in OTO IVM, but here I wanted to emphasize that we've vitrified from 64 patients, we vitrified some oocytes. 5 patients came back. That's how little patients come back. And with embryo vitrification, 13 patients, 7 of them came back. And here are the results on fresh material: 3 childbirths and 1 progressing pregnancy. So, own experience of using OTO IVM. We have this is not OTO IVM quite yet. This is so far controlled ovarian stimulation with onco patients. We've done a total of number of 90 punctures. Average age was 32.7. Average number of oocytes obtained 15.7 per patient. Out of the mature patients, 12.5. And in 54 cases, protocols, we did vitrification of oocytes, 38 protocols of impregnation with partner sperm. 2 patients used vitrification and the impregnation. So we work closely with the oncology center named after Petrov, and we actually have some pretty good results. We have 13 patients with outcomes, 17 embryo transfers, out of them 3 to surrogate mothers, 10 clinical pregnancies, which is 59%, with 4 abortions, so 6 births on time. Now about OTO IVM.
In total, we had 40 procedures. The average age of patients is 30.8. We have not received oocytes from 3 patients. Vitrification of oocytes, 21 protocol, 7.3 oocytes per patient. Fertilization with this partner sperm. The fertilization was 63%, and using 11 XVII protocols. So OTO IVM is the only way for the ovarian tumors or metastatic lesions, and this method is still experimental, and it requires to develop the algorithms further. A clinical case: a patient born in 1994. She lived in Petrozavodsk, so she had an infertility, and she had a OHSS, and based on MRI data. In the Republican Perinatal Center, there was laparoscopy, removing the right ovarian tumor, and there was a serous carcinoma, highly differentiated. The patient was sent to the Petrov's Oncology Center, where adenocectomia was done, resection of a left ovary, omenectomia. It has shown that this is a borderline serous tumor of a right ovarian, which allowed us to preserve the organ-saving volume. Since she wanted to do her reproductive function in the St. Petersburg clinic, she had a controlled ovarian stimulation with anti-agonist, with replacing triggers with GnRH triggers and letrozole transitory hyperostinea. So we received 15 oocytes and cryoconserved 8 embryos. There was the PGT aneuploidia. 2 embryos were aneuploids, and throughout the next year there were 3 attempts of transfer of frozen embryos, but with no results. In September 2023, there was a recurrence of the tumor in the single left ovary. At the Interdisciplinary Concilium at Petrov's Oncology Center, it was decided to preserve fertility by using auto-IVM. Adenocectomia was done from the left and taking the ovary. That's the ovary which is subjected to the tumor. Ovary was transported to the Skyford clinic to implement auto-IVM method. 22 complexes were received. 12 oocytes have grown to the second cleavage phase. 10 zygotes were received from ICSI. This was a time-lapse approach. And you see here the development of the embryo using a time-lapse in the EmbryoScope Plus incubator. Embryo has developed wonderfully. And then there was the hormone replacement therapy. And after pregnancy was allowed, hormone replacement therapy using standard methodics, estrogens, and micronized progesterone. They have transferred the embryo of this blastocyst to the uterus. So this was successful transfer. HCG was received 812 after 12 days, 807. The pregnancy was normal, and on the 31st of July 2025, the birth was given in Petrozavodsk through natural ways, and this was a live boy weighing 3,300, Apgar 9.1. These are our published research. For this patient, the pregnancy support was done using micronized progesterone, using progestan. Everything is standard. After 12 weeks, she was getting for 200 milligrams per day. So the oncological patients, their pregnancy management is the same as for ordinary patients. There are no specialities. So the data which was already published in the literature on the efficacy and safety of using micronized progesterone in the ART programs and for the support of the pregnancy. So there were no undesirable side effects if we compare progestin with other side effects, with other micronized progesterone forms. Progestin has the least viscosity level, recommended for the second phase support and pregnancy support. So preserving fertility for the patients with ovarian tumor is a challenge. So we are announcing the 7th case of live birth after auto-IVM, the 4th for the patient who had ovarian tumor. So perhaps this implement can be implemented without bringing this to the menstrual cycle alignment, because we have our own alignment policy. We need to inform the patients that there could be fertility preserved for young patients with oncological diseases, and this should be integrated into the oncological centers to help. And of course, for that we need a high level of specialists, because we don't have right to make a mistake with those patients. I thank you for your attention. Well, we thank you. Next is Anastasia Sarkasheva, MD, Associate Professor, Head of the ART Department at the Medsi Clinic, Associate Professor of the Department of Obstetrics and Gynecology, Institute of Surgery, Pirogov, Russian National Research Medical University, Moscow, Russia. Topic in vitro maturation for fertility preservation in oncology patients. Colleagues, thank you for your presentation, and thank you for this Congress. It's first time I'm in Kazakhstan. Your country is beautiful. I'm going to talk about in vitro maturation for patients with oncological diseases. I have no sponsor support. I have no conflict of interest. The main algorithms of preserving fertility in ASHRAE, there could be a lot of different methodologies. So to consult patients with oncological diseases is quite difficult, because patients are in a tremendous stress. They just learned their diagnosis, and it turns out their life. It's difficult not only for the patients but also for us, because we cannot answer their questions. Not only counseling on the methodology how to preserve fertility, but also what to do next. Would there be either any problems of relapses? If we talk about preserving fertility, the most studied and the most predicted is ovarian stimulation, cryoconservation of oocytes and embryos. This is not only the most efficient method, but also which has predictable results. Only several methods of research are needed. It's the age, AMG, AMH, in order to understand the efficacy for this particular patient. Another example is a high number of oocytes retrieved if the woman has normal ovarian reserve. There could be also a split program. Both oocytes and eggs can be frozen if a patient is in a legal marriage. It's using estrogens for the breast cancer. However, not all patients should be given ovarian stimulation, because it's 14 days, and not all oncologists allow their patients to delay the treatment. There should be indications for ovarian stimulation and puncture. There is also a higher risk of thrombotic complications and infection complications. We understand that patients come at the early stage which are quite preserved as to their status. We can do IVF in natural cycle. However, we understand that the effectiveness of IVF in natural cycle could be dramatically low. So in vitro maturation technologies of obtaining obviously immature oocytes from, so we have minimum preparation, we have, so the oocytes that are not favorable for ovarian stimulation, these are our target indicators. Then those oocytes are mature within 24-40 hours in an embryology laboratory, usually to maturation rate, usually about 40-60% of cells are growing. The number of cells compared to ordinary ART cycles, there are quite few. Although American ASRM and ASHRAE considers this procedure not experimental but possible to be used in clinical practice, we understand that this research should be continued. And although the preliminary results show that children after IVM are healthy, and there are no results on this KARM, we understand that this procedure is much new, and this research should be continued. If we're to talk about IVM advantages, it's a fast track. It can be done at any phase of the menstrual cycle, on any day, and the care is organized in such a way at our facility that if the patient comes to do AVM, it would take 3 or 4 days. This can be used in situations when the stimulation is contraindicated or oncologists cannot give us more time. There are some flaws. The main one is the very high requirements for the ovarian reserve. It should be not only preserved but be closer to the different ones. AMG should be higher, MGH should be higher than 3.5, Articular follicles should be more than 19, leading to 8 mature oocytes. But at least for the young woman, 8 sites could be not enough to give a birth to a healthy child. The methodology is not used in all IVF clinics, and the number of cells is quite less. We had 34 IVM cycles. In one case, oocytes were not received from a patient of 39 who had a breast cancer. For 5 patients, for 6 patients, we did not receive the oocytes. First of all, this was a lack of oocytes, and 15 patients had no mature oocytes, so there was no cryoconservation or fertilization. 185 complexes were received, so the percentage of growth was 13.5%. And for 15 patients, there was fertilization. I'd like to introduce you to this data. This is a description of a series of cases formed in summer 2025. We applied to publish this in the annual magazine Акушерство and Gynecology. It was published. So there were many cases when we received no embryos, no blastocysts, no cleavage, and that was the end of IVF program. We had several patients that are still storing the embryos, and we had 2 embryos. First embryos was for a patient who had done the transfer for herself after getting a remission. This was one euploid and of a great quality, but unfortunately the pregnancy did not materialize. But without preimplantation, without PGT, this was a transfer in surrogate motherhood, and it ended in clinical pregnancy and childbirth. And now there are no negative factors on its After 15 cycles of fertilization, in 7 cycles we received no embryos. However, in those cycles where we had no embryos, the average age was 39, which is a late reproductive age, or probably the side of menopause, out of 8 cycles. Three patients were. This was an embryo of a wonderful morphological quality obtained in this difficult way. We were talking to this patient several times when we could not help to use her will. Why she stops storage of embryos is that she doesn't want to be married and to have mother's childhood. And it shows not only standard difficulties, but also ethical dilemmas in oncofertility. So very few patients come back with their cells. So among those patients that we've done oocyte cryoconservation, no women came to fertilize those oocytes. These difficulties when the patients stop keeping the embryos, they focus just on this. And that means that we are working with a very high, very difficult category of patients. There are 2 transfers. One came without pregnancy, and in the group where we obtained so finally, IVM is quite prospective. We need to do this. We need to develop this. We need to consider that this is fertility preservation for women that need the fertility program, but we cannot do ovarian stimulation. I'm quite cautious to this procedure in a way. You have to do this, but also you need to watch the outcomes, and you need to counsel patients rightly to talk about lower efficacy compared to ovarian stimulation. So IVM can be done after 2-4 days from coming to the clinic. We need to continue observing the ART outcomes and the health of children and parents. So all research in this area confirmed that the number of patients is much lower than for those patients that have clinically concerned with their opinions, their oocytes. So after forming this publication and article, we also had 8 cycles during the last month. These were more efficient as to getting the oocytes because, unfortunately, these were young women below 33, 32. We did not do hormonal priming. For the last 2 months, we've done hormonal priming. We've been entering 150 milligrams. So that simplifies transvaginal ovarian puncture because all small antral follicles to be punctured is quite difficult. So that's why hormonal priming could be efficient.
Another thing I wanted to specify is that the age limit for IVM is not defined, so even at an advanced age, you can still come to do the procedure. Nonetheless, we all understand that even though it isn't specified anywhere in any legislation or regulation, but it is a program for young patients. And these ovarian reserve numbers, they're looking realistic. So your AMH should be high, the antral follicle number should be high. That is it. Thank you for your attention. Thank you very much, Dr. Anastasia. So questions later, right? That's what we agreed on. The next speaker, Oncofertility, Modern Methods of Fertility Preservation, Legal Barriers and Prospects of IVM Technology, Karimova Aliuralovna, reproductive specialist oncologist. Good morning, distinguished colleagues. First of all, I'd like to thank you for the ability to speak offline this time. Last year I wasn't able to visit. This year's my first time in Kazakhstan. Very amazed by the hospitality. My name is Karimova Aliuralovna. I'm an reproductive specialist. I became an oncologist just to better understand oncofertility. And today, and I'm not going to repeat what other people said, I'm going to talk about the Russian legal issues and the prospects of the IVM technology. Slides don't seem to be moving for some reason. Slides not switching. Now it's working. I don't have any conflict of interest. Not going to repeat what others said, that we have several methods of preserving fertility, both with the oncologist and the reproduction specialist. They are interchangeable and they are combined in some instances, and each method in its own way has flaws and advantages. Yes, the majority of the effective methods of preservation of fertility is in the hands of reproductive specialists, but the patient with oncology is still mainly an oncologist's patient, and only the oncologist can provide the framework and offer options, and we're always going to depend on the oncologist's decision. Now, in the context of my country, I'm going to tell you that we do have issues with regulations. In our legislation, we have Order 803 on using ART, which specifies that patients with oncology have the right to preserve their fertility before chemotherapy and radiation therapy. There are also clinical recommendations where it says that having cancer in the patient is a counterindication to ART. And unfortunately, there's not a single order which covers the clinical situation in pediatrics. We also have a 2022 order on making amendments to certain legislative acts about surrogate motherhood, surrogacy, where it says that using donor material is not possible in such programs, and the first people to get hurt by this were patients with oncology, who at that point had not preserved their genetic material, and they were indicated the donorship program where they had to use surrogacy. Unfortunately, such patients cannot be helped anymore in our country, and they have to go outside Russia for such programs. We also have organizational barriers, which were already mentioned by the previous speakers. We do have interaction between the oncologists and reproduction specialists. There are difficulties still, since we don't have an referral algorithm of patients from oncology to us, and you especially feel that outside of Moscow and St. Petersburg, because the other regions are just starting to work on this. And no matter how well we talk about our results, we don't have a single registry of oncology patients who are indicated fertility preservance. These registers are all siloed, and every clinic does have it, but we don't have one registry where we could look at the effectiveness and the ability to bring back these patients. And this is also a problem. And we don't have funding in the OMS system of these programs. So unfortunately, all the financial burden is on the patients. I'm going to talk about the IVM technology a little bit, because in the city of Ufa, we have a big experience of carrying out these programs, and the key benefits for oncology patients, of course, that we avoid all the complications from hormonal stimulation. There won't be a hyperstimulation syndrome, which is safe for the patients, and especially patients with a higher ovarian reserve, with PCOS. We minimize risk of increased estrogen levels, which is especially important for hormone-dependent tumors, The biggest advantage of IVM is that we do these punctures in a short time. Within 2 days, we can already do this program. If we have some deadlines from the oncologist. We're in the city of Ufa. And over the 4 years, we've already done more than 350 follicle punctures in IVM programs, and the share of onco patients was 18%. I think this is a small number, but for it, there's also certain indications. We don't do the IVM programs for just anybody, and I'll talk about that later. Most of our programs are patients with PCOS, with a higher ovarian reserve, young patients, for who we technically even do fresh transfers during these programs. One IVM program we did at our clinic, where we obtained OCCs, but unfortunately we didn't get any embryos out. Now, who I'm going to offer IVM to first for fertility preservation is, of course, young patients with a rich ovarian reserve, where we clearly see that we can get enough oocyte cumulus complexes, and since we work with cancer patients, we need to understand that we're going to get something as an outcome. And for morbid obesity, I can offer the IVM program to them too when I know that perhaps they won't have a very good response to stimulation. And if the patient is already in stimulation with obesity and we see a poor response with one dominant follicle and 10 follicles not answering at all, then such patients also I'm going to put on the IVM program without the trigger, and thus increase the number of obtained cells. Patients with borderline tumors and malignant tumors are also indicated for IVM, and young patients with a poor reserve also, they show very good performance, especially with borderline tumors, but the only complication here is in technically obtaining these cells at the puncture. So the specialist should be very well skilled in these punctures, because usually patients with borderline egg tumors come back with one operated ovary where we see no more than 6 antral follicles. So it's a technically complicated, difficult puncture. And one of the indications for IVM is the urgency of starting oncological treatment when the oncologists don't give us any kind of time or deadline to do the stimulation. And where we can do the stimulation, of course, we're going to do it, but naturally after the concilium with the oncologist. Now, IVM is no longer an experimental method. It's a life-saving technology for cancer patients. The advances in culture media, puncture protocols, and lab technologies have dramatically improved IVM. We are always trying to find that ideal, optimal method. We've tried different needles and different pressures, so we try to find the best optimal way. Efficiency rates are increasing, approaching those of traditional IVF. There's even articles that say already that it's young patients with a rich ovarian reserve that they show the same effectiveness in IVM as IVF, and it's a safe method because we have studies of 2-year-old children after IVM, and they show normal growth in body weight and mental development compared to IVF children. So my presentation is brief, but with pleasure I can respond to your questions, and thank you very much for listening. Thank you very much. I didn't state that in our agenda from Bashkiria. We're very happy that you're with us, the family clinic. Thank you very much for your presentation. And those legal issues, the financial issues, are of course just as relevant in our country, in Kazakhstan too. And I think we'll be actively working on that too. Thank you very much. Allow me to present our next speaker. Murat Kayarbayev. doctor of medical sciences, the Almaty Sima Hospital, Kazakhstan. Thank you very much for introducing me. Big honor for me to be here today in the company of such esteemed specialists. So fertility is part of the oncological pathway. We talked about the methods, but we haven't discussed how the oncological patient should end up with the reproduction specialist, because we know that when the patient comes with a oncological disease diagnosis, then they don't always have enough time to think about preserving fertility in tomorrow. And so the oncologist, who has a great responsibility on them, they should know the information, they should know what to offer to the patient. And of course, among all oncological specialties, gynecologists and oncologists, they understand that better because their background in gynecology and obstetrics helps us with that. How do I go through the slides? All right. So I don't have any conflict of interest. Right, good. So why we talk about this is because annually in the world there's more than 18 million new cases, and more than 20% of them, pretty much every fifth case, is a patient of reproductive age for who fertility preservation can be relevant. All the more because the successes in treatment and the new methods and new drugs have allowed us to significantly improve outcomes, and most of the patients make it. But surviving is not all. It's about maintaining the ability to live a full life. And advances in cancer diagnosis and treatment have led to an increase in life expectancy and recovery rate. 1 in 12 cancer cases diagnosed in people under 40 years of age. Cancer survivors often experience infertility or premature menopause as a result of treatment, because all the treatment methods that we use, they're pretty aggressive. And also, more and more women are postponing pregnancy until later in life nowadays. In terms of the current recommendations, according to ASCO, fertility in cancer patients is the patient's ability to maintain or restore the ability to conceive after anti-tumor treatment. And currently, oncofertility is considered as part of a comprehensive care aimed at the long-term quality of life and reproductive health of patients. The loss of fertility is one of the most significant consequences of treatment of cancer for young patients. It's not just a medical question, it's also an ethical and psychological one. Patients should have the right to choose to retain the possibility of becoming a parent in the future. The thing is that the methods that we use, and it's already been said today, chemotherapy, they suppress the ovarian function, and oftentimes during chemotherapy the ovaries lose their function. Radiation therapy, a dose of more than 2 GY is enough for the ovaries to lose more than 50% of their function. 4 to 6 Gs, that's 2 or 3 sessions, that's enough to silence the ovaries forever. surgical interventions oftentimes, right? That's the removal of the ovaries or the uterus. And many women, as we said, postpone it to a later stage when the ovarian reserve already is low to begin with. And in terms of the route from diagnosis, and we understand the stage, we do the consilium, we should definitely discuss the fertility before treatment. Because once you've started the treatment, it's too late. We've already discussed how much time can we give to the patient in order for the reproduction specialist to be able to consult them and obtain some kind of material to preserve their fertility. To this question, I always answer like this: how much time do you need? You take as much time as you need, because this patient, once she's in the program, she's not going to have a second chance. Just the same as she won't have a second chance with her ovarian cancer or any other hormone-dependent disease or breast cancer. When you ask how will stimulation influence the disease, that doesn't matter so much at that point, because the patient won't have another chance anyway. Now, the key ASCO recommendations of 2025 were published in Clinical Oncology. What do we need to do, right? Discuss the risk of infertility at diagnosis, and it's recommended to document and put in the patient's medical record. If the patient has doubts, then quickly refer to a reproductive specialist, because no one like a reproductologist can assess the chances of the patient and tell them what methods they have to preserve their fertility. The standards are currently cryopreservation of sperm, oocytes, embryos, ovarian tissue, ovarian transposition, organ preserving surgeries, which are already being implemented broadly in our countries. The GnRH agonists, which we use to preserve the ovary function, and that was in the breast cancer studies as well. They are not a substitute for preserving fertility. They're in addition to it. And annual fertility talks after treatment, you should focus on a multidisciplinary team and accessibility. And key principles: we should discuss with all the patients before the treatment, document. For men, sperm cryopreservation, and what we were discussing just now, annual fertility talks after treatment, strengthening the role of the multidisciplinary team, and supporting insurance coverage of IVF. And it's good that at KARM this issue is talked about, and there's like a whole section today devoted to this matter. So then the discussion of the issue of infertility with cancer patients, it arises not just with those who are not pregnant, but cancer can arise during pregnancy. And here we're faced with a much more complicated problem when we've got two lives at stake, and we should calculate it so that we satisfy the interests of both patients. And clearly, of course, the patients who have had treatment after cancer, they may also have reproductive plans. Cancer incidence in pregnancy is pretty rare, usually 1 per 1,000 to 3,000 to 5,000 cases annually in Europe. It's second place leading cause of death in reproductive age. During pregnancy, we should definitely take into account that symptoms of pregnancy can cover up the symptoms of the disease, such as nausea, vomiting, changes in the mammary glands, and abdominal pain. That the difficulties in physical examination due to the changes in the mammary glands in breast cancer, the reluctance of doctors to prescribe additional examinations, especially visual diagnostic methods, which carry a radiation burden, and that will lead to incorrect staging and bad results of treatment. Especially low value of tumor markers, especially in the first and second trimester of pregnancy. We see a lot of patients who, for some reason, they take tumor markers at an early stage, and of course it's going to be elevated. And doctors start referring these women to oncologists. So what needs to be done? Diagnostics and treatment of the mother should be done in accordance with modern standards, and it should be in full, the diagnostics and the treatment. What we can do is we have to protect the fetus and the future child from possible negative effects of diagnosis and treatment. We should try to preserve the mother's reproductive function and maintain the quality of life for the mother and the child. And pregnancy should not be a reason, let alone an excuse, for incomplete examination and staging of the disease. This is the opinion of oncologists, and it's very clear. Now, common myths about cancer during pregnancy, we explain that too. The thing is that you don't always need to terminate pregnancy, and the cancer treatment during pregnancy is possible because oftentimes we see patients who we see that they can be treated and you can help them, but they send them for termination first, and sometimes termination can even bring worse outcomes for treatment because of delay. Women of reproductive age don't get cancer, that's a myth. You can get pregnant after cancer treatment, same thing. You know that there have been a lot of cases where the quality of life improving and treatment is better. Cancer progresses faster during pregnancy. Actually, some forms of tumors can, but that doesn't have to do with pregnancy. It has to do with the biological activity of the tumor, like melanoma, right? When we've seen metastases of melanoma in the fetus and everywhere. But it didn't have to do with pregnancy. It had to do with the melanoma just being very aggressive. And very rarely does the cancer affect the fetus. So usually that doesn't happen. Cancer is doing its own thing. Pregnancy is doing its own thing. They're separate. And one of these cases when during pregnancy the patient had uterine cancer, that was her only chance. She was midterm in her pregnancy, and the decision was made to do chemotherapy. Of course, with the consent of the patients, we did the chemotherapy, and everything ended well. Delivery at 34 weeks. C-section. The child was a bit preterm, but the child is doing well. She's in second grade now. And the mom every year sends pictures for the 1st of September when she goes to school every year. So everything is possible if you do it right. And in terms of pregnancy after cervical cancer, this patient had surgery, and thankfully these patients give birth full term, and this is one of these cases. We already have a lot of such women who give birth after cervical cancer. Sometimes you even have to do plastic surgery after 2 or 3 deliveries. And another thing I'd like to say a couple of words about is the treatment of cancer, where we do organ-preserving treatment, which is something we focus on as well. Endometrium cancer patients, cancer is getting younger, and namely such patients, they come to us. We've had a total of, from 2015 2024, 542 women for who organ-preserving treatment was done for 82 women. There were different treatment protocols done.
In some cases, it was only a steroid system, and in some cases, we use agonist of gonadotropin-releasing hormones. In some cases, we used oral progestins to increase the dosage individually, because every 3 months we take biopsy and we assess the effect. If necessary, we modify this treatment. So remission was 96.3%. 79 out of 82 women went into remission. 3 patients, unfortunately, had to remove the uterus due to lack of effect. And the average length of treatment was 6.5 months. The relapses were 20%, mediana 7th month, and frequency of pregnancy was 45%, and live birth 34.7% of cases. This was uterine cancer. This is one of the patients after treating uterine cancer. She gave birth to 2 children and recommended to use Mirena uterine spiral for this was our team that made it possible. Thank you for your beautiful presentation, your wonderful cases, and we are very pleased that you can manage the situation quite well. Dear colleagues, we have exhausted our program and our presentations. At the end, I'd like to say that in Russian Federation, there are quite a lot of legislative acts, clinical recommendations on the breast cancer, on the infertility treatment, and mammology society recommendations, oncologist recommendations. And these recommendations would have legal impact. It says that for all patients of reproductive age before start of specific treatment for the tumors, they need to go first to reproductive doctors. And in clinical recommendations on managing patients with breast cancer and infertility, there are protocols for getting genetic material with the coverage of aromatase inhibitors and anti-estrogens. And today in Russian Federation we have legislative acts which allow us to manage our patients in legal field without fearing for some legal consequences. And I hope that in Kazakhstan there will be the same clinical recommendations or legislative acts allowing you to do the not only practical management of our patients, but also some scientific research in this area. We thank you. Thank you so much. I'd like to say that, of course, we have some clinical recommendations of oncologists, but recommendations are purely have recommendation nature, and it doesn't protect you fully, doesn't cover you fully. So that's why we have some legal issues, and we are trying to solve it. We thank everyone. So let me make a small comment. In the Russian Federation, from the 1st of January 2025, clinical recommendations are the main law for making a decision by a doctor in Russia. Thank you.
Добро пожаловать в клинику Астана Эколайф, ваш надежный проводник на пути к долгожданному материнству и отцовству.
Здесь вы найдете все для репродуктивного здоровья. Современную гинекологию и урологию, программы помощи в зачатии, от ЭКО и суррогатного материнства до заморозки яйцеклеток и сперматозоидов, передовые гинекологические и урологические операции, круглосуточный стационар, амбулаторные приемы, точная диагностика, лабораторные исследования – все собрано под одной крышей, чтобы путь к вашему счастью был максимально комфортным. Мы гордимся тем, что помогли появиться на свет уже более чем 7000 детям. За каждым из них история любви и надежды. В 2023 году государство присвоило нам высшую категорию аккредитации. Это значит, что у нас безопасно и качество медицины на самом высоком уровне.
Астана Эколайф – это не просто клиника. Это место, где мечты стать родителями становятся реальностью. Место, где забота встречается с профессионализмом. А жизнь дарует шанс стать родителями.
Dear colleagues, we are starting our next plenary session, which is about pressing issues of reproductive health and gynecology. And I invited Professor Korsak on the podium. I requested Lokshin to invite me on the podium because yesterday he announced and he congratulated our esteemed Eduard Abortsumyan as he became of age, coming of age. And today our colleagues have delivered official address from Russian Association of Reproductive and this is the president of reproductive medicine of Armenia, and he was working in Paris, in Boston, and the book which Eduard Martinovich wrote is especially valuable. As you know, yesterday I've shortened everything and I've made a short introduction, and today, dear Eduard Martinovich, my sincere congratulations with your wonderful jubilee. Your life, your professional way is a vivid example of serving science, medicine, and people. You managed to combine the talent of a doctor, scientist, and a successful organizer, founder of the Reproductive Health Center, head of the National University Department Chair, and author of a bestseller in medical literature. All of this thanks to your energy, your knowledge, your enthusiasm, and thousands of families, thanks to you, gain happiness of parenthood, and reproductive health received new horizons of development in Armenia. I admire your abilities of being creative and creating your ballets, which have conquered world arenas, and your anniversary is a big holiday for all medical community. So I wish you good health, success, and new scientific achievements, and many years of active, fruitful life. May you always be surrounded by love of your family, respect of your colleagues, and respect of your students. From Rarch Korsak. We congratulate you, and our welcome address will be also published. For us, it's a big honor to see your friendship, and we're going to continue. I am very happy to have such friends and such colleagues. Thank you so much. Dear colleagues, we are continuing our work, and I'd like to introduce the first speaker because it's our big friend of Kazakhstan, of our young researchers, and a wonderful example to be followed. How professional and how deep Professor Arazov does his work, whether it's surgery, lectures, or printed articles or dissertations. And we congratulate Professor Arazov that he became the chair of a council for dissertations in a Russian University for the Friendship of People, RUDN. He is a deputy chair of expert council, and today's his presentation is estradiol and breast cancer, new controversies. Unfortunately, he could not arrive here. He is replacing Professor Radzinsky in Omsk, but nevertheless, he is speaking to us online. Dear esteemed colleagues, dear esteemed my most amazing friend Vyacheslav Natanovich, good afternoon. I'm sincerely glad to greet you at the anniversary KARM Congress. Unfortunately, I was not able to fly to this Congress. For this reason, I'm speaking to you online. But I cannot begin my presentation without words of gratitude to KARM, because the team of Professor Lokshin for all these past years has achieved impressive results. And today it is necessary to wish above all not only health, strength, joy, good luck, but prosperity, implementation of all planned goals, and of course the boldest scientific ideas to be implemented. And allow me, without further ado, to start my presentation, which is dedicated to controversies of the influence of the estrogen on the breast. And immediately I want to make two serious emphases. The first emphasis relates to new data of 2025, where despite of the titanic efforts to somehow reduce hormonophobia, the results of independent surveys conducted by our foreign colleagues, they show that unfortunately, even after spending 45 minutes of a consultation by an obstetrician gynecologist with patients not only on combined oral contraceptives or on the necessity of effective hormonal methods of contraception, still 64% of our patients experience certain fears towards any form of hormonal therapy. And the first concern, of course, relates to not increasing the risk of developing breast cancer through the use of hormonal medications in general in our gynecological practice, and specifically the effective use of combined oral contraceptives. Here I wanted to remove a share of subjectivity and immediately remind my colleagues that in all current regulatory documents, this is the first document that defines the tactics of managing our patients with benign breast diseases. There are no restrictions on the use of combined oral contraceptives. And of course, allow me to remind you that this is the category 1, according to national criteria for the acceptability of contraceptive methods. And when we talk about additional risks associated with the presence of a family history of breast cancer or presence of pathogenic mutations BRCA1, BRCA2, which have direct impact on increased risks. And I'd like to remind you that BRCA1 or BRCA2 mutations or the presence of family history regarding breast cancer risk are not contraindications to the use of available methods of contraception. And of course, I especially prepared for you a table related to the 4 key documents. These are not only our national clinical guidelines for benign breast cancer, but also contraception guidelines, national medical criteria for acceptability of contraceptive methods approved 2 years ago, and the most important document, the WHO document, 5th edition, which defines our tactics for managing patients in need of contraception worldwide, since it has not been updated since 2015. Thus, within these key documents, patients with a burdened heredity for breast cancer risk, patients with a family history of breast cancer risk, and patients with BRCA1 or BRCA2 mutations, there are no limitations, no restrictions for the use of available contraception methods, specifically combined oral contraceptives. And we drew attention to the key contraindications presented to you in the updated document on breast cancer. Not a single word regarding benign breast cancer, and the mentioned risk factors are present, of course. However, for our vigilant patients, there is a special form of estrogen which is named as the first selective estrogen receptor modulator, which is directly related to reducing proliferative risks in the epithelial lining of the breast due to the fact that in the presence of estradiol at the level of membrane estrogen receptors, estradiol instead has antiproliferative effects. At the same time, this form of estrogen, due to special pharmacokinetics advantages, due to the presence of a fourth additional hydroxyl group, due to a special half-life exceeding more than 24 hours, due to selective toward estrogen receptors at the membrane level and on the level of nuclear receptors, we can safely say that this form of estrogen does not induce activity of protein kinase B and has no relation to increased proliferative activity of phosphoinositide 3 kinase enzymes. And if we speak about its principal characteristics of lacking cancerogenic properties, this estrogen has no residual venous thrombotic connections. This form of estrogen has minimal inhibition of the cytochrome P450 system. For this reason, there are no clinically significant drug interactions occur. It needs only to bind to sulfate glucuronide or glucuronide groups to be eliminated through urine. Thus, we can say that estradiol is the final product of steroid metabolism. It does not transform into anything further. Unlike estriol, estron sulfate, and estradiol, thanks to such unique qualities, estradiol will never again be accused of mechanisms of carcinogenic transformation. At the same time, if we discuss estradiol in relation to oncoprotective possibilities, our foreign colleagues at the Cancer Institute used estradiol for postmenopausal patients with hormone-resistant breast cancer within phase 1 and 2 studies, 20 milligrams, 40 milligrams, and 60 milligrams of estradiol, and its effect had no relation to increased proliferative activity of cells, no relation to increased invasion, and no relation to risks of carcinogenic transformation. Therefore, today, its oncoprotective, uncompromising nature is obvious. And most importantly, this molecule is being considered as a special form of selective modulator, even when the gold standard of adjuvant therapy for breast cancer is ineffective. I remind you the gold standard is tamoxifen. Phase 3 studies by oncologists will be completed next year in Russian Federation, and we're eagerly awaiting their results. And now we discussed contraceptive described in the current instructions, which has a clear indications, contraception with personalized advantages for breast tissue. So what is known to us? There is another group of patients related to low compliance due to mastalgia risks when using any combinations. Let me remind you that the FREEDOM study demonstrated the absence of newly arising mastalgia de novo, when using this contraceptive, because the risk of adverse effects from the breast did not exceed even 1.5%. Our foreign colleagues came to the same conclusion. A study led by Professor Dan showed that the highest frequency of nostalgia was on ethanol estradiol plus cyproten acetate, and significantly low, almost twice, on estetrol. And the mechanism is obvious, not only due to the estetrol's anti-estrogen effect, but also due to drospirenone in its composition and its anti-mineral corticoid activity. And let me remind you that since drospirenone is derived from 17-alpha spironolactone, its anti-mineral corticoid activity is almost 8 times higher. At the same time, foreign experts clearly speak about esterol's favorable profile for breast tissue. And here at KARM, we have another friend, Professor Kiselova. Probably she hears my presentation, Professor Kiselova, who also participated in this project under academician Odintsov, where real-world clinical practice showed significant reduction of nostalgia intensity. During observation in patients with benign breast disease and nostalgia, its intensity decreased almost 6 times during the first 3 months, with full homological compensation by 6 and 12 months. More importantly, according to structural functional breast assessment, duct ectasia decreased almost twofold. The number of cystic transformation areas decreased 3.5 times, and cyst under 5 millimeters decreased 4.5 times. Thus, high compliance with this contraceptive was due to contraceptive reliability and the need for its prolongation. Most importantly, its improved quality of life in patients with nostalgia and without nostalgia, and a positive influence was established on breast morphology group. Research under Professor Selikova in Volgograd reached the same conclusion, where mastodynia intensity decreased on estetrol and cyst size decreased in benign breast disease patients. Similar results were presented by colleagues from the south of Russia under Professor Karakalis. Let me conclude by reminding you again, dear esteemed colleagues, the use of combined oral contraceptive is not a risk factor for benign breast disease nor breast cancer. Today, protective efforts are obvious for reducing the risk of ovarian cancer, endometrial cancer, and colorectal cancer. And the most important new result, the new one, is estetrol today has the lowest risk of thrombosis. This is indicated by the 2025 meta-analysis, because thrombosis risk with estetrol is comparable to progestin-only contraception, meaning without estrogen. One manifestation of cyclic nostalgia within PMS is directly related to personalized advantages of the estrogen component. The main document defines an individualized tactic which determines our actions today in the area of preventive and personalized medicine. Today, estetrol represents a premium contraception for preserving reproductive health, improving quality of life for women requiring reliable contraception, and is acceptable, favorable option for women with benign breast disease, including mastalgia. I thank you for your attention.
Thank you very much, our distinguished Dr. Orazov. We really hope that you'll be here with us in person next time. Thank you to the company who's supported us, Gideon Richter. They have truly a new drug now. Thank you for supporting KARM and for the opportunity to listen to such a speaker. Distinguished colleagues, we continue. Allow me to present the next speaker, which is Zuev, Vladimir Zuev, Doctor of Medical Sciences from the Sechin University of Obstetrics and Gynecology, Reproductive Health Clinic, Modern Laser Technologies in the Treatment of Female Infertility. I can add to that Dr. Zuev also works at the Art Echo Clinic, and we have a breadth of experience of the most complicated women with difficult pathologies. I mean, he's going to tell us in more detail, but I can tell you that this is our joint work together, and very nice for me to see you here. Good day, distinguished Presidium. Dear Professor Lokshin, I want to thank you personally for the invitation to participate, for passing me the floor. I personally thank you. It's a big honor for me to participate in this Congress, the organizational part also. Thank you. Now let's move on to our subject. Since we are here to talk about the history of laser use in medicine, I have to remember the founders of the lasers. These are Soviet scientists, Prokhorov, Basov, and the creator of the first University of Surgery, Professor Skobelkin. Why we decided to start using a laser? Because it allows us to change the tactic of how we treat and how we see reproduction and reproductive medicine, because it pretty much participates in all the stages. First, diagnostics. We can diagnose the endometrium within 2 minutes. Correlation with regular methods is 98%. Because all the other forms of infertility are excluded, then the question is, since we need to transfer the embryo, which was already tested, and by all laws it should be implanted and should start the pregnancy. However, it doesn't happen that way, unfortunately. And the pathogenetical mechanism, everybody knows very well. Pathogenic mechanism, the hypoatrophic endometrium. We talked about different reasons, the chronic endometrial hypoxia. So thin endometrium, you can call it different ways, but it's the same thing. The causes of the endometrial insufficiency is endometrial hypertrophy and atrophy of non-inflammatory origin. It's an endometrial dysfunction. Here's Professor Podyazhina. Back in 1963, she published the book of Issues of Diagnosis and Prevention of Fatal Disorders, where she clearly states that endometrial hypoxia will have a significant impact on either not starting pregnancy or pregnancy starting, in having a stillborn, and different complications, and for the placenta. You know very well the research methods, diagnostics methods. I'd like to talk about number 5, spectral analysis of the optical biopsy of endometrial tissue. What allows us to do is to determine the tissue oxygenation level. Second is to register the cellular proliferative activity. Third is to monitor the cellular and tissue changes, and that's basically the individual assessment of treatment effectiveness. And one more thing is the structure. So here we have the spectral characteristics of the physiological and abnormal patterns of the endometrium, the norm, and the spectral correlation, chronic endometritis, and a spectral correlation. Here we see this picture of diagnosing endometritis by increasing the level of protoporphyrin 9. Here we're seeing the atrophic endometrium, or hypoxia, and normal endometrium is very different. So here is the spectral and hysteroscopic appearance of the endometrium, atrophic endometrium, the hysteroscopic findings, and the innovations in office hysteroscopy. This is the trophoscope. I know that Dr. Lakshin has one like that. Its diameter is 2.2 millimeters, and we have an operating sheath, and it there easily fits the 200 micron fiber, which can be used to make the most serious intrauterine surgical things. So why do we use it? Because it's the most accurate, and it's the most accurate, careful, and safe, because its permeating ability is not above 30 microns. And see, with bipolar electrode, and the minimum zone of necrosis if you have the scolmial laser. So what are we doing here? We've done the diagnosing, but that's not enough. We also have to take measures to increase the effectiveness of implantations and the birth and the pregnancy rate. So we're using intrauterine laser treatment photosensitizer molecules. These are photoluminescent spectra, and it's shown that the American ones are 150 times weaker than the Russian ones. The English ones are 60 times weaker. So why are they, what is the scheme of pattern of rehabilitation? So the women take the drugs orally, they accumulate in the tissue, including in the endometrium, and we can monitor and look at how it accumulates. As soon as it happens, we activate the chlorophyllin-containing medication within the uterus, thus activating the process similar to photosynthesis. And another active thing we do is the antimicrobial action, because after 48 hours you see that these colonies disappear. So with no antibiotics, we get an antimicrobial effect. The expression of receptors before treatment and after treatment, progesterone and estrogen. And you can see that there's a migration of receptors taking place in regards to the glands. And here I'd like to give you a clinical example. It's a young woman, 28 years old, one nodule posteriorly in the uterus. So they say she should do emboli. They do it in 2 years. They do laparoscopy regular way. The myomatose node is removed, and she comes because her menstruation is done in 2 hours, spot bleeding, so-called. So we were doing the course of rehabilitation for her, and in 2014, spontaneous pregnancy. Now look, this is her uterus. This is the fibrosis, and there's no endometrium. This is her spectral picture before the rehabilitation, and this is spectral picture after rehabilitation. You see a great difference here. This is the picture that reminds us of the previous slide, the endometrium, which is ready for implantation. And this is the decreased blood flow, almost no blood flow in the basal and spiral arteries, and this is what we see after the treatment. And you know, where did these vessels come from? They weren't there before, and the result of that was spontaneous pregnancy. And the story is such that 37 weeks in, the waters went, needed C-section, and one more important thing is that during the C-section, the placenta separated easily, and which we weren't even hoping for. And the clinical example number 2, this one is a 38-year-old female patient, also uterine fibroids, 2 myomatous nodes. This is very bad, right? I mean, it's just 10 by 9 millimeters. So they do uterine artery embolization, and they, at the same time, did the emboli of the left ovarian artery, so one artery gone. One ovary gone, and then spontaneous pregnancy again, and this is the ultrasound image. Where's the endometrium here? I don't think you can really see it there. And clear fibrosis of the myometrium. And here's what we had at the cesarean section. The patient almost, the opening, there's no endometrium there, almost no myometrium. This is the same picture, very similar, but this is 9 months after the surgery, the uterus. And to finalize, I'd like to say that hypoxia and ischemia of the endometrium is it has a big role in changing the structure of the endometrium. They talked about different ways of diagnosing and different pathogenetic mechanisms, but hypoxia is a principally important one for the recovery. And when you remove the hypoxia, you will restore the function and the number of pregnancies. Like in the Art Echo Clinic, from scratch, we took it up to 60.2% of pregnancies. It's true that not everybody reached the final stage, the finish line, but the fact that regeneration of the endometrium is taking place and it's restoring its function. Thank you for listening. I've stuck within my time limit. Thank you very much, Dr. Vadim, for sticking within the time limit. And I'd like to add to what I already said before. At the start of your speech, that we had this absolutely unexpected situation with one of my patients who had already cryopreserved donor egg cell oocytes, and she was sent to Dr. Vadim. She was 41 years old, and thanks to this treatment, we've activated the ovaries, and those follicles that are still there. I mean, she got pregnant on her own, so this is magic that happens, which we're very glad about, and I really recommend to use these kind of treatment methods. Thank you. With pleasure presenting the next speaker, candidate of medical sciences, reproduction specialist, chief doctor of the clinic of GGS, GMC consultant, Tbilisi, Georgia, with her presentation, correction of the uterine microflora and transfer of the embryo with patients with repeated unsuccessful implantations. Good day, dear colleagues. I think I'm coming here every year, and I'm doing that with great pleasure. And you know why? Because first of all, it's my friends, my dear colleagues. And second, the level of the KARM conference is global level nowadays, and I'm always here with pleasure. So thank you to everyone for that. Today, I'm going to talk about the unsuccessful implantations in my, I don't have any conflict of interest disclosures in the methods that I'm going to talk about. This is just our scientific work of one of my students who very soon there will be approbation of that, and I wanted to just share our results, so I don't have any conflict of interest here. So why do we talk about repeated unsuccessful implantations so often? We talk a lot about that because what we have to know when we have to change drastically our tactic for treating infertility. So it's that point when we have to really change something. And when we talk about repeated unsuccessful implantations, right? When with genetically confirmed status of the embryo, when we twice transferred an euploidal embryo, what's wrong? Why isn't pregnancy coming? If we don't know the status of the embryo, there are situations when we don't do genetic testing. And so after 3 unsuccessful implantations, to 39 years old, after 4, and if it's over 40, then after 6 unsuccessful implantations, because then it will depend on age. And So this is the slide everybody knows. So we've learned how to make pre-implantation genetic testing. Yes, the more we do it, the more debate, the more for and against. I remember 15 years ago, I was speaking from a big stage with geneticists saying that we're getting an 80% result. The more we started doing it, the less the result we started getting. And have we thought that studying the embryo is our all, but from the third attempt of transferring a euploid embryo, we're getting a pregnancy with 60% chance, 60, 65%, 35% of the embryos don't get implanted. So we are told and we understand that our all is the good quality of embryos, and a good embryo can even do an extrauterine attachment when we talk about extrauterine pregnancy. But when we have a euploid embryo, what do? What are we left with? We can't do anything. We just can select embryo. We can't improve the quality of the embryo, and what's left is we need to understand what's up with the uterus. And our session is about the uterus today, and I wanted to tell you these are the measures we're taking now. Evidence-based medicine is saying to us nothing is working. You know, when back in 2019 our group of experts was writing clinical recommendations on ART, we were given the task to write a chapter about unsuccessful implantations. And you know, unsuccessful implantations in our clinical ART recommendations, that chapter didn't make it because with nobody could say accurately A or B. You know, it doesn't. None of these methods work, and if it's standard, then we have to write tested methods there, the proven methods. But when patients have had 4, 5, or 7 transfers, we have to look for something to make the next attempt better, and it's already very confusing in medicine in terms of the microbiome, and we started focusing on that too. And all our lives we thought that the uterus was sterile. Turns out it's not. And the microbiome of the uterus has bacteria, phages, viruses, and mushrooms, and fungi in there, metabolites. And when we talk about the comparison of the microbiome of the uterus and the vagina, these are completely different microflora. And you can see, using the NGC method, comparing the microbiome of the uterus and the vagina, we can see different pathogenic flora and lactobacilla. What's interesting for me, what was interesting when I was preparing this presentation, so if we talk about the microbiome of the placenta, generally, turned out that the placenta of a pregnant woman contains the same kind of microbiome that she has in her mouth, and absolutely identical microflora in the gut of the fetus. And it's not about the uterus, but I wanted to focus on the stage of when a pregnant woman is preparing for the embryo transfer. You have this dissemination of all the infection, including from the mouth. So the microbiome of the uterus, normally it should be more than 90% lactobacilla. Different type of lactobacilla, which I will demonstrate later, and all of the other 10% can be things like pathogenic flora. There's a lot of research with the biggest ones I'm going to present to you today. This uterine dysbiosis will lead to more cytokines that will damage the integrity and will hinder successful implantation. Staphylococcus, chlamydia, Gardnerella, and all of that can alter chances of implantation. And so the reasons are retrograde spread through the fallopian tubes, impaired intestinal permeability, and there's different methods of telling when the implantation window is, the microbiome of the uterus, but I wanted to focus more today on those methods that give us better performance and better results, which are method of the metagenomic analysis of the endometrium, and we can clearly understand whether we're dealing with the uterine microflora or are we dealing with a microflora of the cervix, because all of these standard methods of ours of how we detect, right, and I see female flora a lot identifying PCRs in bacteriology. So when we go through the cervix, we have a very high contamination level. No matter which method we use, it's a high level of contamination, and we cannot differentiate whether this is a cervical flora or is this within the uterine flora. So all of these genetic methods, they allow us to clearly separate and say that, which flora we're dealing with.
So this is quite a well-known work of Spanish Morena, which have shown, this is clear, you can see. First is the microflora of a normal uterus, where a woman does not suffer from infertility or recurrent pregnancy loss. And blue is the lactobacil level. In the middle is recurrent pregnancy loss, less lactobacills, and you can see the number of Gardner, which seems to be neutral. And then you see the RIF woman. So what's important is to determine the implantation window, and the uterus microbiome disorders and failures of implantation, they correlate. So implantation window, depending on what cycle we are taking, normal cycle or stimulated cycle, the window may slide to the left or to the right. Also, we wanted to focus on the methods for the research of implantation window. We have used area test, and there are a lot of publications, pro and con, but mostly there are con, that mostly they are pro, and that we're going to show this, the implantation window slide. Depending on age, the implantation window is elongated. Whether the woman has uterine myoma or hyperstringent, the window is also moved. We had a research, 107 patients. We've stratified them in two groups. The first group, there was a diagnostics of uterine microbiome, and second group had pre-implantation PGTA, but did not have gut microbiome test or implantation window test. So criteria to include, we have taken window women according to the precast clinical recommendations. Endometrial thickness should not be thin, reproductive age 27 to 40. So women that should not have reasons for the implantation failure. Average age was 37, and the number of failures should be at least 4. It's quite difficult patients, and almost all of them had failures more than 4. So what we received on the uterine microflora, that was a severe decrease for 33%. For the first group, we have not diagnosed them, and we received dysbiosis for 26%. It's quite a serious percentage for this group of patients. What we received in a group of patients with adenomyosis and chronic endometritis, we received dysbiosis of the uterus And chronic endometritis, this was an important factor that we do not pay attention to. And there are some doctors who are supporting this, and we need to accept this diagnosis, because in the usual population, for women that do not have infertility, it's 10 to 12%, and we don't know this. And for women with implantation failure, with recurrent pregnancy loss, endometritis is for 45–50% of cases. So it's an important issue which we need to discuss. Our data that during chronic endometritis it correlates with non-receptive endometrium, and it's based on literature data of 12 studies. Quite a good work was done with a similar outcomes. Chronic endometritis, if there were any uterine manipulations, polyps. When we looked at the pregnancy rate for the first group where we've done PGD diagnostics, we had quite a high probability, some 80%. And we have calculated this data 3 times, and probably we were taking the quite favorable group of patients, so that's why this outcomes match. And in the PGTA group, it's an orange group where uterine was not diagnosed. The result was maximum 50%. What's interesting for the practicing doctors, with the chronic endometritis, the implantation window has shifted by 18 hours. So if we do transfer after 120 hours, in this group of patients with chronic endometritis, we've done transfer 18 hours later. In routine practice, we do that maximum on the 6th or 7th day. Well, but we won't do the transfer without reasons. In this group of patients, we received the result because we've moved the implantation window. Chronic endometritis leads to implantation failures. This is the literature data which corresponds with our data. And during adenomyosis, we receive the same factors, we see same data. In addition to pro-inflammatory cytokines, we have such indications. We have histogen resistance, and that was the biggest problem, that in addition to increasing the day of implantation, we were also increasing the hormonal dosage or using synthetic histogens which are stronger than micronized progesterone. And the conclusions, these methods determining the microflora or receptivity of endometrium cannot be used in routine practice. There is no need. But when there are patients and the medicine may say that it does not work, it depends what kind of group of patients we take for such studies. If we take such a complex group, as in our research, adenomyosis, probably these methods improves our outcomes. So we need to use, for certain group of patients, use personalized approaches, and this really works. And just one announcement: we invite everyone. In March in Italy, we're going to have a congress on gynecological endocrinology, and our Association of Oncofertility is going to have a big session. And since they give us this session, if you are coming through us, then they are giving us big discounts. So we invite you to be there together. Thank you for your attention. Thank you for this interesting presentation, Dr. Shamugia. If there are any questions to the speaker, if I may ask you, I have one question. So if you find Gardnerella, do you prescribe any treatment before the transfer? If there is endometritis? No, if you find some pathogenic flora in the uterine cavity, what do you attempt? For that, we are making the assay, and the ERA test is one of the methods of determining endometrium receptivity. When they do MLA test for microflora, and this laboratory gives us the sensitivity of how to treat these patients. And in the analysis, when we get the result, MLA or LA test, they prescribe which drugs have sensitivity. And mostly important, when we treat this, these are not antibiotics, but these are antibiotics plus probiotics. And at least for a month, they use probiotics. And in our research, they were taking orally for a month after antibiotics, and vaginally 10 days lactobacteria. Thank you so much. A question there. Inaudible, no mic. Thank you, good question. If we talk about the methods that were introduced, is here MLS test. When using genetic methods, we determine uterine microbiome. They prescribe to us for the sensitivity, and depending on the microbe determined, Gardnerellose, we treat them with antibiotics and the medicine most frequently. And if there is dysbiosis, we prescribe antibiotics plus probiotics. It's quite a costly method. The main criteria for antibacterial therapy is chronic endometritis. The main marker for chronic endometritis is CD138. If using immune histochemical method, we are getting chronic endometritis, we prescribe antibiotics. It's a golden standard. And this was prescribed in Russian guidelines for 2 weeks. If we get endometritis, we prescribe treatment plus probiotics. Thank you so much. Very interesting. Now let me introduce the next speaker, Vadim Polomiskov, Deputy General Director of IRM Clinic Network, Head of Department, IRM Research Institute, obstetrician gynecologist of the highest category, PhD, analysis of luteal phase support, diagnostics, criteria and correction methods. Dear colleagues, I'm happy to see you. I see that the audience is almost full, and continuing how to improve implantation opportunities, we have our presentation. Personalized luteal phase support in IVF and XVII protocols. We're going to talk about luteal phase and what can be done to improve endometrium receptivity while using certain treatment approaches. This is our research. We have started this in June, and we're still continuing this for several months, and then we'll have our final results. Today we'd like to introduce to you preliminary results of our study. Why do we need hormonal support of the luteal phase? The factors that affect the effectiveness of IVF programs are uncontrollable factors, age, ovarian reserve, presence of somatic and gynecological pathologies, race, and sperm parameters. Controllable factors is the number of embryos transferred, stimulation protocols and drug doses, endometrial condition, preconception preparation, luteal phase support options, conducting embryo stage, and qualification of doctors. That is quite important, of course. Why hormonal support is necessary for the luteal phase? Causes of impaired progesterone production is using GnRH agonist and antagonist to prevent the parasitic LH surge, high concentration of estradiol and progesterone, which inhibit production of LH through negative feedback, and aspiration of granulosa cells during follicular puncture. Progesterone supplementation is important during the period between the disappearance of exogenous HCG administered to stimulate LH surge and the rise of endogenous HCG during early implantation. Start of taking preparation is within 48 hours or 96 hours after puncture did not show any difference in pregnancy rates. Addition of GnRH agonist to vaginal progesterone showed a significant benefit in terms of live birth. Taking progesterone supplements in any form is more effective than placebo. Estrogen drugs have shown no benefits, and HCG appears to improve live birth rates. However, the results were mostly based on older, smaller studies. After embryo transfer, the patient is recommended to take progesterone or dydrogesterone. Duration of their use in case of pregnancy is determined by the physician according to the instructions for use, depending on the pregnancy course and patient's medical history, but usually lasts up to 12 weeks. The forms of using this progesterone are 50 milligrams intramuscular progesterone once a day, or 25 milligrams subcutaneous progesterone, 90 milligrams vaginal gel once daily, 60 milligrams micronized progesterone, split it into 3 times, and using progesterone should be continued at least until a pregnancy test is performed. Why progesterone is necessary? It has local effect, decidual transformation, tocolytic effect, paracrine regulation of local estradiol activity, and systematic effect is based on immunomodulatory effect, increased pain threshold, neuroprotective, antidepressant, regulation of vascular endothelial function, regulation of the volume of fat and muscle tissue, glycemic levels, enhanced effect of thyroid hormones, and regulation of water electrolyte balance and diuresis. This research shows how our colleagues in US work. They issue progesterone 50 milligrams intramuscular in the evening after follicular puncture and up to 10 weeks of pregnancy. Progesterone dose can be adjusted up to 75 milligrams per day intramuscularly, achieving a level of 20 nanograms per ml. Estradiol 0.1 mg transdermally is added, and the dosage is adjusted of estradiol to 0.4 or oral estradiol to maintain serum estradiol levels more than 200 picograms per ml. Recalling our early days, we had the same approach. We were also administering and trying to administer intramuscular progesterone. What we had some complications when it wasn't heated, not necessary needle, and I remember those abscesses because those oil solutions they had serious impact. We had some audits because of this. And since those old ages, we were afraid to prescribe progesterone as a oily solution. So that's why in our presentation we're going to show how we can replace this preparation with a more successful one which gives no complications. Why progesterone is necessary? Because there is a vaginal progesterone support for luteal phase is insufficient for 3-4 patients, for each third or fourth patient. And many studies, Jardine, 37%, Labarta, 25%, Alvarez have shown 38.8%. And even when introducing a large dosage of the preparation does not increase the level of serum progesterone. And in 2014, there was a study which have shown that the vaginal epithelium absorption does not allow to absorb vaginal progesterone to the extent to support luteal phase fully for some patients.
And we've set an aim for ourselves, and the aim was to evaluate the effectiveness of an aqueous solution of progesterone in groups with normal and low progesterone levels 1 day before the embryo transfer in HRT cycles, natural and modified cycle, in comparison with a group of patients receiving only progesterone with vaginal administration. The design of the study, we randomized 353 patients. We had 4 clinics working, 2 in Almaty, 1 in Shymkent, 1 in Astana. We still continue the work, as I said, and we continue these studies. They're interim studies, but there are already certain conclusions that we will try to get to you today. What were the inclusion criteria? Transfer of 1 frozen embryo in HRT in cycles, in natural cycles, progesterone level below 1 nanogram per milliliter in the trigger day, the progesterone level more than 4 nanograms by millimeter 1 day before the embryo transfer, patients aged under 49 years old with adequate endometrium of 7 to 14 millimeters. Exclusion criteria, we've removed the patients who had progesterone levels 1 day before the embryo transfer less than 4, the presence of severe infertility factors such as endometriosis, stage 3 and 4, uterine malformations, and transfer of more than 1 embryo. And we also set into our inclusion criteria BMI of above 35. All patients, depending on their progesterone level and the type of LF support, were in 3 groups. In this case, each group was divided into 3 subgroups by age and 2 subgroups depending on the dosage of vaginal progesterone. In the first group, we included those who had a progesterone level before the embryo transfer of more than 10, and they were getting a vaginal progesterone 600 to 800 milligrams per day. The age groups were under 35, 36 to 40, and 41 and over in all groups. In the second group, we included those who had good progesterone, good serum progesterone at the time of the study. It was more than 10, but they had burdened history. And we just heard from a message before me that chronic endometritis creates a problem, and endometriosis, even of the first stage, that you need to postpone the implantation 18 hours forward. Why is that? Because this endometrium is not receptive, and we've included into this group our aqueous progesterone solution in spite of us seeing normal progesterone in the serum. Still, with this group of patients with this burdened history who had certain diseases, we've included also the aqueous and subcutaneous progesterone. And the third group is our group where we also do the vaginal progesterone, but for these patients, we also prescribe subcutaneous aqueous progesterone, 25 milligrams per day of progesterone, but we're seeing with them a significant reduction of progesterone before the embryo transfer. So the research indicators, the key indicators were the HCG test 14 days after the embryo transfer, clinical pregnancy frequency 4 weeks post-embryo transfer, and frequency of continuing pregnancy, determination of progesterone 1 day before embryo transfer, determination on the day of embryo transfer, additional determination of progesterone according to indications, which is discharge from the genital tract, additional indicators miscarriage rate before 12 weeks, and frequency of adverse events, all reported and unreported adverse events. So now to the results of our study. The study, as I said, involved 353 cases to who we prescribed the first and the second group. They weren't very equal. One, we had 155, then 89 and 109 patients in the groups, but those were just the actual numbers. The age, as I said, there were more of those under 35, and what we got as a result of the study, we divided the groups of patients who had embryo transfer at day 5 and 6. About 81% were at day 5, and it was just 19% who had embryo transfer at day 6. And embryo quality. The embryo quality was quite high. Average was 60%, and we also PGTA tested the patients, and there were some unexamined patients, 58.6%. So what we had as the result. In group 1, which received only vaginal progesterone, 65% had a positive HCG test. And the best results were observed in subgroup 1AA, where the age was under 35 years. And moreover, in the subgroups of patients 1AC and 1BC, over 41 years old, despite the progesterone level on the day of before the embryo transfer being over 10, we saw lower effectiveness, which was 50% and 58%. Possibly these patients might need adjustments of their luteal phase to get better results. In the second group, which received combined hormonal support, where we gave aqueous progesterone, the positive HCG was 70%. And the best indicators were in the oldest age groups, but the number of patients there wasn't that many, so the numbers aren't very correct. And in the third group, we included the patients with progesterone below 10 at the time of embryo transfer and receiving combined hormonal support, which is vaginal and aqueous progesterone. In this subgroup, the rescue protocol was applied, which allowed achieving the highest results despite the low progesterone level on the day of the embryo transfer. The positive HCG test results were 80%. In the second and third groups, which received the combined hormonal support, the vaginal and water progesterone, the most noted high HCG results were 70% in group 2 and 80% in group 3. Moreover, the results in older age groups and subgroups are comparable to the results in patients of a younger age. And currently, the study is ongoing, and we've processed the results for the HCG test. Unfortunately, only that criteria now. Data on other indicators, such as the clinical pregnancy rate and ongoing pregnancy rate, are being analyzed. However, already at this point, preliminary data show a direct correlation between the duration of combined hormonal support, the vaginal and aqueous progesterone, and the positive results of the IVF and ICSI programs. And thus, the following conclusions can be made from our study. First is using a combination of vaginal and aqueous progesterone in the luteal phase allows for better results in terms of HCG test, 5% in group 2 and 15% in group 3. The results were higher versus group 1. where they only had vaginal progesterone used. The use of an aqueous solution of progesterone allows for a significant improvement in results in older age groups, in the 41 and over group and in the 36 to 40-year group, and they're comparable to the results in the group which is below 35 years old. And the rescue protocol is the protocol of choice for patients with low progesterone levels. A direct correlation has been observed between the duration of administration of aqueous progesterone solution and the rate of pregnancy loss, which provides grounds for combined hormonal support, vaginal injectable progesterone for 12 weeks, according to previous studies and instructions for use. The longer the course of administration, the higher the ongoing pregnancy rate. When choosing the method, dose, and duration of hormonal support, it's necessary to take into account all risk factors of luteal phase insufficiency, BMI, age, the burden medical history, the low progesterone, and the unsuccessful IVF attempts in the past. And the practical significance for IRM clinics: in all IRM clinics, an aqueous injection solution of progesterone is included in the SOPs. We made it like a law which mandates their doctors to use this medication in their daily practice. The luteal phase support, both in mono and combination with vaginal progesterone. In all IRM clinics, we recommend monitoring of progesterone levels 1 day before the embryo transfer. It's like a law as well. And due to the virtual absence of side effects from subcutaneous administration of aqueous injection progesterone, it's recommended to replace the oil solution with an aqueous one. In all IRM clinics, we've implemented the rescue protocol for all patients with P4 levels below 10. And for patients with a complicated obstetric history and successful attempts of IVF, it's recommended to correct the hormonal support with luteal phase support and with an aqueous solution of progesterone. And thus, already now, we practically have implemented the idea of improving the performance of programs with a low serum progesterone. And just recently, we've been to Spain. That was last year. It wasn't that recent. So we saw this work that was done by our Spanish colleagues. Apart from Labarda, there were also 3 other studies which have clearly shown a decrease in the results of achieving pregnancy in the second group with the burden history, and those who had to use the rescue protocol. So that kind of correlates with the international studies, and nowadays we're successfully using these methods. Hopefully we'll get you to know the actual results of the study, and we'll give recommendations to our colleagues from the other clinics. Thank you very much, Dr. Vadim. I have a question to you, a small question. So if you could tell us, after the transfer, are you monitoring the progesterone levels? After the transfer, no, you've done the transfer, do you monitor? How often? After the transfer, the level of progesterone. Yes, look, I've made a comment, only by indication. So what are the indications if you don't have pregnancy? So the level of progesterone we tested before the transfer, we tested on the day of the embryo transfer. If we see that it's enough, the level is sufficient, we don't really recheck it anymore in follow-up. But if there is some threat of termination of pregnancy, or if there's some blood discharge, only in that case we do an additional test. We don't do it routinely throughout the this 12 weeks, the level of progesterone. And so our colleagues from Yekaterinburg, they actually made this type of research where they had 300 cases. There was this presentation last year, and none of the women had bloody discharge when using the subcutaneous progesterone. So that's, although there is, I apologize, let me interrupt you, we're out of time. I remember that 1 year ago in this same room, Professor Griesinger was speaking, and back in his time, he was championing aqueous progesterone. But in this room 1 year ago, he said that the aqueous progesterone works worse than the oil-based one. And I very much remember that, because in my work, I shifted from aqueous to oil because I'm monitoring the level of progesterone after transfer, and I'm seeing that the level starts to drop. Not necessarily blood discharge, you just don't get pregnant. You have great results. I have nothing against that. But there's a fact like that. In the aqueous, progesterone is not a cure-all. You just have to know how to do the oil, and then you have results. Of course, you can do oil as well. Besides, the price of aqueous is much higher than the oil-based one. We've eaten enough of this oil progesterone 30 years ago. I was prescribing it for 5 years in a row, right? And these complications that would come up, especially with those who we had to do the injections for outside of our institution, where they did it and how they did it. I mean, I don't know, but these complications were all over the place. And so, I don't know, maybe it's like you don't have any complications, but we did have them. And honestly speaking, I have no more desire to ever use it again. Thank you very much. Wonderful presentation, wonderful message. Maybe there's more questions in the room. And then she can say, you know, like when I was using Dufastone with uterogestan, my HCG was positive. But before that, I was doing 3 times. I was taking like injections and oil and aqueous, and it was negative. So like, I want it that way. Do you then not prescribe it? I can tell my experience. I prescribe progesterone injectable to all my patients. But it depends on the progesterone level initially, before the transfer and during the monitoring, because 2 or 3 times in the post-transfer period we follow up the progesterone levels. And if I see that it's dropping, the thing is that oil-based progesterone has a accumulated effect, and its action is stronger. So when they're allergic, when they cannot inject, and we don't have another choice, and we do aqueous. But that's my experience. And at IRM, well, look, actually, we participated in this big work that Abbott was doing, and we researched the action of oral progesterone. And we, honestly speaking, we've demonstrated our results. We don't have a negative opinion about the drug. I mean, we don't believe it necessary that somebody, you know, with a certain individual sensitivity or a certain experience of using the drug to stop using it. We don't have like a fixation against that, and the doctor can prescribe oral and can do support using oral, the oral form. So we don't have a clear concept that no, you can't do that. And it's we're using pretty successfully all of them. But the dominating one is vaginal progesterone. And in the cases when we don't see enough serum progesterone, we prescribe the aqueous one, which gives us good effect. Although you could do oil probably as well, but sorry, we are out of time for the session. A very interesting message, and we've touched upon a very interesting topic today, and hopefully this session gave us some additional knowledge about how to follow up our patients in a post-transfer period. Thank you. Next session, no break. Oh, there is a break.
Там на табличке.
сказала, что да, действительно.
You are treating Gardnerellose, but you are obstetricians, and that you were eye rolling because back vaginose is not called Gardnerellose, it's called biofilm syndrome, and it is proved that biofilm syndrome is transmitted. And the project at the reproductive medicine, together with Professor Vedzinski, whose Hirsch index is more than 40, together with Alevtina Savicheva, we were discussing this problem because biofilm syndrome is not diagnosed. And you asked about antibacterial therapy. You cannot treat it because it would be biofilm syndrome, and Gardnerella, together with atatobium, would create this biofilm. We are starting a new session. You can have discussion separately. I can argument my words with big research. So I would request to come here our moderators. And let's start our next session. We are going to switch to first presentations because speaker has to fly. So I thank Professor Vartanyan for being willing to change with the first speaker. So Professor Vinitadze will be the first speaker, my compatriot, a very famous doctor, reproductologist, general director of one of the clinics. He is a reproductologist, laparoscopist, a person of the world, a person of happiness. That is his title, and I can confirm this. He is a sculptor, an artist. He is making his pictures and making sculptures himself. Hello, everyone. I welcome you all. And I thank Professor for giving me this chance to present. Of course, I understand that you are without a break, so I thank you, and I would try to be on time and to save some time for life and for some questions or discussion. I am presenting a topic which is quite simple, is to do the anatomical abnormalities for women with 2 or more recurrent pregnancy loss. So for women that have RPL, recurrent pregnancy loss, they suffer much more. They are pregnant 2, 3, 4, sometimes 8, 11 times, sometimes 11, 18 times, and they lose their pregnancy. So they cannot be happy when they're pregnant because then they have a different fear. And one of the reasons of RPL, recurrent pregnancy loss, is the anatomical reason when we find anatomical abnormalities of uterus. Although a woman went to many outlets and she was diagnosed, and before 3D ultrasound, these walls were rarely found. So I'd like to say simply that to cut such walls gives us 50% of live birth. This is the conclusion, but before that, the data that you all know, in a population from 0,1 to 3% of Mullerian dysplasia, for women with infertility is 13.3%, and for the recurrent pregnancy loss, it's from 5 to 25%. This is the classification that you all know. And later we're going to talk about the uterine which have complete septum. As to diagnostics, 15 years ago, 13 years ago, when we were doing our work, professor asked me, "Do you do 3D ultrasound?" I said, "No," and he said, "What you can do during hysteroscopy is subjectively. So you need to have a technology which would allow you to make a good measurement to determine that." Hysterosonography, which was always used and is still used probably, also gives some result. Also 3D ultrasound. You understand this, that you know well that a good machine with good expertise can give you very accurate diagnostics, and even for the patient it's clear when we show this sensitivity of 3D, 4D ultrasound up to 98%, and specificity is up to 99%. If you have good expertise and knowledge of using this machine. Professor Bashiri, this was done 9 years ago in 2016 when we've opened this center, RPL, in Tbilisi, in our clinic. And look, you see how young I am. At that time, we have a private clinic, and during one day we do 3-4 new lives. We have 800 per year, only 43 staff. But when I was buying this expensive machine at that time, back in 2015, this was the first officially certified machine from General Electric. I didn't know what would be the effect, and I thought that I need to do something new, something good. And more than 600 families became happy because we started to diagnose, especially for ultrasound, uterus, septum, doing hysteroscopic plastics. So these are pros and cons for 3D ultrasound. I'm not going to list this. There is a septate uterus with a full and partial septum, and the data which gives us an opportunity to know for the surgeon or a doctor, reproductologist, that to do incision of such septums give us the chance to increase the quality of life for those women and come to the childbirth. There is the biggest meta-analysis, some 2,500 women and some 50% after hysteroscopic metroplasty, the chances are increased for after metroplasty. When to treat? Always or not always? For patients with infertility, 2 or more pregnancy loss, it is recommended to consider metroplasty. For others that have not tried to become pregnant, it is not mandatory. You need to give a chance, and if there is infertility, then you should do this. Of course, the technique of hysteroscopic metroplasty is different. You can do micro scissors, monopolar and bipolar coagulation, electrosurgery. Can you switch on the video? Very small video. Why I am proud of this video? This is 2016, when we have just started, and it is done in one breath without any editing. You can see this, just several seconds. And after this, for this specific woman, she had 6 pregnancy losses. Because you are doctors, you are creating life. You are people who see different patients like this. And in this uterus, there was a child who is now 7 years old. So for 6 times she had a pregnancy loss. Just look, several seconds, and it is ended. And after that, there is more technique. This was one of the first. It's like a history of my life. I like it. This is the end of the surgery. It lasts 10-15 minutes, sometimes more, sometimes less. Have a look where to stop. This is a video again. When we see this pink part, that there is no perforation, it's good when it's done accurately, neatly. There are no problems. It won't be a problem. It's not a difficult surgery. Such simple things, ingeniously, they may give both to doctors and to people, to our patients, they may give happiness to prevent some adhesions and complications. Sometimes we use gel, sometimes not. But I talk to you honestly, within our cases, we had no spikes. Results of our research, we had 205 patients, and RPL 46. There were 2 groups, 25 cases of metroplasty and 10 cases, because not always women agree. And these are the results. Almost like in literature, 18 deliveries, live birth, 90%, and in the group without metroplasty, without surgery, 50% only, so almost two times more. Results are better after metroplasty. Several examples before septoplasty and after septoplasty. So these are different cases, and he was born in 2018, that child. So here I'd like to dwell and gradually end. 8 pregnancy losses. Why I'm showing child face? Because the mother said, 8 times I lost my pregnancy, and I want you to show my child, I am proud that you made this, and I have David. And since she gave her permission, she was happy, and we were happy. We're showing that others, families, to give them joy and hope for this happiness. This is when we opened an association. I'm a president of this association. I'm a doctor, so when I'm facing a patient, I'm a doctor, and I'm proud to be a doctor. So very simple. When we have 2 or more pregnancy losses, we're not waiting for the second pregnancy loss. If we find this, we explain to a woman that if you have a second time loss, we can make this surgery later. But we explain that this is 15 minutes surgery, non-invasive, and on the same day women can go home. Many of them agree. And in that case, you can do neat metroplasty and wait for a good result. Thank you. Happiness to you. And there is no my team. And I tell to you, thank you, and I'd like to thank my team, because every day you are creating life. Every day going to work, you are not gifting or presenting, but you are giving yourself happiness to be a doctor, to be empathic to your patients, and to make yourself and many other families happy. More than 8,258 for 16 years. Thank you for your attention. I understand that after the intrauterine procedures, there are synechi, and we get endometrium pathology. You mentioned that you do not use gel for everyone. In most cases, we introduce gel, but it depends on patients. In case of intrauterine adhesions. And all of them are willing and are ready. Sometimes we did not introduce gel, and I don't know whether I'm happy or lucky, or women were good. We did not do hysteroscopy often, but if we get a good result, this is our victory and our happiness. After how long do you recommend for pregnancy? Wonderful question. The results that were shown after 2 months. We call them back and we look at the uterus. We show them what was our result. And there are very, very few cases when we had to 2 or 3 cases during 16 years when we have done repeated septoplasty. Maybe in 99% of cases we don't need it. And the question, do you prescribe estrogens immediately in order to not to have the failure? Estrogen, yes, of course. It's very simple. We prescribe estrogens after the surgery, and after 2 months, when we see that she is ready, we start to be prepared for the pregnancy. And these are natural pregnancies that I've shown to you. There is no IVF. It's a different group where we apply IVF, but in this case, these are women with natural pregnancies. Thank you so much. A question there. We present on the 2015 the first results. When we have started together and my surgery started under your leadership, and I thank you for that, you don't need to be represented. We all know how you work. We thank you for your input, for your contribution of Georgia by you personally and your clinic. But I'd like to note, you had a question, you had an issue on thin endometrium after hysteroscopy. This is a problem which is discussed by academia, but it depends on who is doing the surgery, what is the technique used, and the question which we often discussed, whether we use this after hysteroscopy or not.
So this blind curettage they used to do before, it's now in history. It's in the past, but there are unfortunately cases when doctors still do that. And the problem of a thin endometrium, you have to deal with that. And this at SGA, this was an acute matter, so we never have to use the curette after gastroscopy. So there's a question recently about whether we just dissect the septum or do we have to take that fibrous layer and dissect that, which is still sometimes remains. Good question, thank you. In the majority of cases, we don't have to. After we dissect, we don't have to I mean, this piece, let's just say surgeons, we're also people, we're also humans. And I always say in my presentations, when something is visible during the surgery and it's not based on atlas, not based on the guideline, you can't really separate whether it's here or not. And what do we do then? How do you act? So I would say if my daughter Maria was there, what I could do with my knowledge and my kindness, that is the only one best decision, and I would never regret it. That's the maximum that I can do, and I'm proud of that. And I add, right, when you see that something is sticking out there, sorry for my slang, you want it to be looking good, although we don't know if it's going to hinder pregnancy or not, but you want to make it beautiful. A surgeon is also a human being, right? So yes, thank you. Thank you, Professor, and saying goodbye to you. Good luck. And the next presentation, I'd like to pass the floor to Doctor of Medical Sciences, Professor of the Medical University named after Pirogov, Emma Avramovna Vartanyan. Good day, distinguished colleagues. It's not my first year being here with you. I always listen with pleasure. It's a very professional congress, and everybody wants to learn more and ask more questions about the topic. For all of us is how to increase the effectiveness of IVF, because we've been doing IVF for many years now. Everybody has a lot of different children born, and the numbers are in thousands already. And I can share my experience a bit, our experience of working, and whether we need pre-pregnancy preparation, whether we need to do a lot of supplements, or do we need evidence-based medicine. I'll try to shed light on that in this brief period of time. No disclosure of potential conflict of interest. And based on the recent data, predictors of success after in vitro fertilization, IVF methods, number of antral follicles, age, BMI, sperm, and usually recently in 2024 in fertility and sterility has started telling us that we have to focus on men as well and their FSH. Look at their FSH. And so here is the data of IVF effectiveness, which were given, which give us the live birth rate. We see that the endocrine factors such as polycystosis and the male factor, they give a very low live birth rate. And we were listening to a lot of causes that lead to these results. And the risk of unsuccessful IVF is determined by the quality of the gametes and embryos and the quality of the endometrium. And also today we have to focus on the immunological reasons with the unsuccessful IVF. That the quality and the number of gametes matter with diseases like that. And we also have to remember that there's a quality of the microenvironment, which then creates those diseases that will produce the quality oocyte and quality embryo. Because we need to clearly know that when folliculogenesis happens in the body, there's gonadotropin dependent forming and gonadotropin independent. In the early stages, these are follicles that are regulated by procrine factors and they are not gonadotropin dependent. And there it all happens thanks to the environment of the stimulatory factors. And just because of many factors, and as a result, it cannot give birth to a healthy oocyte. And with later stages, when there already is a sensitivity and gonadotropin dependency, and the follicles are created, that's where they start to involve those processes where we have endocrine disorders and metabolic syndromes, and they also influence the healthy follicles birth. And we know that recently, looking for ways of restoring these factors is so the secondary messengers are things that influence the signal ways. We know that's myoinositol, which actively influences the FSH signal pathway, and insulin. And very important that these stereoisomers, there's a lot of research on that already, and has shown that the signaling pathways that are involved in the activation of the follicle, the mTOR, and if they're responsible for the immune reactions, the autophages, and they are receiving a lot of attention right now in order for them to be active and to participate in the fundamental processes. And actually, this cascade of the PI3K cascade is initiated by the insulin and the growth factors. And the regulation of the osmotic stress, the regulation of the protein kinase C, the regulation of calcium signaling pathways, that all has a influence over the nuclear function of vesicle transport. We know that's very important. The telomere, the chromatin, and all these enzymes that inositol is part of are the regulators of the intracellular processes. I've presented to you quite a few works which are evidence-based, more than 8 million articles, which show that there's a big role in the maturation of cells in the embryo. That the big role is played by myoinositol. And they also talk in their work about, these are the most recent interesting ones, that oftentimes You have them with such diseases as PCOS, endothelial dysfunction, metabolic syndrome. And there's search underway for human infertility factors as well. And here are more randomized trials. They've been done since 1982. In the most recent ones, 2020 through 2025, they've reactivated and they've showed us the role of inositol in human reproduction. It was a big research in this magazine, Obstetrics and Gynecology, by Pustotina, the professor who has shown the role of inositol in human reproduction. It's restoring the tissue sensitivity to insulin when taking inositol. That is a key link in improving hormonal and metabolic parameters in diseases caused by insulin resistance. And today there will be another presentation on that, her presentation, then you can learn that. And there was clinical efficacy proven of compelling evidence of the effectiveness of inositol in the treatment of polycystic ovary syndrome. Myoinositol has been shown to play a role in the prevention of gestational diabetes mellitus and neural tube defects. For the majority of patients who are prone to insulin resistance throughout the whole pregnancy, we prescribe to them myoinositol. And here's the clinical efficacy of our scientists who have shown that 30% of pregnancies occur on their own, up to 40%, and with 70% they have their own spontaneous ovulation. And there's another study that has shown taking inositol together with folates within 3 months before IVF, they have a positive effect on the oocytes and the pregnancy rate. I'm sorry I don't have time to talk in detail about all the works. And then our scientific research on myoinositol, and these are clinics in this network of 30 clinics. We did our own study, and we've shown that this therapy is effective. We looked at the quality of oocytes and embryos and the results in the pregnancies, and we've gotten very high chances through activating for inositol-dependent proteins, and the results are significantly increased, almost 15-20%. And we also prescribe inositol to all the men when they prepare. We use Inofert Forte, Inofert in powder form, and we also see an increase of the frequency of fertilization with ICSI in the pregnancy and activation, the amount of ejaculation in progressive mobility. And also adding myoinositol increases the oocytes in IVF programs. That's also a big study that was presented in 2025. There's a group of patients who are resistant to any medication, including myoinositol, and the bioavailability. It was seen that when they studied the patients and their flora, and this is to continue the topic that was discussed, there was the most incongruences found. Those who had a problem with the ovarian function, the ovarian dysfunction, infertility, ovarian cancer, menopausal osteoporosis, they all had a problem with the flora. And so here we see to which extent the poor flora, the PCOS gut dysbiosis, and a healthy gut microbiome. And so that's why when adding alpha-lactalbumin, we've increased absorption in the intestines, had antibacterial activity, immunomodulation, stress reduction. In thus, if we use alpha-lactalbumin and folic acid, that's Inofert Forte, it's in capsules once or twice for 2 or 3 months, but we see the results earlier than that as well. What is the concept of the IVF treatment cycle? You have to identify the reasons, somatic diseases, and do some preconception activities, because unsuccessful IVF is because we don't prepare the patients. Infertility is a situation where there's a lot of hidden factors comprehensively, and we need to remember that fertility is not just with women. It has to do with the full couple, women and the man. And we have to do preconception activity. And of course, the support of the luteal phase plays a big role. I think Dr. Vladislav has already presented this. I'm always proud of this slide. We show to which extent we're ahead of the whole planet. We're ahead of Europe for the numbers and the quality, but we don't stop at that. We try to move forward and improve our results. And thus, I believe that in Russia, IVF is at a very high level. And thank you very much for your attention. If you have any questions. Does anybody have questions to Dr. Vartanyan? Well, then I'm off. Thank you very much. Thank you for your interesting presentation. Dear doctors, with great pleasure, I would like to present to you the next speaker, Oksana Shurigina, medical doctor, professor, Department of Reproductive Medicine, Clinical Embryology and Genetics, Samara State Medical University, city of Samara. I'd like to say that Dr. Shurigina is the leading embryologist of the country to who we seek out for all problems and issues, and she's always happy to share with people. Thank you very much. That's very flattering, but it's also putting pressure on me because, first of all, I wanted to thank the organizational committee, scientific committee, for one more good opportunity to be here, present my results, and with a lot of our colleagues, we exchanged that KARM is about science, love, freedom, and an endless friendship. Thank you very much. Now, what I said was absolutely true, because when I was thinking that what I would be presenting at KARM, you always want to show something new, right? And so some time ago, we started our work with the microbiologists, and right now I'm presenting our clinical trial, which we did at the Samara State Medical University, the medical campaign IDK, which is a part of a big holding. I don't have any conflict of interest, and we very clearly know today that based on different data, more than 12 million children born in the world is what ART has produced for us. And we need to say that in spite of all of our efforts, the incidence of miscarriage is 15 to 27%. The incidence of primary miscarriage is also 5 to 27%, and the risk of pregnancy loss increases with each subsequent episode of spontaneous miscarriage. I'm not going to dwell on the unsuccessful implantations in the polyetiology, but I'd like to say that the topic of the microbiome of the body is becoming very relevant, and this is one of the articles that was presented to the scientific community more than 10 years ago, and it's shown that flora is of big importance in organizing all the processes in the body, and the balance there is very important. And we need to say that in clinical embryology, you have some very fantastic changes going on, because whereas before 20 to 24 years ago, we could cultivate only to day 3, well, nowadays there's no questions about prolonged cultivation. It's now not just 6th day, but 7th day. And the best thing is that we have the technology now, this microscopic time lapse, or how you see how they develop using artificial intelligence. And this technology allows us to not just look and assess the morphokinetics of the embryos. It not only allows us to select the embryo, but to see something else that's very important. And we need to say that always for embryologists, it was very important to know whether everything was good with the environment and the embryos that are developing, but then why some embryos stop and some of the embryos just keep going in their development. And thanks to the fact that we now have new technology in our hands, and we have now 545 times Zoom for objects, we can see that there are changes in culture medium during embryo growth, and that's important. And when we see that it's not just the embryo, which is the owner of this environment, there's also other residents in it, then of course the question is they can ejaculate also in oocyte cumulus complex contain infectious agents. We need to say that in 2023 we did the first pilot study, and it was very much random, pretty much like many things just happen randomly in our lives. To my lab came, our clinic, a microbiologist, very talented doctor, Artem Lyamin, and he said, Dr. Oksana, so show me what you've got. And we started looking, and I said, you know, I have questions like this and that, and we started discussing, and we saw that it's true that when the focus changes, with these embryos, there's somebody else living there. And we did the first pilot study, and this first pilot study has shown that working on cultural environments, with some there is microflora, with some of them there isn't. And what was interesting was this Mycelia timone bacteria. And you see it's found when the embryos develop, and in the samples that we took, and where it was found, for us it was for the first time, this mystery. We'd never seen it or heard about it before. But nonetheless, when analyzing literature, for the first time this bacteria was found in 1998. And it has led to encephalitis and meningitis. But we wanted to see, of course, what does that mean for reproductive medicine. And unexpectedly, we found a clinical case that Mycelia timone was the reason of an aseptic abortion. And that has allowed us to think and develop further in this regard. And I can tell you that we've presented our article in the Brazilian Reproductive Medicine Journal for this case. And then in 2024 and 2025, we did a microbiological study with patients with unsuccessful implantations. And we took different objects. So we took a swab of the cervix, sperm after centrifuging, follicular liquid, and spent cultural environments. Now I'm not going to talk about low sperm count. This is still in processing. And let's focus on the swab of the cervix and the spent cultural environment.
So video surveillance embryoscope system. This machine allowed us to make samples, and there was very small amount, less than 1 microliter of volume, and then we've done anaerobe conditions. This material was Vitersed, and then it was submitted to the culture. So we wanted to see if there is MALDI-TOF mass spectrometry. We use this system in order to get bacterial spectrum of the material which is cultured in various biological samples and liquids. This is the study design. We've taken 50 samples of the cervical swabs, 50 samples of follicular liquid, and from 200 areas from 50 patients. We were using fertilization with XVII. And the identified microorganism we have separated in 3 groups: normal microbiome, conditionally pathogenic, and mixed. So the cervical swabs, follicular liquid, showed us that 40% is a mixed flora for patients with recurrent, repeated implantation loss. And we see that in the other cultures we've seen no growth, and there are some lactobacteria, mixed flora, and here it's conditionally pathogenic flora. Here there are higher percentages. It was interesting what are the samples in the cervical and follicular liquid samples. It's Lactobacillus crispatus, normal flora, both in the cervical and in the follicular liquid. And in other microorganisms, you can see that it's matching. When we've seen the correlation, there is such an important trend that if in the women microbiota we see normal fluid, then in the follicular liquid it would be the same. And if it's pathogenic at the cervix, then it would be also pathogenic in the uterus. Cultural cultures. These are patients with previous failures, and the embryos that have stopped in their development. For 44% there was no growth of flora, and in 56% there was a growth. And where embryos continue their development, we haven't seen a growth of culture media, but in 70% it was there. And what was also interesting, that depending on the age, the older the age, the more in culture media we've seen predominance of pathogenic flora, conditionally pathogenic. So in this cultures, we've seen staphylococcus and micrococcus. These are representing normal microflora, but these first three representatives are resistant to gentamicin. And gentamicin is the antibiotics which is used for development of embryos, and that is the subject of our discussion. It was also important to see that Escherichia coli is most often for the tubal factor patients. So here, Aspergillus flavus, which we have also identified, and lately the result of attention in the scientific literature given to this because it makes aflatoxin, which is antagonist to steroid hormones, and this is the often reason for unknown infertility of unknown etiology. The microbiota of cultures, how they depend on certain organisms, and Lactobacillus crispatus, which mostly has protective features, we see that in the worn culture media, it changes and loses its protective features because of the pathogenic flora predominance. So the studies which I present today, they have been published, and there is a clear understanding of specialists. And one of the paradigm was changed, that we are not sterile, and microbiota is an additional organism which lives in us, and we know that it has some applications. And dysbiose, which is related to a lot of antibiotics that we use, using various bacterial agents. The correction of dysbiosis is a delicate matter which may turn positive or negative for women to get this long-term pregnancy, which is of special value to us. And of course, there are facts that are well established, but there are much more questions, because all specialists throughout the world, they say that the test systems are not standardized, that microbiota is an additional part of this dilemma. And the microorganisms that we have identified in the processed cultural media does not mean that they're bad and that embryos stop there. I've shown you that where embryos continue developing, microflora is still there. And perhaps, thanks to some representatives, they are creating microenvironment which allows embryo to live and to develop further. We also know that embryos produce cytokines which participate in implantation. So there are a lot of questions, and finally I can make the following conclusions. Of course, cervical microbiota impacts on the follicular liquid microbiota, impacting the embryo media microbe composition. Microbiota may impact both positively and negatively embryo development in vitro. Determining microbiological profile of the biological material could be additional diagnostical tool to determine infertility reasons, especially for the patients that come to us recurrently and older age patients with multiple implantation failures. And accumulating knowledge and experience allows us to make personified approach to every person. I'd like to thank our team for the infertility treatment. Marat Talgatovich Togushev is present here, our chief doctor, because only when there is a team interaction, when there is communication between academia and real-world practice, because we are based for the medical university, this allows us to make such research. Thank you for your attention. Thank you for this wonderful presentation. And it's always nice when you make such your own data. Please tell us, Professor Shurgina, the follicular liquid, is it sterile? No, we've shown that it's not sterile. We have confirmed this once again using microbiological methods. Tell us, I have an interesting correlation, because we are talking that cervical and uterine microbiome are different. And here, the cervix and follicular liquid, they correlate, right? And what about the uterus? Is it different flora? We do not do uterine microbiome studies. It hasn't been included in this trial because this is the main organ where implantation occurs. But we wanted to see first, prior to transfer, what are the tools and factors that can be influential. Because we don't have data on sperm, because they are quite interesting, and perhaps we need to consider, because there are some couples with multiple implantation failures, they have a single microbiome. And in some cases, when we see implantation failures, it's not all 100%, but we understand clearly that in 10–15%, in some cases, they have serious dysbioma with pathogenic flora predominant. And that is the focus group that we need to have specialized, personalized treatment, so that we could use PGTA embryos to introduce them to the uterine cavity without dysbiosis. And probably it would be nice to look at the newborn intestine. For that, we need to receive a grant. It's quite expensive research, yes, because time-lapse observation and microbiological methods. This is the volume less than 1 microliter. When microbiologists have discussed it with us, the main task was to identify at least something. So we were trying to select the methods to identify, because follicular liquid, we can get a big volume compared to the processed culture media. So our task was to select the methodology, and when we made it, we went into this study. Thank you. Another question? No mic. Only one antibiotic, gentamicin. Why don't you do individual separation of this media, which may ease your life without contamination of your cases? Why don't you do that? Vadim Evgenievich, I had this question before you. First that I have done, I went to Vitrolife company, which provides to us culture media, and I asked them, why is it gentamicin? Because if we are to go into microbiology, the world has changed. With staphylococcus, we went to streptococcus era, and the resistance is quite different. So why don't we change? And they said, well, gentamicin has well proven itself in previous years. I said, wow, everything is changing. And especially after COVID, when microflora has changed. And there is another important issue. And now everything which microbiological agents which surround us, they quickly change their properties and their character. So this resistance which appears is a big problem. In the previous section, we were discussing microbiological films, and that is a big problem now. But we asked this question, I don't know whether the company would react to us. We understand because gentamicin is prohibited, it is banned. When I was studying in the institute, it was said that it's an antibiotic which cannot be used for children because it's autotoxic. And this was a misunderstanding. And then we understood these classics. But that's the situation, and probably we all need to change, as well as the manufacturers. No mic. How you have determined that these are pathogenic microbiome and this is normal? Because at each level they have their own microbiota. How have you determined this? We had a tandem with microbiologists. We were working in one team, and normal microbiota is lactobacteria mostly. The mixed flora or pathogenic, it's where there are, which is clinically important for urogenital tract, because you are giving microbiota, and it could be permissible amount or content without requiring an antibiotic. Well, we're talking about antibiotics because we want to find correlations and why patients with repeated implantation failure, it increases after 35 years, and we understand that it's not always the essence, because sometimes there are issues that we did not pay attention to before, and perhaps it's not in 100% of cases, but for this narrow group of patients, that both for men and women there are serious dysbiose manifestations. For those patients, they need a special treatment, and before they start IVF cycle, they need to be personally treated and not just to give them antibiotic therapy, and then to start a protocol. Thank you so much. Quite pressing presentation, quite a pressing topic. It's quite important because probably later we'll make a correlation with the quality of embryos and frequency of pregnancy, because when there is a hepatitis B or C, we don't know that in the follicular liquid those viruses could be present too. There are some big studies showing that for women where in follicular liquid virus of hepatitis B was identified, their frequency of pregnancy is less, quality of life is less. So I believe that this is quite pressing. There are things to study. Insulin resistance as a key factor impacting ovarial response in the IVF outcomes. Anastasia Rybina, reproductologist in International Clinical Center of Reproductology Persona. We're continuing preconception preparation, and there are some reasons why we give to embryologists, and not only for women and men getting this way of life that impacts the quality of the zygote. I have a conflict of interest. The presentation is prepared under Delta Medical Support. The obesity is a disease. It's a chronic many-factor disease when the fat tissue leads to dysfunction related to the amount of fat, which leads to metabolic and psycho consequences for the health. And this is the statistics of the WHO, where 18% of older population and a lot of children and adolescents, they have obesity. So in future, these are our patients that are going to come to us with different problems.
We know that obesity is not just a cosmetic defect. It's a complex condition which is characterized by multiple systemic complications, since this is fat tissue that undergoes changes, and it emits biological substances that impact the body generally, and you have more risk of cardiovascular disease, and there's higher risk of cancer, and there's implications for the reproductive function, which has to do with a lot of mechanisms, one of them being insulin resistance. Obesity and insulin resistance is 100% correlation. And we also see that in women with polycystosis, even if they're not obese yet. The insulin resistance decreases a peripheral tissue sensitivity, and you have this ovarian paradox. The ovaries don't lose sensitivity to the insulin, and insulin triggers this so-called hyperstimulation of the ovaries, and that will lead to an increase in androgen synthesis, and hyperinsulinemia has to do with oxidative stress everywhere in the body, including the germ cells. And we see a disruption of ovulation and oogenesis as a result, and decreased oocyte quality. And obesity and insulin resistance has an impact not only on the ovaries, but on the endometrium. There's a violation of endometrial receptivity and decreased synthesis of gonadotropins. And as a result, you have the threat of termination of pregnancy, toxicosis, preeclampsia, and HELLP syndrome. Obesity and overweight has a psychological burden on the woman. We don't always think about that. We need to consult soft as possible, because they all know they're overweight, and many see that very negatively, so they don't like themselves, which leads to changes in a new stress neuromediator environment and will lead to problems in the hormonal cycle and may trigger ovulatory dysfunction. We've done a retrospective study. We've looked at our relationship between ART and BMI, and we found that there's a negative correlation. So the higher the BMI, the less mature blastocysts and ovaries we get, and less pregnancy, although this hasn't really influenced the dose of gonadotropins. And we've even found a correlation between BMI and chronic endometritis and CD138. Everybody understands that weight loss is necessary before conception. The authors made a study. They did a survey of women with obesity and excess weight, and it showed that it was more than half of the women who were overweight were trying to lose weight at the time of the survey completion, and half of these women are even interested in medically supervised weight loss programs. But almost none of them were willing to delay infertility treatment for more than 3 months. Well, we know that in 3 months to get your BMI in order is impossible, not even physiologically, let alone some activity. Tactics can be non-pharmacological, like diet and physical activity. This is what we should start the recommendations with for obese women: modifying their lifestyle, normal diet, normal physical activity. Pharmacological, that would be the inositols we've talked a lot about. Metformin is a great drug. And GLP-1 receptor agonists. The GLP-1 receptor agonist is for the endocrinologist to decide. I believe only endocrinologists should prescribe them and be followed up, and should be discontinued 1 to 2 months before planned conception. Best case scenario, 2 to 3 months before conception, although they have a lot of positive effects. And in literature, there's more and more work on the use of modern GLP-1 receptor agonists, which show that they have a very good effect on the receptiveness of the endometrium and on becoming pregnant later. Also, surgical treatment. If we recommend them, we have to understand how old this woman is, what kind of reproductive capabilities she has, because this will put her, this is 1-2 years before attempting to conceive. This should be done. There are also observational studies which say that lifestyle modifications, so physical activity, can significantly increase the chances of getting pregnant. Naturally, also metformin has a good influence. And weight loss, the authors have found that weight loss was the reason for more spontaneous pregnancy, and also in the increase in Como index. Inositols have been in the limelight for 10 years now. In 2015, there was even a conference about inositols, where they found that the effective dose of myoinositol is 2 grams per day, and MI to DCI should be 40 to 1. So dihydroinositol is attractive, though, to our attention, because some men and women have a gene defect of epimerase. That's an enzyme that makes MI converted to DCI. And so that's why they don't have sometimes an increase in the level of DCI. And if we increase the dose of dihydroinositol, we can get a positive effect. With women with PCOS, they often use it because it acts as an aromatase blocker. So it increases the chances of ovulation. And as we use these aromatase blockers, right, medically, and it normalizes the HOMA index, because due to its specificity, it works more in the peripheral tissue, the muscles, in the fat tissue. insulin is normalized, and it helps the reproductive system. They also study combining MI plus DCI and metformin significantly improve insulin sensitivity and reducing weight and improving ovarian function in young women and even teenagers. It can lead to normalizing their menstrual function. Also, they studied the level of hormones, and it was shown that in the MI and DCI combination, just like with metformin, it has a positive impact on glycolyzed hemoglobin, and it normalizes the function of gonadotropins. There's also a study prescribing dihydroinositol, dichloroinositol for pregnant women. They were prescribing 500 milligrams twice per day for 3 months, and what they got was the result that incidence of GDM was significantly lower in the DCI group compared with the placebo group. And they had children born with a normal weight. So we know that women with insulin resistance are in a risk group for macrosomia, for preterm births, and there's a very high risk of gestational diabetes mellitus, GDM. On our market, there are drugs that contain 500 milligrams of dichloroinositol. Also in Protalis, we have manganese, which is a trace element necessary for regulating blood sugar levels. And you have B12 as well, L-methylfolate. Let's not forget the women with the issues with that, and prescribing B12 helps these women normalize their homocysteine. But since dichloroinositol hasn't been studied, so it's counterindicated at early stages before 12 weeks. So omega-3 supplements can also help women with who are overweight and obese, because omega-3s are factors that reduce the risk of cardiovascular disease, and they reduce lipogenesis, and they have an anti-obesity effect. Thank you for listening. Thank you very much. We don't have time for questions, so let's just continue so that the next session can continue on time. The next speaker is Apshekenova Aigerim, candidate of medical sciences, obstetrician, gynecologist, reproductologist. How do I go through the slides? Okay. Good day, distinguished colleagues, dear members of the Presidium. Allow me today to present to you about the modern predictors of the effectiveness of ART programs. Now, in this presentation, I'm going to share some clinical data of a comprehensive study, large scale, done by 2 countries. If we look at the past, our women in the 19th century had natural protection from gynecological diseases like many pregnancies, lactation, births. What do we have? More than 40 menstrual cycles. That's the price of progress. That's us deciding in favor of late pregnancy. But this choice is the main reason why right now there is more infertility and why the clinical structure of gynecological disease is changing. As a result of which the demographic situation in the world is deteriorating, there's less fertility rate, and based on World Bank results 2025, forecasted birth rate was 16.1%, which is much lower than the level required for natural reproduction. As a result, of course, the average age of mothers is growing, those who are planning pregnancy. And we see patients a lot nowadays who come to motherhood after 35 years old. And as a result, you have, of course, infertility being widespread. Every sixth couple is suffering with this disease. Kazakhstan also, and that's 12 to 16%. So every sixth couple in Kazakhstan can't have children without ART. So IVF is no longer a luxury for Kazakhstan. That's the main policy in their public health care. So that's how you also have a growth in the number of IVF cycles, or ART cycles. Based on ICMART, the only drop was in 2020 because of COVID. Otherwise, we've been seeing a growth. And this study once again proves to us that the success in an IVF program is probably a journey of several attempts. The frequency of live births, 29% first try, is what our patients are getting. Just first try, we're getting 29% of live births. Where are the 100%? Where are the guarantees that our patients demand from us? Of course, by attempt 6, this result, it goes up to 65%. But nonetheless, for women of an advanced age, this is data from the ESHRI register. So average from 36 to 21% live birth rate. So there's no talk about 100%. That's why we're getting different results in different age groups. And what does the effectiveness of our program depend on? Why can't we, for the same patients, be stating the same numbers? Like, you come, we do a program, you're going to get 40% of effectiveness. And there's a lot of factors. Unfortunately, age can be an issue, the quality of embryos. And since IVF came around, studies continue trying to kind of guess these factors and prevent them. And age is shown to be a major factor. In women aged 38 and onwards, the chance drops to 11%. That's our target audience. These are these patients who are currently wanting to do IVF. And we cannot change their age anymore. We cannot say, come 5 years ago, 5 years before, right? But we can change the quality of embryos and good stimulation and the support of the luteal phase. So since IVF came around, a lot of studies, this one is from 2010, which tries to forecast the effectiveness of IVF. This one is dated May 2024, where they found 11 of the most frequently used factors in the most recent study, May 2025. So we are still trying to find, to this day, some factors that have an influence on the effectiveness of IVF, which is what we're also doing. Supported by Abbott for the first time in Kazakhstan, they did a multi-center study which covered 44 research facilities in Russia and Kazakhstan, more than 1,000 patients. This covered, guided by Professors Nazarenko and Lokshin. And the goal was to assess the predictors. So they had women there included from 18 and onwards, and it had to be a fresh embryo transfer. They used dihydrogesterone, 1 pill 3 times per day, starting from egg retrieval. The patients had 3 visits, and up until week 10, they were under supervision, and they were assessed using a phone call a week after the supposed birth date. And objectives were to study and evaluate the significant factors for the pregnancy rate in IVF and ICSI. the average age was 33.8 years. The BMI was normal. Primary infertility was, and secondary was the same. And mostly they add tubal and male factors as causes. During this study, they analyzed 24 initial factors, as a result of which we selected 5 of the most influential ones: age, quality of transferred embryos, antral follicle count, fertilization method, and type of infertility. And they created a heat map, which you can see on the screen there. So embryos, only fresh embryos were transferred for this program, and we transferred embryos at blastocyst stage, so 5th day, and 3rd day also. We had pretty good results. And so for Kazakhstan, 149 patients were included, and clinical pregnancy rate was 32.9%, and live births were 26, comparable with Eshrei and RAR data. We used dydrogesterone as monotherapy to support the luteal phase. The pregnancy rate was 37.2%, and the live births were 30.7%. Dydrogesterone has demonstrated a favorable safety profile as well. So congenital diseases or developmental anomalies were 6% globally, and based on the results of our study, generally iris 4.2%, for Kazakhstan 4.4%. It's not higher than the global. The congenital defects of the cardiovascular system were also 2.8% iris, 3.4% Kazakhstan, and 8.1% global. So this heat map allows us to adequately speak to our patients and tell them the chances of getting pregnant from the first program or 5th attempt. So the main factors: age continues to be a key factor. The likelihood of pregnancy decreased after 34 years. The antral follicle count is the main prognostic marker. And of course, the quality of embryos can compensate for low ovarian reserve. So even with the number of antral follicles being below 8 and the age after 38 years, the probability is towards donor, is in favor of donor cells. So this heat map model allows patients to make the right decision, but we all understand that when we assess, when we voice a certain percentage for some reason in the ears of our patients, it always feels like 100%, like 50%. Even if we say that the frequency of pregnancy can be 5%. But showing this heat map, we can kind of visually give them an understanding of the chances to our patients.
Dydrogesterone has confirmed its ability to support luteal phase in a mono regimen, which expands the capabilities for individualized treatment. Why age is this main factor still? Yesterday there was a mitochondria replacement therapy presentation. So it's due to mitochondria, which are the sources for oocyte energy, and the quality of mitochondria decreases. So that's why there are membrane defects, mitochondria swelling, and membrane rupture of lysosome and cells autolysis. So we need to understand that such patients we cannot prepare just by folic acid, omega, or vitamin D. We need to look at the oxidative microelements, oxidants, including L-arginine, coenzyme Q10, ubiquinone. And on the 6th of November, I was at the pre-congress about antioxidant therapy, its importance for the patients of the older reproductive age. And antioxidant therapy includes psyllin, vitamin C, vitamin E and D. They have antioxidant protection. And there is a preparation on the market which has all these microelements, and it's quite affordable. So we need to prepare our patients for the cycle and not to take them immediately, but to have at least 3 months of preparation, of course, if we have time for that. Also, we'd like to note ethical aspects, fertility, sterility article, where authors say that the patient perhaps is conscious that further attempt won't lead to subsequent pregnancy. So they need to assess their chances and give chances to look for other forms of implementation. So our heat table may show the chances of pregnancy as a visual diagram, keeping in mind the ethics. So age and viral reserve and embryo quality are the 3 pillars of ART success. Even with a low reserve, good quality of embryos may change the outcome, but after 38, the age becomes determining factor. So success in IVF are not only numbers, but honest perspective, informed decisions. This presentation was made with the support of Abbott because IRIS research was organized by Abbott, and we thank them because that advances our practice, and we should have more of such research. Thank you for your good presentation, and you were on time. You saved us some time. Thank you. Freeze-all protocol and endometrium preparation. I give the floor to Ravil Valiyev, the obstetrician, reproductologist, surgeon, PhD, and wonderful speaker. And I believe that you would be much enjoying his presentation and his level of expertise. Dear Presidium and colleagues, thank you for your kind words. Colleagues, I would be quite short. The endometrium preparation for the transfer, our wishes and opportunities. We've studied some part of this at the pre-congress. So let me go further. We are making transfer of frozen embryos. It's the tendency that we are all following. Hormone replacement therapy and natural cycle are 2 popular methods of endometrial preparation, and this was discussed yesterday and today. Hormone replacement therapy is now used at the discretion of the physician or patients since the time of embryo thawing, and transfer can be easily coordinated with the schedules of IVF laboratory, physicians and patients. However, current findings suggest that pregnancy in the absence of a corpus luteum due to anovulation may pose a risk to both mother and fetus. Yesterday we discussed that the level of hormones should be maintained, basic hormones, preparing the endometrium in natural and modified cycles, and cycles with hormone replacement therapy. So the abandoning fed HRT regimen would mean abandoning their main advantage, which is opportunity of programming, which is in accordance with the need of the clinic and the physicians. But for the patient, it's a problem because they don't have the corpus luteum, and that is related to HRT. So there are true natural cycles as to basic protocols, and if we're adding some stimulants to the FSH, that would be a natural cycle. No, that would be a modified natural cycle, and hormone replacement therapy in the HRT, and so-called modified natural cycles with ovulation stimulation. Their efficiency is proven long ago. It's important for your colleagues to understand that if you want to start any of these cycles, it's important to follow certain requirements both to the doctor, lab, and the patient. These are requirements written on this slide. And it's important to understand on which phase what you're getting, what kind of hormones, what is the level, and what would be the outcome of this program. Are you getting pregnancy or not? And briefly, I'm not going to dwell on numbers. We've discussed this on the 6th of November. This is a so-called natural cycle when we see the growth of our own follicular at the ovulation test or hormonal profile, and we give progesterone. 3 or 4 years ago, in natural cycles, we did not prescribe progesterone. Now there are a number of evidence that even for absolutely healthy women, from 18 to 30% of cycles come with the insufficiency of luteal phase. So even in natural cycles, some form of progesterone should be given to support luteal phase. Modified natural cycle has HCG trigger, where we can program the cycles that we need, and also we administer here progesterons. So about the FET-HRT protocol, here I want you to understand. Please raise your hands. Who is using natural cycle? Natural cycle? And who is using mostly HRT cycles? Colleagues. Everything is clear with natural cycles. But if you're mostly using HRT cycles and you know that you have a problem with endometrium, or you have thinner endometrium or hyperplasia endometria, are you going to use tablet forms or transdermal? Who is going to use tablet forms? Tablet forms or transdermal? Transdermal? Okay. That's quite important. We should always remember that using only tablet forms, the estradiol action in this case, there is no action of estradiol on endometrium because estroma is formed after the liver. It's more compliant to endometrium. We get a better growth of endometrium. But when we use transdermal forms, there was an opinion that they're not working. But this was just because we are it works better with the endometrial growth. And estrol is such a preparation. It's 1 or 2 cycles of preparation, and then there are big risks. So if we want to have a big number of cycles of preparation with a thin endometrium, with the asynchronous growth of polyps, then you need to use transdermal forms. So the so-called long protocol in HRT, when with the luteal phase we start to block the endometrium to have desensitization, and only then we start endometrium preparation. In that case, we're going to get good outcomes. So there are some such cycles of women when there is a follicular growth, even if there is 7 milligrams of cardiol per hour. So it's rarely used. We mostly use it at the transport protocols because we know that we can postpone this go as much as we want to, and it won't be a problem. The mid-dose cycle for stimulation, monofollicular growth, or anti-estrogens, or HMG or FSH recombinant in small doses, there could be 2 outcomes. In order to prognose your work, you can have the growth of follicles to 16-17 millimeters. Main thing that endometrium should be more than XVII. You can give HCG or just give progesterone and go ahead with the transfer. What's most important? We need to have a mostly efficient transfer. We need to remember about safety, and they should be natural protocols, but we could not always get the opportunity from the patient or a clear level of the hormones in the natural or naturally modified cycles. That's why the approach is changing. In the Nana clinic, we have some 40 cycles, unfortunately, with HRT or HRT in a long protocol. So what are the reasons? It's asynchrony of follicle and endometrium growth, the so-called thin or hyperplastic endometrium, perimenopausal period, or the ovarian wear syndrome, the limited period of patients stay in the clinic because these cycles may be failing. We need to change our tactics. Limited ability to perform ovulation tests twice a day. And of course, when we know that there is an implantation window has moved for the sooner or for the later, for those patients we understand what are the protocols, and I want to remind you that in this case it's important to use certain transdermal forms. So when we prepare endometrium with certain problem, if we have a thin endometrium, we're going to use hormone replacement therapy, HRT. As it was mentioned yesterday that we need to train endometrium on how it should grow. That was the last presentation yesterday. When endometrium does this best, it's better to do this with transdermal forms. It's more safe. So you can use transdermal forms for patients. It would be more useful. So the interaction says that it's estradiol, and not all estradiols they metabolize. That's why there are only 3% of estradiol enters the system bloodstream. Mostly it's estrone, estriol, catechoestrogens, and that is dangerous and scary. Metabolism of transdermal form is better conjuncts, and there are no peaks when we use in tableted forms, and so transdermal is better. Estradiol, and this is the most safest approach. Some international recommendations. Transdermal estrogens is that they do not go through the liver, does not increase the body mass, and transdermal spray is more can be applied for women that do not want to take pills. 100B 240 it's always under stress, there are no metabolites, and this distribution of the dosage throughout the day and convenience on use. We don't have to do any genetic activities, you don't have to drink water. So this is a patient, 47, 2 years of menopause, and she wanted to become pregnant. Can you switch on this video? So we had a hysteroscopy, we've seen a full occlusion in the lower part of the So this was Asherman. And before that there is a scar. We have cut it, and I'm going to show next video. We did not allow girl to menstruate. We've done Seppin clog hysteroscopy. You see that endometrium have filled the area where we have cut. This patient is going to get estrogen for the endometrium, and she was opting for transdermal. She got the pregnancy, and everything was wonderful. Estradiol in reconstructive surgery stimulates endometrial stem cells and has the regeneration of using a spiral. We're not using it. So this is the protocol of treatment after the uterine cavity excision. You need to give a good treatment, at least 6-8 milligrams of standermal. And the rest that what you want you can do at the same time. And you can form the second phase and do this so that's not a problem. Let me pause here and give you 30 seconds if you have any questions.
Большое спасибо. Есть вопросы к Равиловичу? Как проводите их? Вы на дифферении или в естественном цикле? Вот цикл у него 24 дня, а овуляция примерно...
So cycle is 24 days, ovulation is on day 5 and 6. How do you do transfer for them? If everything corresponds, growth of follicular and endometrium, you can do that in the natural cycle. It's not a problem. Only if you have the follicular and endometrium asynchronous growth, and so you can use either FET or long protocols. So if you have ovulation on the 12th day, it's not bad. The first phase, less than 10 days, should not be. If it's on the 8th or 9th day, you need to see it, and I would give you the HRT, and for the first 10 days we need to keep it, because endometrium may not grow in this time. But if it's the 12th day, I agree with Ravil that you can add this quietly. So if there is a special HRT in cycles of FET HRT, if you have endometrium very early, and you see that on the 8th, 9th day it's ready, in this situation you should think whether you should make a transfer. If it's a natural cycle, I agree, and the 12th day, 10th, 12th, 11th day is normal.
If I could ask a question, thank you for your great presentation. So in the natural cycle, modified, you do transfers, right? Depending on the subtask. Do you add Divigel in natural cycles? In natural ones, no, because it won't be a natural cycle if we add something. So you don't add. If we add Divigel, it's not a natural cycle. But modified cycle, you look at the endometrium, for instance, is like 6 millimeters and the follicles are 14. I mean, legally, a natural cycle is when we don't do anything. We just monitor the ovulation. Whatever we add to the natural cycle, it's either called modification or we're going into hormone therapy, hormone replacement. I mean, if you want to save that cycle and you see that the endometrium isn't enough, but the follicle is running forward, we give estradiol, why not? But then, of course, you need to look at a few things to make sure you finalize that cycle with a transfer. Monitoring of hormones, do you do at the onset? Yes, of course. And the most important thing is to not add estrogens until the follicle is 14 millimeters. That's for young doctors, 14 millimeters is when the estradiol starts to produce. If it's before 14 millimeters, like 12 millimeters, we add estrogens, and we are slowing down the follicle growth, and then we'll have to do large doses of estrogen. Sometimes you have to. So the follicle can grow, if it grows faster in the endometrium, then we speed up the endometrium, the follicle slows down. If it slowed down more than 14 millimeters, that's okay. You can give either a trigger and go and do the transfer, or without giving the trigger, just start doing the transfer. Another question, Dr. Avil, about the dosage. It says estradiol 1 to 9 milligrams. So what is the scheme? How do you prescribe it? You standard, just go with everybody, or is there a step-by-step increase? Or what is best if we're talking about our HRT? Depends on your patient. If your patient is with PCOS, like I have girls who on 1 milligram they grew enough and they got pregnancy. So 1 bag, why not? And if you see that she's got her own FSH faster than the LG, than the LH, then you should give more. Like 6 milligrams is enough of a dose to block. But there are some really stubborn girls who like 6 and 8 and 10 milligrams, their follicle can still grow. Then we go into the long protocol. Or are you afraid of follicle growth? You're just going to go into the natural cycle. You'll just have Relixin and additional corpus luteum. We use that. No, nobody's afraid of that. It is good, but it all depends on what you're trying to get. Because, sometimes you can have asynchronous growth, just like in the beginning, you can have that asynchronous thing at the time when you want to give progesterone. So it depends on what you're trying to get as a result. There may be different options for each patient. And there's standard schemes which we talk about, but we all understand that we can go like 4 milligrams of estradiol and move on to 10 milligrams of estradiol to get something from this patient. So I'm talking about standard cycles. Thank you, doctors. Thank you very much. Very interesting discussion turned out here. And with great pleasure, I would like to invite a very revered doctor by me, Laila Chalova, with an interesting subject, which is sensitive for us all, features of testing the unified registry of donor gametes based on KARM. There's not a lot of countries where they even have a donor registry. Leila Rashidovna, we have 15 minutes. I'm going to have a very brief presentation. Good day, distinguished colleagues. It's not a very medical topic, it's more of public health care, this one. So the peculiarities of testing the unified registry of gamete donors based on KARM. So what do we have here? Don't have any conflict of interest. The relevance. The number of ART programs worldwide is growing. The number of ART programs using donor gametes is growing. You can, as a remark, take the recommendation of ASRM for a population of 800,000 people, up to 25 births per donor, no more than 6 stimulation cycles per donor, as per recommendation in our order, which we work with, which we're going with, 10 children born from 1 donor. Now, the purpose of the study, we designed the registry and we wanted to see how it works or whether it doesn't work and the current problem issues that exist with donorship. We've sent a survey to 30 clinics, ART clinics in Kazakhstan. Unfortunately, only 16 replied and participated. That's 53.3%. Every clinic filled out a questionnaire, and we tried to understand what we got as a result. So what we saw was the IVF program and insemination with donor sperm was 1,319. That was 2 years, 2021, 2022. We were getting data from these years. The number of clinical pregnancies quite high, 457, and children born. And I'm going to tell you a bit later how many were born. But let's go with the IVF programs with donors sperm. The donor eggs. We got 2,511 in 2 years. The number of donations of donor oocytes and donor sperm. We wanted to see if clinics do that accounting, and how, as we can see, the donor of oocytes in one clinic in a year goes up to 6 times. That's one clinic. And donation of one donor of sperm in one clinic, that's a number is quite high, up to 13 times. The number of donations of one donor in the different IVF clinics. And you have 14 clinics that don't have that accounting. And there's 30 clinics in Kazakhstan. Accounting of number of children with donor sperm. We've seen that after insemination, not such a huge amount. We know that the results are low, 14 to 16%. The number of children born after IVF with donor sperm is more, 115, 199. In 2022, it was a little less. It's hard to say why, but those were the replies. The number of children born to couples that are non-resident, small also, but we're seeing a growth. So people are coming more to Kazakhstan as for medical tourism. Number of children born from the same sperm. They're doing records, but 2 clinics did not keep records. Number of children born with donor oocytes in Kazakhstan was 1,242, and number of children born from the same donor, 2 clinics do not keep records once again for that. So first year 15 clinics, second year 14. Number of children born from donor oocytes to non-residents, we're seeing a big progress in 2022. And it also shows that medical tourism is developing in Kazakhstan. So where are we getting these donors from? How many times in your clinics have they used donor oocytes brought from other clinics? Very little. So every clinic pretty much from donor sperms and donor oocytes, they prefer to work with their own bank of donor gametes. But donor sperm is brought from other countries, and it can be used many times, up to 40, 30 times. And we don't have accounting of which donor it is and where. So what we found is 16 clinics from 30. That means we don't have enough coverage, we don't have full monitoring, we don't have a normative legal framework which mandates clinics to provide this data for accounting. Not all clinics keep this accounting, so we ask them, but they just say they don't need that. We don't demand new reports. It means the clinics don't need that. If we say it's recommended, and a person can just say, I don't really need that. If we say it's mandatory, then the clinics will be doing that accounting. And without tracking the number of children born, we can have a potential inbreeding problem in the future. There's no interclinical information system. There's no collaboration between the clinics. There's no traceability of biomaterial, and there's no unified electronic database where we could control the number of children born from one donor. So what are the ways of solving this? Have a unified registry. It's already developed, the algorithm, the traceability in this registry. should be on a national state level, and we should make changes to the legislation to make it mandatory for each clinic. And I would like to also say that we've had births using donor sperm and oocytes, about 1,500 children. Is that a lot or is that little? It's hard to answer this question, but if we've grounded from the recommendations of ASRM, we already have more of them. And considering that reproductive tourism is on the rise, and the number of aging women is on the rise, I think if we do in the future also accounting of these donor oocytes over the past years, I think it's going to be even more. And for some, it's little. It's like glass is either half empty or half full. Nobody knows. But I believe that already now there is some flags for concern, so we need to check that. Thank you. Thank you very much. Very relevant topic, but we need to say that pretty much there's little countries where they have their own donor registry. The most visible registry they have in the UK, but they have this free of charge donorship, and we can even go in and see very transparent. This is difficult to do because in such a big country, where in Europe they have the largest number of cycles done, even in Russia, unfortunately, it was a big problem. And for small countries, it's very relevant. So look, when we talk about donors, they don't always provide the right information. So a donor can go between clinics. And I know that from donors who are oocyte donors up to 13 times. So they migrate between cities. In Europe is taking a lot of laws where they're canceling anonymous donorship. In our country, donorship is both anonymous and not anonymous. And the biggest problem is that the donors come, very rarely do they come for no reason, like why the donors became a donor. There is no altruism in their motives almost ever. They're financially interested, and that creates a problem. So if we make an attempt to somehow control donation, then we can understand that if a donor, maybe they concealed some information or maybe they weren't found in the database, but if the main cohort tackles that, we can solve the task of uncontrolled ownership, and it's about the safety of donors too. Yes, Laila Rashidovna has been raising this issue not the first time. I think a unified registry can only be created when all the clinics participate and provide assistance, because the first thing we have to do is make it safe for our population, because it's very difficult, because when you have like brothers and sisters, and you understand what it is. So I urge you to help Laila Chalva unite our efforts. Very important to learn the opinion of the Armenian Association. Thank you. Based off our suggestion in Armenia for 2 years now that we have created a registry in Armenia, and our law is 5 times they can do it. And all the data goes to the Ministry of Health. It's not anonymous anymore. So these donors, as you said, they did it 5 times there and 5 times here. And then inbreeding, Armenia is 3 million population. It was a big problem. And so we adopted a law that they can't do it more than 5 times. But for the second baby, they can also come twice more if it's one child born in a family from this donor. Or we try to get the oocytes from them ahead of time. We try to maintain contact for them if they come for the second child, so then the family, they have children from one donor. Yeah, I fully agree with you. In this question we also raised in our dissertation, when in one family they may have frozen several embryos and you want it to be from one cohort, but that should be accounted for somewhere, because what's going on now in the country, it's good that you pointed this out and you actually did it. But if we're talking about inbreeding, the chances of that are going to grow because the country is small. And let's not forget that reproductive tourism in our countries are open, right? Everybody's traveling. So non-anonymity and the openness of access, where the EU, the US are all moving towards that. They will create a platform where a person can see whether this person is they're related to them or not. That's very important. All right, we're supposed to finish this session and start the next one.
Уважаемые коллеги, наверное, мы не будем...
Dear colleagues, we are not waiting for the exact time, and we will try to start earlier so that we would be on time. The Muhira Tursunova would be postponed, so the next speaker is Hilola Usmanova, reproductologist, SIS Onabula SIS Clinic, IVF Clinic, Tashkent, Uzbekistan. Results of intravenous immunoglobulin use to patients with recurrent pregnancy loss caused by APS syndrome. Hello, colleagues and Presidium. I'm very happy to be at this Congress with this presentation. The topic of my presentation is immunoglobulin for the patients with recurrent pregnancy loss caused by APS syndrome. APS is an autoimmune disease characterized by arterial venosis or microvascular thrombosis or recurrent pregnancy loss, and it's directed against one or more phospholipid-associated proteins, beta-2, glycoprotein 1, prothrombin, annexin A5. There are two main clinical variants, vascular and obstetrician. Obstetrician APS, the primary concern is not thrombosis, but damage to placental cells, disruption of angiogenesis, and activation of the complement system. Our study, the IPS syndrome, probably you often meet it as well. 1 to 5% of reproductive age women, they have a habitual miscarriage, And APS accounts for approximately 10–15% of cases of recurrent pregnancy loss. Even with the standard therapy, low-dose aspirin and low molecular heparin, there remains a risk of pregnancy loss. Intravenous immunoglobulin is considered as an additional immunomodulatory method. I'd like to explain the pathogenesis. There is the complement system involved, and that's why they have the embryon nidation, and that's why there could be such cellular changes, and this placenta is kind of switched off. So placental tissue, there is thrombosis and angiogenic disruption. So there could be different disorders of placenta, preeclampsia, and there could be antenatal death of the fetus at different stages. So that's why the purpose and objectives of this study is first to evaluate the effectiveness of intravenous immunoglobulin in complex therapy of patients with recurrent pregnancy loss associated with APS, to assess the frequency of pregnancy onset and outcomes, and to study the effect of IVIG on immunological and coagulation parameters for these women. Materials and methods. The study was conducted in the specialized practical medical center. The study included 30 patients from 20 to 35 with a loss of 3 or more pregnancies at 4 to 37 weeks, refractory to traditional treatment of APS. Exclusion criteria, patients with systematic collagenoses. The object of this study is the blood parameters of patients, hemostasis. For APS, criteria were established based on ACR EULAR 2023 criteria, and also having positive immunoglobulin M and G, and having beta protein 1. Out of 30 patients, 12 were which had spontaneous pregnancy up to 5 weeks, antenatal fetal death at 24–38 weeks, combined with preeclampsia, 2 antenatal fetal death at 34–36 weeks, and 2 had antenatal fetal death at 34 weeks, preeclampsia and HELP syndrome. The blood counts before treatment is lupus coagulant 1.5 for 80 patients, cardiolipin IMG 15, and cardiolipin and glycoprotein for 13 patients. The treatment regimen, standard treatment was IVIG. It was done once, 10 milligrams intravenously. We've applied it every 12 weeks with a transfusiologist. We had 2 regimen. First was 8 and 20 weeks, and triple administration was 4th, 16th, and 28th week. After the second administration, negative tests for APS syndrome were obtained for 36% of patients, and after the second administration, negative tests were obtained for 80% of pregnant women, which may indicate a pronounced immunomodulatory effect. In the study group, there were losses in only 3 patients. at 26 and 27 weeks. So the obtained data shows that the use of IVG in proven APS syndrome may be a good method for maintaining pregnancy, because in other guidelines they give, in 15% of cases, pregnancy is ended in fetal death. In our study, it's 30%, which helps well for the APS syndrome using immunoglobulin IV. A case study, a patient born in 1989. She had 16 weeks plus 1 antenatal death, and she had a hypercoagulation. And after we prepared her before the pregnancy, we were providing supplementary treatment and giving every 12 weeks immunoglobulin intravenously to prevent hypercoagulation. And at some time she was losing the fetus, and there was this IV therapy because it's 16 weeks, and after we reached week 35 with a healthy boy weighing 2,200 grams, and today he's growing and developing in accordance with his age. So intravenous immunoglobulin have immunomodulatory effect. To confirm the immunological effect, repeated measurements must be carried out after sufficient interval of time. It's not a standard first-line therapy, but it's a low-dose aspirin plus LMWH remains the standard according to the guidelines. IVG is more often considered as an option in refractory or high-risk cases. In Uzbekistan, we received a patent for APS and for loss of pregnancy. Have you had any side effects? And as to administering aspirin in low doses, Russian clinical guidelines, we can use it only from the 12th weeks, although we understand that for APS we need to do that before the frozen embryo transfer. What are your limitations and restrictions? And third, if immunoglobulin is administered, immunoglobulin A, if it's lower than reference, it's not recommended. So how often did you see immunoglobulin A, and how did you understand the reason? When this was done in the Republican Center of Hematology under the control of transfusiologist, because for that you need a blood count, immunoglobulin E and A. If there are no allergy reactions, then with the hematologist, we've done that protocols, and the patient stayed for a day in the hospital, because before the IV there should be pre-medication with the Dimedrol or other, and after sensibilization, since this is a foreign protein, and after that we observed the patient condition, if there are any changes. As to low-dose aspirin, in many guidelines it still remains, but since this is teratogenic properties for the fetus, it's not recommended prior to 12 weeks. But in our standards, to prevent preeclampsia, if the patient has losses or antenatal fetal death or certain blood count, then in standard dosage before planning for the preconception care prescribe this, adding low molecular heparin. We also look for anti-10A. Thank you so much. Are there more questions, colleagues? Let us move on then. Next, it's anti-age approach, ovarian aging, modern opportunities to it's Natalia Teraraka, Брак и семья, Medical Center. Thank you for staying with us. Thank you for your endurance. The topic is quite pressing. Ovarian aging is doubtless because it's a multi-factor process. There is decrease in quantity and quality of follicles. The initial pool is 1 or 2 million follicles. By puberty, it's 300, 400,000. And by 35, 37, there is a critical decline of reserve. In our clinic, that leads to decrease of ART programs after 35 and growth of infertility with delayed childbirth. We see that there is a certain trend for the delayed motherhood, the increased age of patients in ART, and the need of early diagnostics of pre-age ovarian aging. So we are determining the reproductive age, which shows increases the efficacy. This is the integrative model of pathogenesis for ovarian aging. And we see that this is not a individual process, but it's a complex process. And so when we use therapeutic targets, it's regenerative technologies and endocrine support. So what is apoptosis? Cell apoptosis is a key chain of aging. It's a process of programmed cell death when a cell is self-liquidated due to certain signals. And Caspase and BAC proteins are increasing this. And atresia of follicles is a consequence of apoptosis when it's not reaching the maturity and there is no ovulation. Why atresia happens? Because there is increased oxidative stress. Active oxygen forms, calcium production.
problems with pregnancy and early termination, because we know there's conflicting information, controversial information, different sources saying different things, that, in artificial cycles, people are saying that the effectiveness can be a bit lower than natural ones. So what provides to us good effectiveness in cycles when we do a transfer for HRT? Now, if we look at the dosages of hormonal support, unfortunately, we don't have recommendations that we should be using like a personalized approach based on nosology. Although we know the endometriosis and progesterone resistance, we don't have recommendations that we should have one standard dose in this natural cycle or an assisted cycle, or if there's no corpus luteum, a third dose. We have standard dosages according to Russian recommendations and initial recommendations. But still, we know that at least when we don't have the corpus luteum, we can measure the progesterone levels, and that number will be more or less replicatable in 80%. Open as lutein support in different countries and different clinics are used differently. Some in 100% of cases, some in certain situations, some don't use them at all. Nonetheless, and currently these medications are used more and more thanks to the fact that they've demonstrated their safety, and the receptors are seen in ectrophytodermia and on the granulose cells, and there's a lot of application points where you can use them. The majority of the research that compares different types of micronized progesterone have not shown any differences in effectiveness or safety. They assess the viscosity of these because it's also important in terms of their effectiveness. And in my clinical practice, I've been using gels mostly because it's convenient, just single use. But there's forms like 300, 400, and there's no need for patients to be using it 3 times a day. You can just use it twice a day. And how long should we luteal support last? There's no standard recommendation, once again, for that. We know that in fresh cycles, the majority, there's the studies, according to systematic reviews and meta-analysis, say that we can cancel luteal support right away after we have a positive HCG, but many works say that it's these meta-analysis, would include studies where they included patients with a good forecast that didn't have any threats of termination, that didn't have a bad history. So that's why, of course, when we talk about how long should luteal support last, we'll look at the patient's history and the clinical situation. According to our clinical recommendations, we can use a minimum up to 12 weeks, up to 20 weeks of termination, and preterm up to... So now let's go to the convenience. Now, that's why doctors love HRT. For minimum 7 millimeters, we can prescribe progesterone, although I put a question mark there because of a recent publications, they've been talking about this big registry, starting the Canadian one. They're talking about that up to 12 millimeters, every additional millimeter gives us an increase of a pregnancy rate, so we shouldn't hurry it. We can wait another few days to grow the endometrium to a better number. And the estrogen, right? They talk about 10 to 28. There's some works that say it's less than 10 might not be enough for the estrogen. And there's another fresh work published by Elena Labarta's team with a large number of cycles, more than 7,000, has shown that even if the endometrium has grown to that still doesn't reduce the effectiveness of the cryotransfer. Now, the question of when to do the cryotransfer, and we've talked about that, about the implantation window, whether it's individual or not. Is it 120 hours or is it 144 hours? Well, by standard, we work like it's the 6th day of progesterone, so about 120 hours. But if we didn't do the assessment of receptance of by the endometrium, doctors don't usually calculate exactly by the hour. Usually they prescribe progesterone in the evening or in the morning. And in this fresh work, they compared exactly the prescribing of progesterone in the morning and prescribing it in the evening. And there weren't any differences found, although it was a 12-hour difference. And it was the same level of progesterone, although the suboptimal level of progesterone, which was below 8.8, which is Elena Labarta's collective, for them the suboptimal level was seen more often if the progesterone was started in the evening. So possibly still, when we're prescribing a little bit earlier, maybe that will be better. So another interesting work, this one didn't have PGTA, but it still showed that globally, after 144 hours of cryotransfer, the effectiveness was higher than if they had done it 120 hours. And important was the quality of the embryos. With high-quality embryos, statistically, there weren't any statistical differences. 120, 134, 144, or 132. But with lower quality of embryos, however, the best one was the 144-hour interval. This is the data that was actively discussed at ESHRE this year, which is probably true. The implantation window does not play such a big role when your quality of embryo is good, especially at a young age. And on the contrary, when your quality of embryo is lower, that's when the implantation window becomes more narrow, especially if the patient has some comorbidities, the chronic endometritis and the others. We know that with these conditions you may have a different, a longer, more narrow implantation window. And maybe it's these categories of patients where it's important to assess that.
Now let's talk about cryotransfer in natural cycles. As to effectiveness, it's low risk of excess estrogen levels and better obstetrician outcomes. What are the difficulties which may reduce efficacy? It could be early ovulation, which we have missed, and we may see the corpus luteum already. It's difficult to hit into the implantation window. So they measure the LH level, but we don't know what should be the LH peak. Is it 100%, 150%, or 200% peak? So it's a relative change, and it's impossible to check LH so often. Not always endometrium is growing when it remains thick, even during ovulation. And although corpus luteum emits its progesterone, we're adding it from outside, and its effectiveness may be increased. There are a lot of publications to support that, including fertility, sterility, systematic review. So we're not afraid to add progesterone, and usually it's enough to add one form of progesterone and to change progesterone in a natural cycle. It's a still debatable issue to measure it, but some works they do measure. So how can we provide for the convenience? Can we start progesterone before ovulation, or can we postpone ovulation if we need to increase the follicular phase of the cycle. Our compatriot works, Nikolai Kornilov, this is used in clinical practice since 2012. They have less progesterone dosage, just 400 milligrams, and the efficacy was comparable as to the frequency of miscarriage and live birth. Here all works on the so-called lazy protocol or NPP protocol, just showing that most doctors were applying progesterone for 16 millimeter follicle. Some used it for 12 millimeters. 7 millimeters is the cutoff, and in some studies, as soon as endometrium was more than 6 milligrams, estradiol was also measured to exclude early ovulation. At a blastocyst stage or second or third day of transfer, whether there was ovulation or not, there was the corpus luteum, and only in one study they've studied the progesterone level. Do we always need ovulation? In 90% of cases, even if we administer progesterone for 2 days before, we see luteal corpus luteum on the day of transfer. And that's nothing to worry about. Even if we need to cancel cryo transfer because the growing follicle has grown endometrium using endogen estradiol. So what are the factors that may impact on pregnancy in this MPP or lazy protocol? It's not continuation of the follicular phase or progesterone before ovulation did not impact the pregnancy. Progesterone or estradiol concentration, the only factors were quality of embryo and day of biopsy. So the growth of embryo, the speed of embryo growth. Although we assess this in cases if we have any doubts. Here you look at the patient and you see there is a fresh corpus luteum, and we don't know whether this day is important or not, whether we need to cancel or not. We may try to measure progesterone level. It's an interesting work, which shows to us at least indicative levels of progesterone depending on ovulation. Before 1 minus LH, it would be 128 on the day of ovulation, or if it's 1.3, it's day of ovulation. First, after ovulation, it's 2.3, then it's 4, and then it's almost 8. If we want to postpone cryo transfer, we have a fresh work on this. We can use the GnRH antagonist, 75 international units of gonadotropins. And in this group of programming cryo transfer, the frequency of pregnancy was even higher. So in what situations it can work? We're waiting for the blood count, or the patient came traveling, or if it's always increasing the cost of treatment. So why the efficacy was higher? Maybe because the early ovulation was blocked and we didn't miss it. Perhaps for these 2-3 days endometrium has grown, but in this case the endometrium thickness was comparable in both groups. Perhaps for the patients with thin endometrium, these 2 additional days give better thickness of the endometrium. Although there are a lot of works which show that in the natural cycle, if we revise the patient on the day of transfer, on the day of cryo transfer, it could be 6.9. So having this endometrium expansion was not negatively impacting as in cycles with HRT. So compactization of endometrium is still widely discussed. A very good study which unites all these approaches. The cycles are studied in the natural cycle, where trigger was administered from 13 millimeters without NPP trigger. And thanks to Raul Arveta, I stopped to use a modified natural cycle. There was a work that when introducing exogenic HCG may reduce endogenic LG, which may negatively impact the luteal phase. So we were talking about individualized approach for cycle replacement hormonal therapy, and in fertility sterility there was a work on optimal approach without measuring progesterone to all patients. Two types of progesterone was given, vaginal and dydrogesterone, or subcutaneous or intramuscular, but every 3 days and not daily. I share our project. It's independent project of Russian Association. We have an audio podcast where we share about latest publications, fertility, sterility, human reproduction. Thank you so much. Elena, I have a question to you. How often do you use long protocols for frozen embryo transfer, or do you use daily form or deponated form? In my practice, 80% natural cycle. However, there are situations when we use GnRH agonists for patients with multiple, with the repeated implantation failure. And there are works which shows that for endometriosis, if it's a first frozen embryo transfer, there might be a tubal factor, and the previous administration of agonists from 1 to 3 months, we always use depot, may increase efficacy for this type of patients. There are different protocols, agonists plus HRT, could be agonists plus stimulation with low dosage of gonadotropins, and with a thin endometrium, such approach is better to increase the thickness of endometrium. So you're using everything to get the result, as all who are present here. Thank you. More questions? No more questions? Thank you for your attention. So we move to the next presentation, very interesting topic, a precise approach to differences, technologies that allow to change the future. Yaron Goichman, Medical Director of IMC Genomics, Israeli Medical Center for Reproductive Medicine. Hello, everyone. Thank you, everyone who stayed to listen to my presentation. I'll try to present this in Russian, although for me it would be easier to do this in English, but I would try to do this in Russian anyway. Today we're going to talk about revolution. On Earth there were several revolutions when the hunters started to be farmers, and then we continued with using computers, and now we're at the next revolution, which is about AI. As a person who is quite lone in this area, I don't want to use artificial intelligence because it's a misleading presentation of what is available here. We don't have actual artificial intelligence. We have an opportunity to model very complex processes using advanced computer technologies. Before I touch on this topic, I like to touch different topics. I'm a medical advisor in fertility, fertility AI, no other conflicts to declare. But before we touch that, conference is a good place for debates. At the same time, debates should be based on precise information which is given to our colleagues. There was a talk at the beginning of this by Professor Metalipov on PGTA, and yes, this analysis is not ideal and it's quite controversial, which I'm going to touch at the end of my presentation. But there was information which was incomplete. If there are mistakes in multiplication, we can escape using amplification as PTA, and there are a lot of research on this. It's RPG, PTA, and other amplificators. And this analysis is not ideal, but it does not give 50-50. That is not existing, it's false data, and it's important to say in this background. It's not ideal, it has its challenges that we need to work on as doctors who try to bring benefit to your patients, but to say it's 50-50, that is not existing in no works, in no studies, in no country of the world. That's important to say this. I would be happy to debate this and to show this in scientific articles. Now let's go back to why I came here. Let's talk about artificial intelligence. My colleagues have mentioned that there are a lot of things when we meet and we share our information, and we talk about experience of other doctors to make informative, right decisions for the benefit of our patients. So what about artificial intelligence? It allows us to analyze millions of cycles per second and use not 3 colleagues' knowledge, but a colossal volume of information, colleagues from the entire world. And this model is called XGBoost. And based on this model, we have analyzed a lot of data, and we found that doctors are mistaken when they're giving how many oocytes they're giving. They're mistaken by 4 oocytes. 4 plus, getting not 10 or 6, or vice versa. On the same patients, AI could be mistaken by 1.94, which decreases the error rate and allows us to get much more oocytes during stimulation. Let's talk about trigger. Each of us has triggers based on their experience, and there is a difference in the outcomes of those procedures. So these models allows us to stabilize and to leverage our experience. So the model is based on the accumulated experience of all doctors. When it says this is the dosage that you need to administer, it uses not only your experience, but the patient history, ultrasound, and millions of similar patients, and I call them medical twins. The patients that this model has found in other countries of the world, seeing similar characteristics as your patient. So we had this analysis with what algorithm has recommended, and we've seen that when the doctors accept recommendations by algorithm, then we have very high concordance between these 2 indications, which we don't see when we do this between the super experienced and less experienced specialist. In RBMO, we've used 10,000 cycles between 2018 and 2022, we've shown correspondence between the amount of oocytes and the quality of outcomes. You can see the results between different days. And as to fertilization, we see that the volume of fertilized oocytes is quite higher, and as well as the pregnancy rate. For each 3.6 oocytes results in 0.9 more blastocyst. When it's a low ovarian reserve, it's critical because one oocyte may lead to a pregnancy and live birth. So we cannot allow to discard such oocytes. So this algorithm was checked in Europe. You can see the volume of cycles and the percentage, and that's where you put the information in, and that predicts on what day you should do the puncture and when you should do the retrieval, and when you should inject the oocytes, how many oocytes would be there. That's the hormonal profile, ultrasound. Before it was mentioned about frozen trends, natural cycle, modified natural cycle. The work which we have done for 101 cycles, this is the results with this modulation. We base them on the progesterone, LH, estrogen test. The algorithm was accurate 92.9% of cases on the day of ovulation, on the retrieval, and on the hatching date. Women younger than 37, we can see that mismatch and match is quite different. So when we see at what algorithm has done, the efficacy is 10% higher. When we talk about young girls, it's up to 20% higher, because these are old data. Another work on the same topic, this shows the optimal day for transfer in green. This is the 5th day, and it tells us when to transfer. The same picture you can see when you do the protocol of stimulation. You can see that if you retreat on this day, you would have this volume of oocytes. At the end of the day, it doesn't make a decision for the doctor. That's what everybody is afraid of, that AI would replace a doctor. That's a nonsense. It allows the doctor to improve their decision-making, to assist the physician, and doesn't come instead of physician.
It's also important to understand, I don't know if you've seen it, but OpenAI has actually forbidden to analyze medical data when you upload it in ChatGPT. Why? Because I'm sure you've had patients who have said, I don't need you anymore, I can just put it into ChatGPT. Since everybody's doing that, I think you've had that too. So that won't be the case anymore. OpenAI has blocked that. Grok is blocking that now, and Gemini is going to block that too. Why? Because, well, what are you going to do? It's not so easy to replace doctors, even with AI. And there have been a lot of cases when it would give you false information or would tell a patient what to do, like stimulation. I had a patient who said, you know, I want this stimulation, doctor. I was like, why? And because ChatGPT told me that. Well, that's really cool, but maybe it wasn't very correct, though. It was XVII, and they wanted like a dosage of 450. Maybe not the right decision, but all the programs of artificial intelligence, they're here to help us. And there's another thing here, and I'm going to move forward a little bit. How do we choose the right program? There's Frito-Lay, AI, AVF. There's a whole lot of software. If you you probably have Chloe. For if you work on embryoscopes, you probably have soft embryoscope. How do we know which one is right? We don't. Actually, all of these programs nowadays are relatively, it's an educated guess. The only thing the doctor has to do is choose the most adequate educated guess. And another thing I'm going to go over quickly is for those who have a huge amount of cycles, this program knows how to balance cycles day to day, avoid collections and transplants on Sunday when doctors are resting. You see, you're hitting your days. That's what they had in the lab, 6.44 collections per day before the program, 3.44 after balancing. And it allows big labs to balance their work of their doctors and to not overburden them. The red in the graph is what happened after they introduced the program. Blue is before they had the program. And it's the same thing here, just coming back to the same point. And a brief conversation also about artificial intelligence in PGTA. I'll show you the work of Cooper Genomics, where before they introduced artificial intelligence, they had 26.9%. Then they went to, after that, to 43. But the transfers they had before they implemented AI wasn't very good to start with, right? And it grew significantly from a bad result to a kind of an okay result. So, and that's one of the lawsuits they have in the US right now to the subject of thrown out embryos. Why I'm bringing this example? Because I'm not perfect either. And if you think will resolve all your problems, you're wrong. I mean, that AI will resolve your problems, you're wrong. I don't even think it can improve at this stage colossally the results, like 30 or 40, 50%. No, that you won't have more transfers because of it. And because we have it in the lab, we won't have more blastocysts. I don't want to disappoint anybody. But what do these artificial intelligences give it to us? They can allow us to combine a lot of data and make the right decision, but the decision, the choice, at the end of the day is for the doctor to make and the patient, not the computer. And I don't see how in the coming time this will be changed. Based on what I know, at least, I'm showing the difference in normal embryos in age. And this is our internal research study that we did. We took the data provided by the different labs like PGT-AI 2.0, and we compared it to what we do. And in our lab, we have both AI working and human intelligence. And the human intelligence, at the end of the day, beats artificial intelligence, because the human intelligence, it truly is intelligence. I mean, no matter what artificial intelligence, how sexy it sounds, everybody's talking about AI this, AI that. It's all very cool, but in practice, life is showing that you should have a combo between the human intelligence and artificial intelligence, which is just there to help it make decisions. Let me tell you a bit about us, since I don't know, many of you, maybe you've heard of us. We're the only company nowadays in Central Asia, that is, who have signed official collaboration with NVIDIA on developing AI for modeling and PGTA. And you can see that's the smallest supercomputer on the planet, DGX Spark. That's what NVIDIA sent us. We work with Vitrolife. The Embryo Map SNP, their latest development, is actually our development. We did it together. And we're developing products with Sophia Genetics. And we try to do the more research, the better. If you're interested, we're always happy to participate in your research, or for you to join ours. There's a QR code, my WhatsApp or LinkedIn. You can always seek me out. I'll be glad to work with you. I hope it was interesting. Thank you. Thank you very much, Yaron. Relevant topic. My question is on your study on the trigger day. Are you planning a freeze-all, or so when you set up the program, you give it the options. It's just that, in 15 minutes it's hard to cover all the slides. So it's taken into account, right, whether it's prolonged stimulation Yeah, they take into account what you ask. They take into account the ethnicity of the patient, because we saw that the patients who are in Asia compared to patients who are in Israel have 26% more oocytes. We can't explain that, but it's just what we've seen physically just on the data that we got out of the program. Why? We don't know, but it's all taken into account. And what about the Agnes, you can select all that. You can select all of that. It's important to understand it doesn't change things for you. It just helps you make a decision, the right decision, a more correct decision. And from my personal experience, I didn't want to use that, honestly. I thought this was kind of not needed. I have enough experience to do it myself, to decide myself. But I noticed that it's actually better for me to listen to what it's saying, because at the end of the day, it turned out that my patients started having more oocytes, one or two more blastocysts, and I'm giving patients now a more broad understanding of what to expect. I'm turning the screen to them and saying, hey guys, look, like, you're gonna have at least like about 10 oocytes. Out of that, you're gonna have about this many blastocysts. And then the patient has adequate expectations. They don't think that they have like 30 antral follicles now, that they're gonna have 30 oocytes and 30 blastocytes, right? And that's something that, as a tool, helps me get it across to the patient in a very simple visual form what they can expect. And I noticed that when a person knows what to expect, they're more calm mentally. When they're more calm mentally, they will always have a better result, always. So yeah, colleagues, if anybody has any more questions, if I can ask a question. Colleagues, good day. Do you not think that introducing artificial intelligence in the aggressive way that it's being done in medicine, it has to do with the fact that, unfortunately, the quality of the doctors that are graduating compared to our parents, let's say, and the academicians from before is going to be much lower, and the world is having to a little bit, I don't know, kind of streamline and tell the new generation, give them a hint of what to do, like that the new generation is going to be not as smart because of AI, and that this product, AI, is more of a commercial program for, you know, to earn money rather than to somehow, you know, make things easier or help mankind. Well, you know, it's kind of two very ambiguous, controversial questions. There's a politically correct answer, and there's a real answer. People who know me, you know that I'm not politically correct. I'm very far from that. And so let me tell you honestly, the first question, probably yes, because the quality of students, not in specific locations, but generally, is dropping significantly. The number of doctors that are graduating from universities. In terms of their knowledge, sometimes I don't know how this guy graduated or this person graduated, and it's not enough of us, okay? No matter where you go, doctors, there's always three categories: really good ones, and better not be a doctors. But there's not enough of good doctors, and you need to somehow do something about that. Like, producing more doctors is very difficult, because when I was graduating from university, at that point, I counted that there are 600,000 physical procedures, 600,000 that a doctor should be doing. And I don't think that anybody in this room can do 600,000 different interventions. I don't think that's adequate to expect. And so that's why, you know, we're very limited in what we can do in our knowledge. And yes, AI is here to help us. To say that it's only commercial for somebody to make money, I wouldn't say that. In some cases, yes, but I can't really say that, as, you know, as they said before me, that PGTA is bad, generally, right? Well, I mean, it is what it is, but when we talk about artificial intelligence, it's based on the intelligence on the person using it. You just have to decide whether that's something you're selling to the patient because it brings money to your company, or are you bringing benefit to the patient because you're bringing benefit for the patient, you're getting benefit for your company. I'm not one of those people who is illusioned that doctors should work for free and we should get paid $1 for our work. I'm sorry, I think after 14 years of study and all the work experience, constantly training and moving forward, I think that doctors should be paid more than a cleaner. And in Israel, a 1 hour of doctor's work is lower than the cleaner who cleans my apartment. And I'm not sure that's the right way to go. And that's one extreme. In America, that's a different extreme, right? So we should be somewhere in the middle. And it's the same with AI, all right? So somewhere in the middle, somewhere down the middle. So it doesn't replace us, but it helps us improve the performance of the doctor. Because I think that colleagues have been in this field for a long time, but I don't think much has changed over the past 30 years. Not much has changed, unfortunately, right? Yeah, we're finalizing. Sorry, we're falling out of schedule here. Yeah, thank you very much for your very detailed answer. Just moving forward, the effectiveness of ART in patients with infectious, inflammatory, and dysplastic cervical diseases. Disukeva Elena from Astana. Good day, distinguished colleagues. Thank you for being here at our section. Allow me to start with the presentation. I wanted to express my gratitude to our scientific Professor Dilara Radikovna. Oh, there it is green, I'm sorry. And to thank all the participants of our project, which is the International Oncology Center OMIT, Open Health Care Kazakhstan, and Medical Laser Center, which participated in our study. Now, before telling you about the study, I wanted to remind you of the new guidelines which we've used. Cervical cancer and vaginitis. Now, based on their most recent guidelines, cervical cancer, they want to use co-testing for this. So HPV genotyping with oncocytology. Now, in Kazakhstan, the overall number of women is about almost 10 million. And over the past 5 years, the screening for cervical cancer underwent 5 out of 10 women in the age of 30 to 49. Vaccination against HPV is included into the national vaccine calendar in Kazakhstan starting 2023. The smoking by women of 15 years and up is 7%, and HIV per 1,000 people 15 years and up is 0.16%. So full vaccination against HPV for girls by 15 years old, high quality screening of 70% of women at the age of 35, and again at the age of 45, and ensuring treatment of 90% of women who were diagnosed with cervical cancer. So what we have in Kazakhstan, we have the national program, the national screening program for cervical cancer, where the main method is cytology. Our age cohort is 30 to 70 years for the screening. And having programs, recommendations, and timely detection of first systems, and having a strictly regulated system of referral of patients from PHC to get assistance of second and third tier. At every PHC facility, primary healthcare facility in Kazakhstan, there is a room where a woman can get her cytology done for the screening in the age of 30 to 70 years old every 4 years. Main key facts. In Kazakhstan, there's 27 cycles of ART done. In 1 year, 6.6 thousand newborns were born. And as you know, any pathology of the cervix has to do with chronic inflammatory changes the persistence of viruses and human papillomavirus, namely. The pathogenic bacteria become a cause of the change in the amount and the quality of the cervical liquid and other problems. And the classical scheme for detecting the oncological pathology of the cervix is cytology or PAP and PCR for STDs and colposcopy, and as the final diagnosis, histological test. Now, the etiological factors which are there, which can be defined. So 18% of cases, mycoplasma genitalium, 39% were confirmed the diagnosis of cervicitis, 4.5% mycoplasma genitalium, they always had a comorbidity. And bacterial vaginosis, almost 50% of women in cervicitis. The mechanism of development of cervicitis is not quite clear enough, and it leads to the increase of, And when doing ultrasound, the cryptosome is changing in, and they expand and change the structure of the cervix. And let me go to a study. The goal was to assess the accuracy and the applicability for patients with a new method of diagnosing STDs and HPV using PCR from the urine. The design is multi-center prospective. We were doing the test in Almaty and Astana. The population of the patients 20 to 50 years old. We got voluntary written consent, and the procedures we did was manual collection of the by the patient of their urine, cervical swabs, and surveying, and for HPV and STDs. And the diagnostics is a multi-complex PCR. So the relevance, based on WHO data, daily in the world they register more than 1 million new cases. And unfortunately, the majority of which are characterized by treponema, chlamydia, trichomonas, and mycoplasma. In Kazakhstan, the morbidity or the incidence has a decreasing trend, but it remains stably high. In 2022, syphilis incidence was 18 cases per 100,000 of population, which is higher than a similar number in Europe. For women with an untreated STD, they're associated with long-term complications, which can be a chronic diseases like endometritis, which leads to infertility, stillbirth, and higher risks of HIV contraction and decreased quality of life. In Kazakhstan, we need to expand access to diagnosis of STDs, increase the coverage by screening, and overcome the social barriers. Have the first batch of urine taken together with high-tech tests can become the alternative for clinical methods.
We've tried first 58 women, and there is a table. You can see what kind of diseases we have identified. The PCR diagnostics of urinary and cervical samples, 48% are true positive, true negative was 518, false positive 6, and false negative 8. Specificity was 98.5%, and 100% agreement on the STI. So the user acceptance assessment, most of the participants positively assessed the test. 86% are ready to recommend this to others, 90% are ready to use it in future, and 86% consider the test simple and convenient. 60% prefer to collect urine, and 16% collection by healthcare professionals. 28%, no difference. Of course, they want to reduce the barrier between the patient and doctor. And the patient does herself collection of a sample and comes to the lab and gets the results, and based on these results, she can come for a visit with ready assay results. These are the certificates which were used in a lab. Open Healthcare Korean Medical Center. It's a modern center and lab which uses Korean standards, which combines technology, accurate diagnostics, and attentive attitude to each patient. So sometimes we're afraid to go to the doctors. And when did you go for a checkup last time? When did you do a checkup last time? We had research asking women doctors that are seeing patients in the maternity wards, and for the last 5 years they did not do a swab for oncocytology. Although it's 3 minutes to go to a room, to the office, and you can get next day your analysis. The PCR diagnostics, collecting first urinary sample, is quite specific and sensitive. It's preferred by many women with the collection of urine by a healthcare professional, and it increases diagnostics of STI and STD between vulnerable groups. So we need some additional testing in prophylactics of STIs. And all this research that we do for women is quite convenient. And during our polling, we've looked at the contraception method used in Kazakhstan, and it's a barrier method. Hormonal contraception is used only by 5% of women. And all this research, you may scan QR code, and you may have these assays yourself, these tests, using our method of STI tests, including HPV. Thank you, very interesting presentation. If you have any questions, you may approach the doctor. So we are coming to the next presenter, wonderful doctor and our friend, Anatoly Kolmogortsev, Master of Public Health, obstetrician gynecologist, reproductive specialist from IRM Clinic Almaty. Pre-implantation genetic testing in women under 35. Is it necessary? Analysis of aneuploidia in oocyte donors. These 2 days, each second presentation, we're talking about PGT, whether we need this or not, whether we are damaging or not, under 35, after 35 years old. At the end of our presentation, let me try to put an end to this discussion. So we have 23 geneticists in our team. We have to take donor oocytes, and the resultiveness should be high, but unfortunately it's not so high as we want to. So the purpose of this study is to estimate the frequency of chromosome anomalies for women under 35. And these are healthy women, oocyte donors that have their own children that are not infertile, and to discuss the need for routine use of PGT among all patients. What is aneuploidia? Everybody knows. In the literature, we have certain trends showing that the older is the reproductive age, the higher is number of aneuploidy embryos, and that grows linear. But that's not so. PGT traditionally is 35 plus, genetic diseases, repeated implantation failure, spontaneous abortions. So we used the women with donor oocytes from 20 to 34, PGT-A by AACGH. We had a comparative analysis between subgroups, trophectoderm biopsy, and there was a secondary analysis, relationship between the morphological quality of the embryo and its chromosomal status. Characteristics of the study: we've checked 334 women donors with a biopsy for 870 embryos from 20 to 34. Group characteristics. Do you have a laser here? So this sample is not equal, but if we look at the last right column, you would see that the percentage of aneuploidy is not linear, so it varies. At 20 years, it's 20%. At 21, or 22, it's 32%. And the lowest level of aneuploidy was for a group of 32 years old women. So in any case, 73% of embryos were euploid, which is 639, and aneuploid was 26%. So more than 1/4 of all embryos had chromosomal pathologies. So this data doubts that we should not use PGTA for young patients. Detailed analysis by age: under 30, the proportion of euploidy ranges from 67 to 83%, and there is a sharp decline after 33. Peak of euploidy is 32 years. Perhaps it's optimal combination of biological maturity and oocyte quality. From 20 to 24 years, we've surveyed 416 embryos, and in the youngest group, we had the highest percentage of aneuploidia. And this has confirmed my hypothesis, because when I came to our genetics, I said we always take young women, and somehow their percentage of embryos with pathologies are higher than for the donors of 30 years old. And in the literature, it was shown that in this age, most prospective, this immaturity of oocytes, and genetics understand there are microtubes, meiosis, deletion, and they attach to centrosome so tightly that they take extra chromosome away. So there is no linear growth on aneuploidy. So high level of aneuploidy, 1/3 of embryos are aneuploid. So 2 cells are discarded, 2 cells are not thawed. So what we are going to take? the significant frequency in the group of 20 to 24 years old, lack of correlation with morphology, and consequences of refusing PGT. There was a higher rate of cancellations and biochemical pregnancies. Discussion of results. The data obtained indicate that age under 35 does not preclude a significant risk of chromosomal abnormalities. Oocyte donors represent an ideal model which has confirmed this. The lack of PGT increases likelihood of transferring an embryo with chromosomal abnormalities. Without PGT, the overall effectiveness for transfer is reduced. Clinical significance, improving the effectiveness of ART, reducing the time to pregnancy, reducing emotional stress, because after 3 transfers, the patients do not come for repeated cycles, and economic efficiency. Sometimes to do PGT is cheaper to do than to do cryotransfers again and again. Limitations of the traditional approach. The age criterion is not sufficient, morphology is deceptive, and missed opportunities. Refusal of PGT in young patients reduces the overall effectiveness of ART programs. Finally, we need to revise clinical guidelines, because our clinical guidelines, they say that PGT is prescribed for women under 30, after 35, and I believe that age criteria can be removed based on our data. Recommendations to expand indications for PGT, because IVF itself could be an indication for PGT. We need to inform patients, we need to talk to them about the advantages of PGT for all ART programs, and then it requires further research to identify factors impacting the frequency of aneuploidy and optimization of ART protocols. I thank you for your attention. I believe in the golden medium, because some are saying that PGT is harmful, others are saying that PGT should be applied for everyone. We know that most studies show that under 35, the number of aneuploid embryos is only 60–70%. In your work, it's a bit higher. Yes. Why I am coming with this presentation, we are saying that PGT is harmful, but it turns out to be not harmful according to genetics. And secondly, this is just a take-home message, because for your patients, for other specialists, not only in ART, they think that 35 years is a cutoff, that under 35 we have zero aneuploidy. What we, for that, exist in order to show this information to our patients. But if we to take literature data, 35 years is an age when it's 50-50. 36 would be 56, and 34 would be not 0%, but that would be 48%. So it grows gradually. And also, we don't know the results that we get for PGTA, whether those embryos are aneuploid or these results. There is a specificity, so we need to discuss it together with our patients, right? And it's always a joint decision. We talk about restrictions, about pros and cons, and they can choose. In our clinic, we disseminate this among our patients, but only 30% go for PGT. For us, it's 30% of PGTA, and I say that there is always should be a golden medium. Let's move on in the interest of time. A question without a microphone. In our clinical guidelines, there is a concept that we are taking as donors women that have not given birth, like 19 years old. And in Canada, from a daughter of 19 years old women, which don't have children, there is a pathology of fetus development. And Canadians cannot understand why it happens, because before we were taking women which had children, we were taking a pediatrician confirmation, there are no defects, and these are women that can give normal offspring. What about a young woman, a girl which hasn't gave birth before? So you show here that we are taking any women from 19 to 35, and up to 40% is aneuploidia in those cells. That's why we need to raise this issue and discuss it with Professor Lokshin, whether we should leave this issue in our guidelines. Otherwise we won't find donors if we restrict them. And of course, the doctors that recommend donors can recommend to take a donor from a woman with a child, with children. And screening on monogenic diseases is not so expensive. So I would recommend at least to do this screening. It can be not only basic but also expanded screening. For a patient that are thinking about their offspring, I believe that they can pay this money. It just needs to be discussed. And it's better to have in guidelines that there should be a child, that there should be base screening on monogenic diseases. Now Professor Lokshin wants to discuss. Who introduced this? It wasn't me. Mr. President, tell us please. Who introduced this? In our clinic, of course, we should not only give birth, but there should be a child. How can we believe the blood counts, the assays? We know very little in genetics. If you take a girl, a woman without a child, you are risky, because there are people who would miss this opportunity of having a child. And thank you for paying attention to this. And also, in parallel, you made a donor, and we have a big cluster of work with discarded embryos that we don't know at all. We don't know at all what's going to be and how. And I believe in this guideline we should include the requirement to take them only after genetic screening of both parents. And if we are going to hatch unknown material, and this woman is going to give us birth of problematic children, she won't say thank you to us. We can introduce PGT donorship, and we can give you 25 examples. We need to do PGT before transfer, before thawing the embryos and transferring them. This is inaudible. No mic is used. We're going to write internal SOP, and Tamara Muftahana is going to sign it. You've raised some important issues. Let's discuss it. One more question. Have you taken in consideration male factor when you've checked this? Yes. The share of male factor is 2% only. And the type of stimulation, is there a difference between quality? All these donors are using histogen protocol, so it's a similar protocol.
Colleagues, we're moving on to PRP in Lake Askar. She's here. PRP and regenerative technologies in the treatment of repeated and unsuccessful fertilization. Good day, distinguished colleagues. The topic of my report is devoted to one of the difficult emotionally problems of reproductive medicine, repeated unsuccessful fertilizations or implantations. Repeated implantation failures. Sometimes they do it all right, they choose the good quality embryos, they did a transfer correctly, but the implantation doesn't happen. And if such situations repeat, when we talk about repeated implantation failures, Today, I wanted to share our experience of using regenerative technology, PRP technology, to improve the endometrium and have more chances of pregnancy. So we all know that the main reasons of repeated implantation failures can be grouped into three groups. Endometrial factor, when the problem is in the uterus, and when it's idiopathical, when we don't know the reasons, and in multifactorial, when there's many factors. Now, modern approaches to RF is based on personalization. So we are basing the treatment based on the causes of why the pregnancy didn't happen. So repeated implantation failure. We define the implantation window. We do immunomodulations. We correct endometritis, and we use regenerative technologies such as PRP and ultrasound cavitation of the uterine cavity and the receptiveness of the endometrium. And this process is happening at a certain time, which we call the implantation window, and it only lasts several days, and it opens up after 6 to 7 days after the peak of LH. The problems with the implantation window can also be in two groups. Morphological, when the endometrium thickness is less than 7 millimeters. When in the uteral cavity you have synechiae or scar tissue and inflammatory processes, so endometritis, which will hurt the receptiveness of the endometrium. Also, for some reasons, this implantation window can open too early or too late, and this is a condition that we call a shift of the implantation window. At that time, the embryo just cannot synchronize with the endometrium, and the implantation doesn't happen. What we do in situations like that, we use regenerative technology, such as we do correction of chronic endometritis. We all know that implantation takes 3 stages, and to do successfully, to go through all these 3 stages, we need to activate the signal molecules, such as integrins, selectins, mucins, and other factors. So when there's an inflammation or a hormonal imbalance, the expression of these molecules reduces, and the receptiveness of the endometrium will also be violated. So that's when we do technology. PRP, like PRP is not a medicine, it's the own biological autologous material, which is platelet rich. It's rich in cytokines, growth factors. PRP preparation is in several stages. First, they do a collection of the patient's own venous blood. Then the first centrifuging is done when the blood is divided into fraction, and they isolate the plasma, which we call the triple P, pure platelet plasma. Then in this plasma, to this plasma we add thrombin or calcium chloride, and we do a secondary centrifuging, and we obtain plasma, which is a PRP concentrate, platelet-rich plasma, rich in cytokines and growth factors as well, which we use for the irrigation of the cervical cavity. Now, PRP will recover the endometrium using hemostasis, so first the tissues recover, regenerate. After that, there's inflammatory response to make sure it's not too much. Then we activate the vessels, and in the endometrium, then there's proliferation of cells, a updating of the cells of the endometrium, and remodeling of cells finally. So there's a restructuring of the tissues. The endometrium becomes more alive, more prepared for implantation of the embryo. Also in our clinic, we use ultrasound cavitation of the uteral cavity, which is also a soft method of regenerative technology, where using ultrasound, low-frequency ultrasound in a liquid environment, you have micro bubbles which will burst in the cavity, and there's regeneration and better blood supply to the endometrium. The dead tissue will be removed, and it restores the reparation and improves the reparation and regeneration in the mucous membrane of the uterus. In which pathological diseases or conditions of the endometrium we use these regenerative technology methods? Within endometritis, which you see in 2 to 8% of women who are getting treated with ART, the causes are inflammation, scraping, bad blood flow, and resistance to hormonal therapy by the endometrium. Also, chronic endometritis, which is one of the main causes of repeated implantation failures. And based on literature, it's seen in 22 to 25% of women who are getting treated for infertility, and in 20% of patients who have in their history repeated implantation failures. We are doing regenerative technology in the natural cycle and in HRT on the 6th day of the menstrual cycle by combining ultrasound cavitation with PRP therapy. So taking turns. First we do ultrasound cavitation, then PRP therapy. So 3 times US cavitation and 3 times PRP therapy. We've done a retrospective study at our clinic where we included women with chronic endometritis and a thin endometrium. And before the prescription of therapy, all women had hysteroscopy done from the endometrium in the 2nd phase of the menstrual cycle, in the HRT, on the 6th day of taking progesterone, in the natural cycle on the 7th day after the peak of LH. We would check the expression of the markers of inflammation, 138, and the signal molecules and the lifts and the integrins. We divided the women into groups. In the first group, you have 1.5 minutes left. In the first one, we used combined therapy, and in the second one, antibiotic therapy. Then we did a repeat endometrial biopsy on the same day of the cycle for the same markers which we studied for in the beginning. And we did the transfer of the embryo and assessed the pregnancy rate and the take-home baby rate. And finally, in the study, as a result, we saw that combined treatment of chronic endometritis and a thin endometrium were 20% more effective than the standard therapy, apart from having less inflammation markers. There was more signaling molecules and more pregnancy rate and more take-home baby rate. And our research was published in the High Cordell Journal, International Journal of Fertility and Sterility. And we are continuing our research of this pathology. Thank you very much. Thank you. Unfortunately, we don't have time for questions. Possibly the next speaker will answer if people have questions. I'd like to pass it to the next speaker, Yulia Zabrodina, obstetrician, gynecologist, PhD, lecturer of the Department of Obstetrics, Astana Medical University. Good day, dear colleagues. Let me continue the topic of the previous speaker, PRP therapy, a new chance for the thin endometrium. We know that infertility is a social problem. That's why ART programs are so in demand today. But in spite of the improvement of ART programs, over 60% of cycles are unsuccessful. And the endometrium is 2/3 of all the causes, and the frequency of thin endometrium can go up to 8.5%. Currently, there are plenty of ways of treating thin endometrium, but some of the patients still remain non-sensitive to neither of these methods, so looking for alternative therapy continues. And in recent years, regenerative technology is becoming more popular, using platelet-rich autoplasma. Using PRP in therapeutic purposes is based on a high content of platelets, more than 1 million per milliliter. And on this slide, we're seeing the growth factors and their functional activity, which are part of PRP. Their effect is based on the ability to deliver cytokines and base growth factors and alpha granules. Taking into account these factors, their ability to do regenerative proliferative action on the tissue, we decided to do our own research and study the effectiveness of PRP when treating the thin endometrium. In this way, we did a study for which we selected 200 patients who underwent in vitro fertilization at the Perinatal Prevention Center between September 21 and September 23. Inclusion criteria age 18 to 40, canceled previous transfer due to thin endometrium, endometrial thickness less than 7 millimeters on the day of the gonadotropin injection, or on the day of the start of progesterone use in the cryo protocol. Having a blastocyst of good quality, 4AB, isocoagulation, normal karyotype of the spouses, and sign from consent to participate. Exclusion criteria is hypoplasia, having a septum, genital endometriosis, premature ovarian failure, hemoglobin less than 120, platelets less than 150, use of donor material, pathological karyotype, positive test for antibodies, low quality of embryos. The goal of the study was to study the effectiveness of using PRP as part of a comprehensive treatment for women with a thin endometrium in relation to its thickness, receptivity, and the outcomes of assisted reproductive technology programs. We chose 200 patients. Before the start, we did for all of them an ultrasound of the pelvis and a biopsy for the sensitivity receptors, after which we did a randomization of patients, and they were divided into two groups. Group 100 participants, they were getting HRT. Second group, apart from HRT, were getting an infusion with PRP. First, we assessed the thickness and the sensitivity of receptors after the treatment. Second stage, we were doing a transfer of the embryo of high quality morphologically, and we were assessing clinical pregnancy and the outcome of pregnancy. The whole preparation of the endometrium started from the second day of the cycle, after we did the transvaginal ultrasound, to the patients of both groups. They got traditional therapy 3 times a day, vaginal progesterone, and their thickness was controlled when it was over 7 millimeters. We used vaginal progesterone at 200 milligrams 3 times a day. And for the other group of patients, we did autoplasma injections in the volume of 0.5 milliliters. For both groups, on day 6 of progesterone intake during the expected implantation window for subsequent immunohistochemical examination. The medication was continued until day 21, and it was discontinued. When the onset of menstruation, preparation began according to the same scheme, but on the 6th day of progesterone, embryo transfer was performed. And the autoplasma was got using double centrifuging. First time we centrifuged for 10 minutes at 900 rounds per minute. Second time, 15 minutes at 1500 RPMs. Before the moment of the study, the patients of both groups were fully compatible by status. The age was 35 years. They had a normal BMI. The majority of them were officially married and had higher education. Also, the patients were fully compatible for duration of infertility and the fertility type. Mainly, the interventions were scraping, 1/4. Also to interventions for removing synechia. In terms of the results, the thickness of the endometrium at the onset was less than 7 millimeters, and it didn't have statistical differences. After the treatment, in the first group, the endometrium thickness was 7.5 millimeters, in the second one, 8.7. The growth of the endometrium in the first group was 165, in the second one, 283 millimeters. And the differences were statistically significant. And this histogram shows the receptiveness of the endometrium in both groups before treatment. There weren't any statistical differences found between the groups. After the treatment, the receptivity rates were both statistically higher in the intervention group. The embryo transfer was only done when the endometrium was 7 millimeters or more. And there was no endometrium growth, and that's why the transfer was cancelled. 14 patients in the first group didn't achieve the thickness, and the second intervention group, it was 4%. 14 days after the transfer of the embryo, they would do a blood test for beta HCG for biochemical pregnancy, and that biochemical pregnancy was higher by 16.03% in the second group. As for the frequency of clinical pregnancy, if 7 days after the HCG test, they did transvaginal ultrasound to confirm the clinical pregnancy, and the clinical pregnancy rate was 15% higher in the intervention group, 31.4 in the first group and 46 in the second. And the childbirth was more in the intervention group. We also studied the timing and methods of delivery, and there wasn't any statistical difference between the groups here. One of the stages of the study, we did a ROC analysis in order to find the thresholds of the thickness and receptance of the endometrium, which will increase the likelihood of childbirth. And it's at 8.10 millimeters, the point which can be used as a threshold for the thickness of the endometrium. The cutoff point for the progesterone was 86.5%. Estrogen receptors in glands is 60%, in the stroma 59.5%. One of the stages was finding side effects and possible complications. Out of 100 participants who did PRP therapy, 32% felt unpleasant when the plasma was introduced. Some had insignificant pulling pains in the abdominal area, and 57% didn't have any negative reactions. Nothing was painful. None of the participants found any infectious or other diseases after the intervention. Thus, we came to the conclusion that PRP therapy increases endometrial thickness and improves its receptivity, thereby enhancing the effectiveness of ART programs. The use of autologous PRP is not associated with allergic reactions, infectious complications, or other adverse effects, making it a safe, natural source of mitogens and growth factors with intense proliferative capacity. Therefore, PRP therapy can be proposed as an effective and safe treatment option for women with thin endometrium and assisted reproductive technology programs. In our research, we didn't have any conflict of interest. Thank you very much.
Thank you. It was a very interesting presentation and quite practical. And since every year we see the growth of presentations on PRP, that is quite pressing, and that gives us the resultiveness. Going back to PGTA, now for the older patients, 40 plus, Kalidinova, Aigerim. My topic is retrospective study of IVF results with PGTA for women aged 40 plus. This is quite pressing because for IVF mostly come women of the older reproductive age, and there is a trend with the increase of women's age, there is a growth of aneuploid embryos. And this shows two embryos, euploid and aneuploid embryos at the same development age. Morphologically, they have no differences. However, genetically, there is a big difference. To solve this issue for women 40 plus, it's PGTA, which determines whether we transfer this embryo or not, reducing the share of ineffective transfers and increasing cumulative live birth rate per cycle and improving cost effectiveness of this method. And since the IVF programs are growing, the programs are improved, including embryo cultivation, biopsy techniques, and genetic testing, and even using PGTA with one or two blastocysts reduces the number of transfers and accelerates the completion of the IVF-XVII cycle. So the goal of our study is to evaluate the clinical and the biological result of IVF-XVII programs for PGTA in patients aged 40 plus. The retrospective analysis included 70 patients, 40 plus. There was 148 embryos assessed. The method, the analysis was conducted from the 1st April to the 30th of July in two of our clinics, ECOMED and NGC. The inclusion criteria is having her own eggs, egg cells without donor programs. This is the PGTA biopsy given by our embryologist. So here you can see the PGTA process, cutting trifactoderma. We are taking 5-6 cells from the embryo, and thus we are not damaging the major biomass of cells. PGTA is not much different from IVF-XVII programs, but at the embryo cultivation, at the blastocyst stage on the 5th or 6th day, we do trifactoderma biopsy. And this biopsy area we send for PGTA. And the embryo itself we freeze until we get the results. Based on our result, out of 148 embryos, we received 48 euploid embryos, which means 32%. So 1/3 of embryos are euploid, so we can only transfer them. There are no statistical significance from modern data, foreign data. So out of 48 embryos, only 21 was transferred, so 10 embryos have resulted in clinical pregnancy. And that means 47.6%. So clinical pregnancy rate is almost 50% for women 40 plus who have her own oocytes. We also use IDA score with artificial intelligence. We've tried to compare the morphological index of the IDA score with the results of PGTA and clinical pregnancy. But this topic is still being researched, so we don't have morphological difference for the embryos of the euploid and aneuploid, so the correlation is low. However, the pregnancy frequency, according to IDA score, leads to results in pregnancy. So the results of our research is that the aneuploids are 2/3, the proportion of euploid pregnancies is 1/3. So the frequency is almost 50%. That is clinically efficient. IDA score correlation with the euploidia is weak, and IDA score correlation with NSC is moderate. Recommended tactics is to do a PGTA with morphokinetics. So combination of these methods increases effectiveness of ECO-XC program. High share of unemployed embryos emphasizes the need of PGTA for women of older reproductive age. For effective selection of embryos and to decrease unsuccessful embryos transfers, because that improves reproductive outcomes for patients, and combined method allows us to choose euploid embryos. These are my sources, no conflict of interest. Thank you for your presentation. We've seen a clear report on the patients older than 40. It's quite pressing because now we see that the patients are growing older, those that participate in ART. Dr. Alatau Bagarova, Janar, Deputy Medical Director of IRM Center Kabanbai. The poor response, trends and tactics. At the modern stage, we all know that the incidence of poor response, according to literature, is 9 to 24% of women in all ovarian stimulation cycles. The problem, especially important in the context of increasing age of patients seeking help, shift in reproductive age, and low ovarian reserve and age directly affect the effectiveness of ART and the likelihood of pregnancy. The issue of economic and psychological burden on the patient and the clinic makes the problem even more significant. There are different criteria. There used to be Bologna criteria. Then I know that we had European colleagues who decided to divide the responders into 4 groups according to Poseidon criteria. These are poor responders, and they were spread into below 35 and older than 35. So young women before 35 and after 35 with low level of hormones and low number of antral follicles. We all know this criteria. What we know is that regardless of the ovarian stimulation method, regardless of the anti-age preparation, whatever we use for our women, we not always may reach the number of oocytes that is desirable to give us the best result of our pregnancy. So not high level of gonadotropins did not increase the number of oocytes on the puncture. And everything which was mentioned before, genetics, epigenetics, metabolism, lifestyle, all of that is impacting epigenetically the outcomes of our pregnancy. So in general, we had an analysis, retrospective analysis of our commercial programs. These are the women that were not included into the insurance scheme. These were 3,500 programs, and the patients were divided, which had 3 or fewer oocytes per puncture. So almost 30% of women in commercial IVF programs, they have poor response. So we divided them for women under 35 and older than 35. Older group, the percentage was higher. It was 63%, which was expected. In the transfer cycle for young women, take-home baby rate, despite of the poor response, was high, 35.7% for transfer, and older than 35, there was a tendency to have a less efficiency, 24%, and take-home baby rate is for women who did not take the. Of course, these are not all women older than 35, but these are more women older than 35. We do not transfer embryos of bad quality, and if the bad quality was not having a satisfaction or bad quality of embryos, and later we have the tendency, and we offer to the women not to leave this, but to use it for genetical screening. According to our annual report, and according to the global statistics, the younger the woman, the higher percentage of aneuploid embryos. And as it is confirmed by the statistics, if we are to take the CGH, it is leveled, and 40 plus the efficacy is again. Probably there were cycles with oocyte donor cycles. We started to increase the poor response programs when we cryopreserve oocytes to improve the outcomes for pregnancy. So each doctor, this is not my patient, but last winter a patient came 30 years old, and there was a tubal occlusion, and in the first stimulation program, she did not receive oocytes. Now she moved to a different oocytes, and there she received 2 oocytes, and they've made another program, and then this woman have 4 embryos there was a biopsy on ACGH. So this is the accumulation program, and there was a transfer in March, so she gave birth to a healthy child, healthy boy, and she had urgent delivery. So we need to discuss all types of treatment, high risk of program cancellation, and PGTA recommendations to the patients that you need a lot of programs, not just single program, that it will be economically costly. Perhaps it's better to take oocyte donors, you will get a fast effect. However, we think what to do, whether we should do embryo transfer. Shall we store the cells to increase this? But not all women are agreeing to clinical interference. So we do all types of stimulation, as I said. And there are a lot of questions faced by our practical doctors, whether to transfer in a fresh cycle, whether all embryos should be transferred in PGTA. So I believe that should be a dialogue with the patient and the doctor, and to accept joint decisions. I've heard that there is aneuploidia, that we may be mistaken, and there are patients who require 3 biopsies. I hear that Mutalipov, they take bioptat and they send to 2 different labs. They do cross testing of one single embryo for genetic screening. So their rate of mistake could be 50%. And we have patients that require this during biopsy, and we said that we've had mosaicism, and then it was removed because probably this was a mosaic and not aneuploid. So what we heard from Mutalipov about the transfer and about reprogramming somatic cells into gametes, I believe that this is science fiction. It's too expensive. Whether we're going to come to this, it's only future can show this. So for a practical doctor, it's quite difficult. So we are increasing PGTA in this age group, and it's a big load on a doctor, because low efficacy of such programs, sometimes it decreases the good indicators for the clinic. But that is not a method to refuse the patients. So in what area we should go, it's good. But I believe that you need to inform the population, and that there should be state programs to assess the families and study their reproductive potential. I believe that's the way where the government should apply its efforts. And I had no conflict of interest. This was our internal data. Thank you, Zhanar Borisovna. You have summarized the entire topics that were discussed previously. And although we don't have answers to many questions, nevertheless, we do not stop in our research, because in Kazakhstan we have a lot of opportunities for academic research. And a short question, please speak to the mic. In your presentation and previous presentations, you were mentioning that this is an issue of transferring aneuploid embryos. And in the yesterday presentation, Mutalipov was saying that it's not proven that using PGTA testing reflecting the future fate of the embryo with a self-correction and giving birth to a healthy child. What do you say to a patient when everything is clear with her? When you talk about transfer of aneuploid embryo, we sign embryo informed consent that we are recycling or discarding aneuploid embryo. So we can do testing of the bioptat, but we do discarding. We are signing the informed consent for the utilization. But do you tell her that it may lead to give birth to a healthy child? So it's your decision of the patient. We need to tell the patient that aneuploid, because what we have here is mosaic algorithms, and aneuploid embryos were not transferred to patients. And we had a patient who said, why you are you have discarded my embryos. I said, you've signed a informed consent, and I don't want my embryo to be destroyed. Perhaps I would like to take an unemployed embryo. So in that case, there should be informed consent on transferring unemployed embryo and give the chance to women to be pregnant or not.
Yeah, so they make a decision up front. Okay, moving on, reproductive health with HIV infection and using ART. Igor Mahmetova, over to you. Good day, colleagues. So, reproductive health with HIV infection, standards and algorithms, application of ART. HIV infection is a slow progressive disease caused by virus immunodeficiency. For the past 40 years, HIV, from a deadly diagnosis, turned into a chronic controlled state. And the main ones share made up by people of reproductive age. ARV therapy, 60% are children and 73% are adults. So, based on data in 2025, the prevalence of HIV among the population aged 15 to 49 years old is 0.34%. The largest indicators are observed in East Kazakhstan, 0.97%, Karaganda, 0.77%, and Pavlodar, 0.72%. In particular, Almaty shows 0.5%. In Kazakhstan, the data shows that we need comprehensive measures aimed at not only treatment, but the reproductive health of HIV patients. Our goal is to rate the efficiency and structure of IVF in HIV-positive patients. It was conducted in the ECOMED clinic on Almaty 20 to 2025. We included a total of 48 IVF programs for couples where one or both partners had HIV with code B20. Patients were all outpatient. They were taking ART. We divided the women into age groups up to 30, 31 to 35, 36, 40, 41, 45. The clinical stages are different, first to fourth, and the decision to include in IVF through a multidisciplinary approach consultation where we had HIV specialists and all the narrow specialists. The research methods: patients with HIV B20, selection by criteria for reproductive health, then consilium, where they would include an HIV specialist who would be observing these patients, 48 IVF programs, 20 to 2025, grouped by age and serostatus. Pro-insert is a safe processing of sperm for safe preparation of sperm in HIV-positive patients, gradient division of sperm. Statistical analysis, Fisher 95% confidence interval Wald method that we used. Majority of patients, 68.7%, are in the first clinical stage. It indicates an early stage. On the second stage, we reached 23% of patients. Heavy severe forms, we were seeing significantly less often. Stage 3, 22%, stage 4, 6%. So the predominance of early stages and geographically, the IVF in HIV patients, we had a total of 48 patients. Out of them, Kazakh citizens, 43. Other countries, including Uzbekistan, 4, and Netherlands, 1. And the biggest share of participants of the IVF program is in the city of Almaty, 41%, which shows the concept of specialized clinics and accessibility of reproductive technology. The Almaty region takes second place with 12.5%, followed by the Zhambal region with 10.4%. and other regions in Kazakhstan make up 35%, which shows that the program is expanding outside the southern region. We've analyzed 48 couples participating in the IVF program. The majority of couples are 31 to 35 years, which corresponds to reproductively active age. Concordant couples with both partners are HIV positive accounted for 48%. Discordant, where one partner is HIV positive, 52%. As you can see, we've divided them into under 38 patients, out of them 5 were pregnant with clinical pregnancy rate. Out of them, 12 patients were pregnant. 36, 40 years is 15 patients, out of them 4. And 41, 45, 4 patients, out of them 2 pregnant. After 35 years old, there's a trend for the reduction of effectiveness. The clinical pregnancy rate is 48%. The IVF program of people living with HIV is demonstrating satisfactory efficiency. The best results were seen in couples with HIV-positive men, 59%, which confirms the effectiveness of ProInsert. The overall effectiveness of the program for people with HIV, 48%, which is comparable to the general population. The results of the study: IVF programs for people living with HIV demonstrate satisfactory effectiveness. Frequency of clinical pregnancy is 48%, which is comparable to the general populations. The age of women remains the key prognostic factor. Best results are observed at age under 35 years. After 35 years, there's a gradual decrease in effectiveness. Conclusions: the effective of ART provides viral suppression and allows to conduct ART programs without risk of transmission and infection to the partner or child. HIV infection and stable remission is not a counterindication for implementation of reproductive functions, does not reduce IVF outcomes. And it's necessary to extend cohorts of observation, standardized reporting, and develop united clinical recommendations to conduct patient with HIV and ART programs. No conflict of interest. Thank you very much. Thank you very much. Truly is a topic that's always relevant. We know that it's there. So, final presentation of the day, and we pass it now to Kamala Husseinova, IRM Clinic Laboratory Head. An intelligent system for predicting the success of IVF treatment. Please make it less than 10 minutes. Distinguished colleagues, I'm very glad to be here at this conference. Very many useful presentations. We've seen much was said today and yesterday about AI. My presentation is work done jointly with 2 universities in the UK, the Robert Gordon University and University of Aberdeen. They have reached out to us with a suggestion to do this joint research on the development of an intellectual system which would forecast the outcomes of IVF for women even before getting enrolled in the program. Now, what the relevance is of this matter? We know that we have a lot of IVF programs done in the world, but based on the results, the numbers are very different from clinic to clinic. And the goal was to create an early forecasting tool for IVF outcomes for the reproduction specialist and the patient. And the development of the system is suggesting that we try to understand to which extent a certain woman will be successful in the IVF program even before we start the stimulation. So from our clinic, we took almost 4,500 cases of women who did the program of IVF at our clinic. And these were women of very different ages. The exclusion criteria were only karyotype differences, very severe forms of male infertility, and also donorship cells and surrogacy. So all women went with their own cells and they would carry their own pregnancy. And we proposed 8 criteria, entry criteria, which were all available before the stimulation, and another 8 criteria was generated by AI for the expansion. As a result, we had 15 criteria. The validation of the results was done using cross-examination and independent test sets. This is what the interface of this program looks like. And there it says what the algorithm is that was used and how much initial data was used. So here a little bit more detail. These are the 8 parameters, entry parameters we use, which we deem to be the most necessary to calculate their effectiveness. That's the age of the woman, age of man, BMI, the AMA, the number of follicles, the thickness, endometrial thickness, and the blastocysts. We took the ones that were of excellent quality and the blastocysts that were of poor quality. The 8 additional criteria that AI added, I wanted to name the total number of blastocysts, then the share of excellent blastocysts to the total number. And AI also took a few risk indicators, one of which was the age of a woman over 35 and an AMH level below 1. Some technical information about the program. Maybe some of you are interested in what algorithms were used, which programs. So this is the main page where you input the clinical parameters of the patient, based on which the machine will then calculate the probability of IVF success. A high accuracy, 93% the program counted. Also there was high sensitivity and specificity of how the program worked. And now I want to demonstrate to you how you input the data and how the result is then shown here. The age of the woman and man are input, the AMH, the BMI, you can do it manually or you can use this calculator. The endometrial thickness is input and the number of follicles and the number of blastocysts that you're presupposing, and the program will give you this result. Well, this is just an example once again. And what else I wanted to say to finalize that the development of this kind of system is, we believe, an effective clinical decision support tool for the reproduction specialists, for them to, when they consult the patient, so that they can say to the patient what her chances of success are, so that the patients are psychologically and financially prepared for, whether it's going to work or not. So when we're doing the consultation, the reproduction specialist says you have about 50% chance. Here it's different. Like, they can actually show to the patient that with your input data, you can get this kind of prediction. And we need to realize that there's also a mobile version of this app. There's a possibility to enter data not one by one, but together, like a group of patients you input, and the program will analyze that too. And we need to realize that these are just our first steps in this direction of creating this AI program. We plan to expand our database, expand the input data in order to have a more personalized approach to the treatment of women with infertility. Thank you for listening. If you have any questions, I can answer, but we don't have time. Thank you for having saved some time. One question. So we can be here until tomorrow morning. I wish that you have a list for the AI of male factors too, smoking, alcohol, profession, and for women too, because there's an article that came out from the US that said that they believe infertility is dependent on external factors to a significant extent. Thank you. I would like to thank all the participants of the session. We had different reports, like about big data also, and we had some statistics related presentations, so please be conscious about your data. And as always, we need more quality research that we can rely on. Thank you, Yulia. My big request for the closing, can everybody sit in front, these two front rows? I want everybody to sit here in the front. And I invite Dr. Vladislav and Marcus. Distinguished colleagues, Yulia, maybe you can sit with us. If you can just move one chair. Well, we've survived until the end. If there's somebody from the organizers, like if you can, they're waiting. There's many people, so let's bring people in. So it's a final to our seminar, and we're glad that our colleagues, esteemed colleagues, are here. I just wanted to tell you that over the 3 days of our Congress, we've listened to 182 presentations. 182 presentations, right? And our participants who were in the room, there were 32 countries, Serbia, Switzerland, we forgot to say Singapore, we had representatives from Aspire, 32 countries, which is a record for this Congress. And in our workshop, we had the presidents of IFFS, 3 people. Aspire was represented by 5 people. The Office of Aspire from Singapore. We were very happy to greet here almost 80 specialists representing the Russian Association of Reproduction, of Human Reproduction. In our Congress, we had about 62 people from Uzbekistan representing the Uzbek Association of Reproductive Medicine. We had the president of the Armenian Association of Reproductive Medicine. Georgia was represented by several specialists. Tajikistan, Kyrgyzstan, and countries that they're all listed there. A lot of information came out in the media. The Ministry of Health is spreading that. We will publish it. We'll put Maulen Ashimbayev's welcome, which is the head of the Senate, the second most important person who very highly valued the work of the Kazakh reproductologist, which is super important that a politician like that, number 2 after the president, wrote about that. And we had a welcome from the Deputy Prime Minister who's in charge of healthcare, Bozumbayev, and the Minister of Health, of course, as well. You've seen all the participants. And of course, very important that, we had the 4 or I guess 5 pre-congresses, right? To our big amazement that the pre-seminar that Visamed organized with the embryologists from the different countries was really, really interesting. And It was about 70 people participating there. For the first time, we did a wonderful workshop on the endometrium, and I'm very thankful to Professor Talipova, who we brought specially, flew in here, and other colleagues, ours, and they were standing in the audience. There were so many specialists. It was good communication. Unfortunately, our Brazilian colleague got sick, but he did still a workshop on ovulation stimulation. We had a wonderful workshop on management and healthcare. That was kind of my idea, modest idea, but it was wonderful too because we didn't kind of lock into our own audience, but we invited the leading managers of Kazakhstan, the large clinics in Kazakhstan. You've seen that. And it was a dinner there as well, and I think everybody talked for a long time. I think that's very valuable. Now, one of the best sessions was a session on the extragenital conditions. The Ministry of Health told me last year, like, why are you going into this? This is none of your business. Well, it's my business to decide what to do. And we invited the main specialists, a hepatologist, an allergist, a hematologist, a cardiologist. Yuri Papo sent a very qualified specialist by my request, an endocrinologist, right? So we had the allergist really amazed me. They had data, the head allergist of Kazakhstan, some great information. The room was full, and it's important. Now, why are we not meant to know this? We're responsible for the final. If we give a pregnancy to a woman who has an extragenital pathology and she dies or in the process or after, it doesn't make any sense. So that's why we're responsible and we should be informed. And now my dream is to do a big conference, pregnancy and extragenital pathology. And we'll do that under the auspices of KARM. We don't care about the Ministry of Health, nobody else. It's for the patients. We need to do that for the patients. It's important to do that. And the Ministry of Health will support that project. And we had a very good section on urology and andrology. It was a full house. We had professors from Georgia, Uzbekistan, Kazakhstan, Russia. Really good. I'm very thankful to our urologists and andrologists for this active involvement. The Institute of Urology, it worked out very well, very quality. The psychology section today, very interesting. For the first time, the Professor Zhanna Gardanova participated from the Russian University. I think the first medical named after Pirogov, was it? The second medical university. It was really good. We've known Zhanna from 25 years. I was surprised by her desire to be here with us today. And Elena Nikolaevna, I'm very thankful to you for this participation.
So such a broad spectrum, and I'm not talking about reproductology, embryology, genetics. We had a center, our leading center for biotechnology, Yuri Alexandrovich Skiba. Thank you, you were always with us, and I appreciate that. And in the Center of Biotechnology, I introduced there our minister and our leading specialist. We had there a meeting of the Academy of Science. Our minister was surprised because I was so insisting for her to come, and she had a tour of your center. So we need to work more with specialists. We shouldn't trust to some strange people, because this time we have rejected 55 participants because there are poor presentations, just reviews, and there were some presentations without statistical processing, because pen less than 0.1 cannot be accepted. So we need to accept statisticians and invite them. Also AI, quite important. And about AI, we should have adults talking about this problem from all aspects, or somebody who has done something and achieved something. Just philosophy is not enough. A president of Aspire or FFLS, or when I talk about this, when our president of Kazakhstan talks about this, but when people who are doing something, they should show their data and not just to say about who should do what. So everything which is said today would be tried and tested and followed tomorrow. So when you come to a clinic, they would say, we want to show you this, we want to show that. We should be open to each other. Because if you don't show anything, that means that you don't have anything. Why they are then presenting and saying some fairy tales from the podium? I think our doctors that came from all over Kazakhstan, from all over of Uzbekistan, a professor from Urgench, that's where Hiva. She came with a team of her specialists, Bukhara, Samarkand, leading centers, Alexandra Khamtsova, Khujand. And that is so valuable because the opinion of each leading specialist is important for us. A Russian young professor, she went to Tajikistan to work together with our colleagues, and she would do that clinic because I know her as a good specialist of the Ural Institute of Obstetricians and Gynecology. I'd like to thank those that have trusted us.
IFFS, I would like to really congratulate Professor Lokchin and all the people that worked for the success of this Congress. The KARM Association, we were very impressed about the quality of the program, the social events as well, for sure, great party last night. And I wish you all a very successful year and probably another successful meeting next year. It was a great opportunity to network with all of the presidents of the associations from the region, from Uzbekistan, from Armenia. We had a very fruitful conversation yesterday, and we will continue to work together. So thank you very much.
Thank you very much.
And congratulations.
Thank you. Почти 100 человек из Российской Федерации.
Almost 100 people from Russian Federation. Two words, what if I say 3 words? This was a festival that was a truly international congress at the highest level. I thank you for all these years that ART exists in Kazakhstan, for all these years when it has started working, and until now, Kazakhstan Association of Reproductive Medicine is working with us. We thank you for that, and we wish you further success, and we wait you for the 18th conference. We thank you so much, and we're going to visit you to celebrate the 40th anniversary of a child in the Russian Federation, the 9th to 12th September in Moscow. We're going to go to Moscow, all of us. I have just one wish. We should work together so that between Almaty and Yerevan we should have a direct flight and there are no more other problems. This year in 2026 we're going to have a flight to Tokyo, to Poland, and maybe to Yerevan. We would request our president. Tokyo through Yerevan. Yesterday we learned that our president has signed a contract in US for 15 Daimlers, the huge Boeings. Also we've signed some document of Abraham for the peace in the Middle East. That was an important event. A leader of our state met with President Trump, and Kazakhstan again becomes a leader in Central Asia, and it's a protection of our borders from all who surrounds us, and we should have only benevolent relationship, and that event coincided with our KARM Congress. So I'd like to declare to you on the 3rd and 4th April in Turkestan, we're going to have our Southern Congress of KARM, regional conference, and the 12th and 14th of November, there will be 18th Congress of Kazakhstani Association. Because Vilaska and Grisinger, they all wanted to participate, so we would try to book this. That would be next year in 2026, the 12th to 14th of November. So if you want to say anything. Aktau, I don't know. These are 2 cities, Turkestan and Almaty. because it's quite expensive. So that is with ISRM. Otherwise, everybody would be in the mountains. November is our month in the world. We are not going to move. Radzinski is not moving from September. Raj is always in September in Russia. So it's a good timing. Why is it autumn? Because first we visit Ashria, then we visit Raj in Russia, Radzinski, ISRM. We gather speakers because that is on purpose. We agree there with speakers. We can have in October a round table. So many issues we have which are topical, like extragenital diseases. And another section which was very interesting, it's like scars on the uterus. What is the, why we're talking about this? We've called Professor Shmakov a star in Russia and throughout the world. We've asked two of our Georgian colleagues, and Shmakov said that our obstetricians and gynecologists are quite advanced in Kazakhstan. And Souley Sienova, they have presented their data. So the session, I like to listen to that session. There was a lot of experience, a lot of material. Everything that we have heard are miracles. I've heard Mark Kursor, it was 11th cessation. So this session, I thank you for this idea, because cessation is quite important. Section, and we're going to have specific areas for our Congress. I'd like to thank ECOMED, Persona, my PhD doctors. So we need to do science, but science should be modern. It should be having good statistics with a lot of materials. When they show 32 and 25, maybe there is no statistical accuracy, right? Because when we hear and they compare, I had here 10% and there it's 20%. That is not accurate, because statistical, they would recalculate this. So statistic is the basic in the medicine. We cannot believe 20% and 10, because when we recalculate, it should match. So next year I'm going to add a statistician, my PhD doctor, Sivara Ilmuratova. She was trained in her course. She was uploaded by the council, and based on 30-40 cases, she presented so beautifully where everything matched. There were 7 articles in Scopus made by one person, not in our local Scopus, but in the first, second quartile. So Yulia Koloda, she is a master, and I would request you to curate us, because she is a scientific secretary of Reproductology Journal of Russian Federation. So we admire your depth of knowledge. So Edgar's past president of FFAS, Edgar's Mokano, his Hirsch index is almost 50.
And just to remind everybody that after 2026, there's 2027. And in 2027, the IFFS has the World Congress in Brisbane, Australia. Anybody that does not want to go to Australia here, please raise your hand.
Everybody wants.
But also to say, this is the time to think research, this is the time to work together, this is the time to pull the data, this is the time to write the abstracts and say, we want to be there. As always, there will
in
be...
Japan, it was about 8 from Kazakhstan and speech. We will continue.
Well, there will be direct flights from here to Brisbane, apparently. Did you hear that? No? Direct flights.
I promise. Господа, just announcement. В Брисбене будет конгресс.
In Brisbane there will be a congress like in Tokyo. It's better than Austria, so we should all go to Brisbane because our colleague, my former student, works there. So we should go to Brisbane.
18th to the 21st of April 2027. And furthermore, as always, we will have a National Society hall where you can organize a meeting of your own society. So, Russia, whoever wants.
Just I
Thank
translate.
you.
Значит, Brisbane.
In Brisbane, as in Japan, there is an opportunity to conduct national symposiums. And this year we made a symposium together with the Russian Federation, and so many people came here throughout the world, Japanese people, and Professor Korsak was the manager there.
You're all invited.
Yes. Вы все приглашены.
You are all invited. And the government bought us a plane for that purpose. Now we're going to have a group photo. So the photographer will be on the podium, and participants will be in the audience.
Первый ряд будет сидеть, сейчас еще наши
Готовы? Раз, два, три, фоткаю. Все смотрим. Смотрим. Раз, два, три. Сейчас, секунду. Отлично, улыбаемся. Не моргаем. Раз, два, три. Все, есть. Отлично. И видео давайте. Сейчас я видео. Не, погодите. А что они будут говорить? Да. На счет 3. Раз, два, три, махаем. Отлично. Еще раз. Всем внимание, пожалуйста. Смотрим на камеру хорошо. Раз, два, три, машем. Поехали. И еще раз. Машем, машем. Отлично было. Не отходите, пожалуйста, сзади.
Подождите, пожалуйста, все остаются на местах. Еще один кадр. Еще один кадр.
Еще один раз. 1, 2, 3.
Президент государства, сделайте сейчас всех. Лет. Владислав.